Sure, sure. Check. ಬರ್ತಿದೆ. Sure. Hey. Sure. ರಾಲ್ಫ್ ಅವನ ಹೆಸರು ಹಾಕಿಟ್ಟಿದ್ದಾನೆ. ರೆಡಿ ಇದೆಯಾ ಮಾತಾಡ್ಬೋದಾ? Hi Ralph, is it okay? Obviously okay, no? Yeah. So I can make some announcements now that I have mic. So food is ready. Please start having food. By 12:30 you come and sit here. All the staff here. Food is here. Kishan, take them and let them have food. Yeah.
Pradeep, okay? Podium. Pradeep. Pradeep, can you check on the main laptop on the podium?
Every time.
No, it's not. Okay. Audio.
Headphones.
Echo. So she will tell us once the tenting sets in. So this is unlike BMV, we don't change view here, everything under.
Doctor? Dr. Ranjan? I'm just playing.
Hi everyone. So this is a 66-year-old patient who's come with AF, which is persistent, heart rate reasonably controlled, but she's on anticoagulation. She had multiple episodes of bleeding epistaxis. So we are planning and multiple ecchymotic patches. So we are planning a closure for her. So now what you see is the femoral venous puncture is done, only a venous puncture, and it is done under ultrasound guidance. Okay. There's also arterial sheath.
Yeah.
It will stop.
Yeah.
Now what I want to
You just talk like
yeah,
you talk and
stop and talk.
yeah,
Huh? Yeah, we can do that.
you can space bar.
For this patient because okay, this is good. My face also will come on this one as a speaker.
That also can come.
Come side.
Yeah.
This side you. And
Camera. Camera team. Where's the camera team?
so in and these people who are speaking there
Yes.
constant. So we plan here. There also. Yeah. Not possible. Those two are same.
Speaker only will become.
Both the
But if you want,
we did a not on. Now it is on. Yeah. Noor, did you have food? Okay. Camera here. Put that and see. Yeah. Coronary angio, which shows minor disease for her. And patient is on DexMed, not intubated. Hello? Yeah, yeah, that's good. That's good. Perfect. So let's.
sure.
check. Hey, check, check, check. One. Hey, hey, check, check, check. Hey, hey.
Check, check. Good afternoon, everyone. It is a moment of extreme pleasure to welcome each one of you present here. It is so wonderful to see you all. I'm delighted to welcome you all to the first Left Atrial Appendage Closure Summit in India 2024, organized by Dr. Ranjan Shetty and Manipal Hospital.
Good afternoon, all. I now call Dr. Professor Ranjan Shetty, sir, to come up on the stage, the Program Director for Left Atrial Appendage Closure, and Dr. Ramesh Dagubati, sir, to come up on the stage and start the function.
No, good afternoon, everyone. This is great pleasure to be with all of you today. We know there are several conferences in India, and obviously almost every week or every day, right, Dr. Hazra? We have webinars and on top of that in-person meetings. But for the quite a few years, I actually was talking to most of our leaders in India to say that we need to have a focused meeting on left atrial appendage closure. So then I had the opportunity. We've been great friends for several years. We're both alumni from Manipal, and much later on, much younger than me, I met Dr. Ranjan Shetty, and we shared this idea of actually having to establish a left atrial appendage program in India. It is important to educate ourselves and educate all our referring physicians. And so I think this is a great start as a first left atrial appendage closure summit. I want to thank all of you to be for partaking in this program and for being here. And I think that we can definitely exchange our ideas and see where the barriers are. Why is this a particular therapy not growing as much as it should? And we'll share how this is projected in other countries in the next in the session. But thanks for being here today, and I'm hoping that all the other people who are having lunch, they will join us soon, and then we will start quickly. And now, Dr. Ranjan.
Thank you, Dr. Ramesh. It's actually been wonderful. We have been discussing it for some time, as Dr. Ramesh told you. We are happy that it's finally materializing, and it's good to see such a good crowd. So it's a new therapy, or so-called new therapy, although it's been for long. Obviously, over the course of, since it is just one structure, I'm sure there will be a lot more discussion about each of the part of this structure. So what we want from all of you is to join and have your own questions, understand. Feel free to communicate with all the experts here, raise your doubts, whatever it may be, because that's something which is going on in others' mind too. So there's no wrong question, there's no bad question. So make sure you ask all of them. Also go through the schedule, because sometimes that questions are asked in the next talk. So just go through the schedule. If there is a talk on that, we could discuss. We are also planning to have lot more discussion with each session. It's not going to be just running around. We do have 5 live in box cases which are recorded. So we will go through it one by one. So without, I think, further delay, we'll start off the conference. But let's make it very interactive. Thank you. Yeah, start the session.
So we will start with the first session. I would like to call upon the moderator for the first session, Dr. P.K. Hazra, sir, Senior Consultant, Intervention Cardiologist, Kolkata. I request the chairpersons for this session to also come on the stage. Dr. Deepak Padmanabhan, Senior Intervention Cardiologist and Electrophysiologist, Bangalore. Dr. Neeraj Avasti, a Pediatric Cardiologist, Delhi. And Dr. G.G. Shetty, Intervention Cardiologist, Bangalore. I request all of you to take the chairs on the stage, sir. I would also like to call the panelist for this session, Dr. Anil S.R. Sir, Senior Pediatric Cardiologist, Kerala. I request the moderator, Dr. P.K. Hazra Sir, to now introduce the first speaker for the first session, Dr. Professor Ranjan Shetty Sir.
And good afternoon. Good afternoon, Bangalore and Manipal Group of Hospital, my friends, my colleagues. It's a new beginning, but it's a great beginning. And we have none other than Dr. Ranjan Shetty, who is my mentor, who taught me LA Closer. And things are getting now more attractive for many people who are not able to do a TAVR in your hospitals because of the cost and still want to do some structural cases, want to highlight them or align them into structural case summit, present their cases. So best and easiest way to present or be in the structural heart group is to start with LA closure device. ASD, VSD, PDA, those things are pediatric cardiologists, but some adult cardiologists are also doing this kind of work. So Dr. Ranjan will tell us the journey of LA closer in India. Over to you, sir.
Yes. Thank you, everyone. Good afternoon. So, the whole conference is about journey. It's not just this talk. So I'm going to make it very short and very quick. So as we know, this, although atrial fibrillation is extremely common, and there are a lot of patients who cannot or will not take anticoagulation. So as physicians, as doctors, most of the time we end up under treating them. We don't give them anything or think aspirin is enough or a dual antiplatelet is enough. Since the awareness itself is less in the country, the uptake of this therapy has been much lesser in India compared to the world over. Dr. Ramesh will next talk about the world over. Dr. Horst Sievert will give more about evidence and tips and tricks on this. So I'm here to just share the short journey of this. We do have our surgeon who is going to talk about the appendage itself because that's the organ of debate today. All of us know about AF. It's extremely common. When it leads to stroke, we understand that it leads to stroke, but the opposite becomes very difficult. The very AF which you are seeing in OPD today could be the culprit of stroke, becomes difficult for people to understand because it doesn't happen that day. It's a cumulative risk, so people forget it. Although we do give, there are anticoagulations which are available, but most people don't end up taking it. Drugs like statin also, when you follow up people for around 5 years, 50% stop. So when you are actually talking about some, drugs like this, there's more fear both in physician and patient. I wouldn't say it's just the patient fear. As doctors, when the bleed occurs, we think that we are responsible. When stroke occurs, we think AF is responsible. So this itself leads to under treatment and under representation. We're also worried that some other colleague might end up saying, because of that drug, the patient bled. So, there is real fear which comes. I'm not going to go through these trials now. I'm going to just talk about journey, but all I want to say is there are trials, there are randomized trial. I know that the evidence right now is 2B, but if you look at the trial, there are trials which have come after those 2B, which probably Dr. Host will cover in his talk, and we could have discussion at the end. The first case, when we say it is a new therapy or it's just began, probably it is not true. Dr. Ramesh will tell you about world over when it started. It started way back in 90s, so it's around 3 decades old. Even in India, the first case was in 2012 as a part of a conference which was done, but it has its ups and downs. We started it in 2014, so it's been 1 decade since we started in KMC Manipal, and this was the case which with Dr. Hazra, which we were discussing. Lot of we had done one conference. This is the first publication which we did. Our first 10 cases. There is no publication after that. So I feel this is the forum where at end of it we need to sit and discuss how do we take the whole thing forward. The first watchman was done in 2017, and lot of workshop, lot of place is been traveled. This is a rough number across the country, up to now. Which are the states which have done cases. So if you see it's spread across, it's very sporadic, there's no wave here, it's just happening. In some places we need a wave, without wave no therapy can take up. We need people like you who are convinced. uh, this is again year on year. Initial year it was very less. 2022 and 23 had a good number, but that also could be because of the post COVID catch up, because hardly anything happened in COVID years. And this was in 23 data of different industry. Now, almost surely this data is correct, because there are only few companies which do it, but overall the numbers are minuscule. It is small. So what I'm trying to tell here is what we have achieved till now is actually nothing. It's too small, but today is encouraging. When we see so many people attending the conference here, the interest which we had actually 400 registration. We had to actually decline people in the last couple of days because it was not possible to manage the logistic. So the interest, this is what is interesting, and we think we could take it forward. And the way forward, I was hoping that at end of this we go stepwise, we learn the step, we have lot of interaction, we have discussion. We also try to make a registry. Me and Dr. Ramesh, when we were discussing, we want it to be a yearly event. So when we come next year, whichever month we come, we hope that there is more data from us. We could have a registry and we could present those registry data, and that's what is more exciting. So, although it is, I'm happy that a lot of people are interested in this. And as Indian cardiologists, the skill is already there. Because, a lot of people do balloon mitral valvotomy by just closing their eyes. They don't even use imaging. A lot of people do ASD also. You realize this is just a combination of two done more systematically. And we'll be showing some recorded live cases which are actually unedited. All 5 cases which I'm going to show and Dr. Ramesh is going to show are unedited. Most of them are over in 17 to 20 minutes, just plain unedited. So we'll go through all that, and we'll be happy to interact. Please interact more. I don't see any mics kept there. We'll make sure some mics are also kept for interaction. Thank you. And I welcome Dr. Ramesh. I think we'll take the questions later.
Right. So it's a great thing, great initiative. And most of my juniors, they asked me, you have not gone to US, you have not gone to France, you have not gone to Switzerland, you have not gone to Germany. How you have learned the LA closer, TAVR, his bundle pacing, etc. It was Horst Stewart's, CSI Frankfurt. There's a site, TCTMD's site. From there, I started watching ASD, VSD, sinus venosa, LA closer. Then one day, Dr. Barney Meyer, he is the person who did angioplasty second time, third time, fourth time, fifth time on a person who has got his angioplasty done by Grunzig. So subsequent angioplasty was done by Barney Meyer. So Ranjan, myself, there are 5 cases one day we could collect. And first case, Ranjan taught me. Second case, Barney Meyer was excited. You have invited me. Why you are not inviting me inside the lab? I said, there's a much more difficult case for you. And the simple case is done by Ranjan and myself. So what is there is difficulty doing LA closer? What you are doing inside? So this is the T machine. What the T machine is doing here in LA closer? Remove this T machine. I don't want any T machines. Ranjan, you remember? So he did the puncture. Give me the LA closer device. Sir, how much? Give me 22 or something like that. So don't you measure the LA, this thing was 10 millimeter? No, no, no. Do you measure the stent diameter in proximal LED? Was it 3.5 or 4 millimeter? So I don't measure. So that's how become very, I mean, for me, it was that easy those days, but things can go wrong. So go through the training, and we have Ramesh and Ranjan to correct any steps you have gone wrong. Any comment from my panelists? Otherwise, we'll invite the second speaker. Okay,
This is
please.
Dr. Bernie Mayer, his photo.
Oh, yeah.
Yeah,
Yes.
this was the
Yeah.
workshop.
Okay. Thank you. Can I get the program over here so that I can see? I think next speaker is Ramesh.
Yes.
Would you invite Ramesh Raghuvati and introduce
Yes.
Ranjan?
Yeah, he's here.
We now call upon Dr. Ramesh Dagubati sir to give the second talk. He is the Director of Structural Heart Disease, West Virginia University, USA. Sir is skilled in all aspects of intervention cardiology. He has proctored many physicians across the world. We are honored to have you as a part of this conference, sir. Over to you, sir.
Both, I don't know where. Can you bring up my slides, please? Okay, so thank you very much again. So we'll try to skip some of these because there may be repetition. And I think we all know atrial fibrillation is a risk factor for strokes, and obviously the slow flow in left atrial appendage or left atrium itself can cause strokes. And when you think about where does the strokes commonly happen, in valvular atrial fibrillation, it is in the entire part of the left atrium. But still, 57% of the patients will the left atrial, in valvular atrial fibrillation will have clot in the left atrial appendage. Compared to that, in non-valvular atrial fibrillation, that's why this left atrial appendage closure is indicated in non-valvular atrial fibrillation, because 90% of them happen to be in the left atrial appendage. So oral anticoagulation is an alternate therapy, but John Madden was the first one who did left atrial appendage ligation in 2 rheumatic heart disease patients in 1949 because of those 2 patients failed oral anticoagulation and kept forming clots in the left atrium. And so, as I mentioned, 57% in rheumatic heart disease or valvular atrial fibrillation will still be in the left atrial appendage, and 91% in the non-valvular atrial fibrillation is in the LAA. That doesn't mean that valvular atrial fibrillation doesn't have a risk of strokes. So there will be several devices that are approved, and we'll look at them gradually. But in the United States right now, there are only 2 devices that are FDA approved based on randomized clinical trials. One is Watchman, the other one is Amulet. And but Lambre is also available for larger left atrial appendages on a special 501(k) clearance, which we have to make a special case with each and every patient to the FDA. Even though oral anticoagulation is possible, several of these patients are not receiving oral anticoagulation therapy at all. So there is a gap that remains in these people with the left atrial fibrillation who are eligible but not getting the therapy. That is one thing. And that's why we are trying to make a point to you. When you look at your atrial fibrillation patient, how many of them have been consistently taking the therapy that you have offered them? Whether it is warfarin or whether it is DOAC, how frequently are they taking it? Are they taking it just for 1 month and stopping it? Then it is ineffective. Then you're not actually providing them the best protection that they should get. So, because of that, initially that in 2009, that Plato trial actually showed that it is feasible to do left atrial appendage with the catheter-based therapy. So surgeons are actually on the top. Now there's a Laos 1 study has been done long time ago. Laos 3 study was published in last ACC, and left atrial appendage occlusion with surgical ligation. And so that actually has been shown to be superior to not doing it at the concomitant procedure. So if they're doing bypass surgery, it is better for them to now to ligate the left atrial appendage, and that has reduced the strokes. So that has come with strong evidence. And then since 2011, we started again looking at endoscopic trials in 2005 onwards, but it got approval of FDA approval is only to 2015, where after having Protect AF and the Prevail studies, these two studies led for the approval of first Watchman device in the United States, and then Amulet IDE. So I'll skip these slides. As you see that there are several devices that are available. We'll go over that in the next few lectures. Okay, so this is one of my patients where initially we started with the TEE, had obviously TAVR, and then we are doing left atrial appendage occlusion. So this also has been studied. People with aortic stenosis and atrial fibrillation, should we do just one therapy or two therapies? The burden in the United States is actually cost. If you get paid for the maximum amount is paid for the TAVR, so then you have to do it left atrial appendage as free. So this patient had both of them in the same setting, but that's not the usual one. We try to stage them and do it so that the hospital doesn't lose money as well. So, and Watchman procedures have now become, or left atrial appendage occlusion procedures have now become very simple. And as we know that from Pinnacle Flex studies that in 96% DOAC could be discontinued after 45 days. There's increased safety and efficacy in these patients, and procedural success is 100% or 98% success rate in these patients as well. So I'll skip these slides. Let me show you what is the so there's even with the Pinnacle Flex with Watchman or Amulet IDE, initially showed slightly higher rates of pericardial effusions, but the recent study which looked at the Emerge in 4,000 patients with the Amulet showed the same sort of efficacy and safety. 0.5% ischemic strokes, all-cause death was 0%. Maybe with Emerge, I think it was 0.2% pericardial effusions, and very rarely device embolizations. I think it's maybe 1 in thousands in our practice, at least in the United States. So I'll skip these and I'll show you. Sorry, can you go back? Okay. Yeah. So traditionally we do the device. We give them short-term anticoagulation with warfarin or DOACs for 45 days. And after 45 days, we check actually with a TEE or a CT scan. They make sure there's no device-related thrombosis, and then we can stop them and continue aspirin and clopidogrel for 6 months, and then stop clopidogrel and continue just aspirin alone. So let's look at what is expected in the world. This is 2024, and this data is about 2 years old, and this is up to 2032. So in overall, globally, they're expecting 12.5% increase in endoscopic or epicardial left atrial appendage closures. So market value of that is like really for $1.4 billion in 2022. It's going to go triple to 4.5 billion in 2032. I think it's still, there's a huge growth that is going to happen in these patients. And about 40% of that will come from the United States. And in the United States alone, there'll be an increase of about 20% from 2022 to 2030. And most of it will be endocardial in the light blue color. But still, there are so many devices like AtriCure Clip and other devices are coming in, and for epicardial devices as well. So that's going to happen as well in the future. At our center, we actually can offer even robotic left atrial appendage ligation along with the Cox maze or therapies that sometimes they do concomitant surgeries, and or actually just for those patients who have a recurrent atrial fibrillation, that is an alternate to catheter-based ablation and ligation. So globally, if you look at this slide, which is actually the reason that we want you to be aware of it, in that light blue color is Asia Pacific. So ignore whatever, I mean, don't ignore, but at least even if you don't want to think that the dark blue in the United States and Horst Siever's place, Europe is actually in the green, is also going up. So we both come from this region, and which probably 67 or 70% of them are in these two regions. But look at the light blue color where there is from Asia Pacific, that means China and India, there's going to be a huge increase. I think this is like in 10 years, there will be maybe 10 times the population that will receive left atrial appendage closures. So I think with your help, that could be achieved. And in MENA, Middle East, North Africa, that actually in the darker blue is going to be a little less. Okay. So the growth that we wanted to show is, state by state. Actually, Dr. Ranjan Shetty showed how it is in India, but here, let me show you in our center or in the United States, including our center, the growth has been this curve. We started in 2016 when it was approved in 2015. Our program started in 2016, and we had one structural interventionalist. Then we added a second one. The two of us were doing about maybe 30 in a year. Now, actually, we don't have time. We added 4 structural interventionalists, totally 4, and we do them actually almost 6 to 8 in a day, 6 to 8 in a week, because we can't actually afford other room availability of staff and rooms. So, but we could do more. So there are some limitations, and if you want to do transesophageal echo, that needs an anesthesia and all of that setup. So we shifted to intracardiac echo guided left atrial appendages. Out of 4, 3 of us are comfortable in doing that. So this is what we need to see. Number of physicians that are training in left atrial appendage closures are also is on the rise. And we train all our fellows that qualify from interventional fellowship in our program. They are certified to be implanters of left atrial appendage occluders. So I think with that, I'll stop here and we'll take, there are several challenges that will still remain. And that's what we are going to learn in this session is how to improve efficacy, how to prevent device leaks, how to mitigate device-related thrombosis, and how to optimize the overall procedure. And so that is with the segue. This is going to be the segue for the future sessions and in the day we have this wonderful program. With that, I'll stop here and I'm happy to take any questions. Thank you.
I think we'll take up some questions and comments at the end of the session. And Ramesh, you can join us here. I think, guidelines is a kind of draconian restriction sometimes. The regulatory authorities sometimes are draconian in the sense you can do this, cannot do this in this kind of situations. But I feel certain devices have their democratic choices. And I heard one of the lecture of Dr. Hart Sievert, LA for all, he was debating. So we'll move from the journey of India to journey of world, the journey of evidence-based medicine and the guideline. Horst does not need any introduction here, so may I invite sir to deliver his talk.
We now have Dr. Horst Sievert, sir, to talk in the next session. He is the Director, Cardiovascular Center, Frankfurt, Germany. Sir is like the jewel in the crown in the field of LAA closure procedure and various other cardiac interventions. Sir's enthusiasm for intervention cardiology has been tremendous and has been inspiring. All of us here are eagerly waiting to listen to your session, sir.
Thank you very much to the organizers for inviting me. It's really a pleasure to be back in Bangalore. I have been here some years ago. So welcome India, welcome Bangalore. Updated evidence of LAA closure. So you know that atrial fibrillation is very frequent. And these are old data from the Framingham study, but it's age dependent. So if the patients are older than, the humans are older than 70 years or 80 years, the incidence of atrial fibrillation is about 5 to 10%. And atrial fibrillation is a frequent cause of stroke, especially in the elderly. And those who are older than 80 years, 30% of all strokes are caused by atrial fibrillation. So it's a very important disease. Atrial fibrillation causes big clots, and big clots cause big strokes. And for that reason, the mortality of strokes caused by atrial fibrillation is 2 times higher than the mortality of strokes caused by other causes. AFib patients are at a very high risk of embolic stroke, and you can calculate this from the CHAS-VAS score. So for example, if your CHAS-VAS score is about 3, then your stroke rate in 10 years is 32%. As you all know, anticoagulation is effective. These are all data with warfarin, and you can see that the stroke risk reduction by anticoagulation with warfarin is about 70%. So anticoagulation is effective. However, in daily practice, it is often difficult, even with NOACs. And that is because many patients are just not good candidates for a lifelong anticoagulation. And when I give this lecture for referring doctors in Germany or Europe, I very often ask how many of your patients with atrial fibrillation are anticoagulated. And then they say, oh, it's about 90%, 95%, 99%. And then I say, okay, congratulations, because you are much better than what the data tells us. And you have seen these slides. These are data from the US, and Europe is the same. Only about 50% of all patients who could take or should take anticoagulation because of atrial fibrillation are actually taking it. And NOACs did not make a relevant difference. You can see the percentage of patients who are anticoagulated did not change with the invention of NOACs. And also those patients who initially can take or are taking anticoagulation, they stop it over time for various reasons, because of side effects, or they just don't want to continue. And you can see that after 6 years, only about 20% of the patients are still taking anticoagulation. And the discontinuation rates with NOACs is exactly the same as with warfarin. So these are data from the randomized trials. You can see that after 2 years, the stopping rate was between 20 and 30% in all these trials for warfarin and for NOACs. And for those that remain adherent, bleeding risk persists. And these are the annual major bleeding rates with all the NOACs. And you can see it's not really different from warfarin. So you have about a bleeding risk per year between 2 and 3%. This is a typical LAA clot, and I would like to ask you, how often have you seen a clot outside of the left atrial appendage in patients with lone atrial fibrillation? And you will agree it's very rare. When I started doing this procedure, I like to show this slide from Blackshear back in 1996. And I was telling the people, well, about 90% of the clot form in the left atrial appendage, so it makes sense to close it. But we have looked into the current data, and you can see that actually 99% of all left heart clots could be prevented by LAA closure. So LAA closure is a causal therapy instead of a symptomatic therapy. It's a local therapy instead of a systemic therapy. And that is something we always want to achieve in medicine. It is a one-time procedure, is independent from patient compliance. There are no late complications, and remains effective in high age. This was the first successful LAA closure back in 2001, a 72-year-old patient. He had multiple contraindications for anticoagulation. The annual stroke risk, the annual calculated stroke risk in this patient was 5.9% per year, and the annual bleeding risk was more than 9% per year. We did 19 years follow-up in this patient, no stroke, no TIA, no bleeding, and he celebrated his 91st birthday in January 2020 and then passed away in April 2020, not due to COVID, but due to pneumonia. For me, back in 2001, this was enough evidence. So it makes common sense, it's feasible, we should do it, we should close all appendages in these 5 million people in Europe who have atrial fibrillation. It did not go like that. This was the first occluder we had, the plateau occluder. These are the devices which are now approved in Europe. So, okay, LAA closure does make sense and it is feasible, but the community wanted to have more evidence. And then we did all these trials. These are only those trials with the Watchman device. And what is important here, all these studies had been positive. There was no one single study with a negative result, LAA closure comparing to anticoagulation. Okay, LAA closure does make sense and is feasible, and there are some studies, as you have seen. However, where are the randomized studies? And most of you know this PROTECT AF trial. It was the first trial we did. It was a non-inferiority trial with 707 patients randomized. LAA closure was non-inferior as anticipated to anticoagulation with warfarin, and you can actually see that the device patients did better than the control patients. During long-term follow-up, PROTECT AF exceeded all expectations. This is the 5-year follow-up of the PROTECT AF trial, and you can see that there was a significant advantage of LAA closure regarding the primary efficacy endpoint. There was also a significant advantage regarding all cause of stroke and regarding cardiovascular or unexplained death. So that means if you close the appendage in a patient with AFib, compared to anticoagulation, you are actually improving prognosis regarding life expectancy. These are the combined PROTECT PREVAIL meta-analysis data, and they showed that LAA closure was as effective as warfarin regarding stroke prevention. Slightly more ischemic strokes, but less hemorrhagic strokes, less follow-up bleedings, and overall a significant reduction in cardiovascular mortality. There are no late complications of LAA closure. However, patients who continue with anticoagulation obviously continue to bleed. They have an annual bleeding risk of 2 to 3% of major bleeding complications. And today, LAA closure is much more reliable and safer than in randomized trials. These are more recent trials. You can see that the implant success in the initial phase of the PROTECT AF trial was 90%, and now it's 99%. And also the complications decreased. Initial complication in the first phase of the PROTECT AF trial was almost 10%, and it's now less than 1%. LA closure has long-term benefits, but it also has procedural risk, of course. So how long does it take until your patient has a benefit from LAA closure? As I showed you, according to the PROTECT AF trial, there's a significant benefit regarding stroke prevention and mortality after only 4 years. But there is not only mortality, there's also the so-called net clinical benefit, because you have more advantages, not only prolonging life, but also less bleeding complications, less stroke, and so on. And you can see that regarding how you look at it, the net benefit, clinical benefit crosses the 0 line either after 3 months or after 9 months, depending upon the data you're looking at. Also, LAA closure is cost effective, and you can see that the lines cross the line of LAA closure with warfarin and NOACs after 5 or 4 or 9 years. This obviously depends upon the system you're working in. As you know, the physician salary in the US is much higher than in Germany. Also, the salary for physicians in India is higher than those in Germany. Then depends on where you cross the line. When you compare the results of LAA closure with NOACs? Well, we know that NOACs are better than warfarin, but LAA closure is also better than warfarin. It all depends upon the time. The longer the follow-up and the life expectancy, the better LAA closure will be. Time is always working for LAA closure. Now we have some data comparing LAA closure with NOACs, and this is the Prague 17 study. 415 patients had been randomized. So these had been patients who could take both. They could take anticoagulation and they could undergo LAA closure. Watchman or Amulet was used in this trial. Primary endpoint was a composite endpoint of stroke or TIA, systemic embolism, significant bleeding, cardiovascular death, or significant procedural device-related complications. And it was again like the PROTECT AF trial, a non-inferiority trial. You can see now the 4-year outcome. LAA closure remains non-inferior, not superior yet, but non-inferior to NOACs for preventing major cardiovascular bleeding events. Non-procedural bleeding was significantly reduced with LAA, and most importantly, the curves continued to divert because patients on NOAC continued to bleed. There's another not randomized trial, but very carefully designed propensity score match study, the Danish trial, with more than 1,000 patients in each arm. And when you look at the results here, you can see that ischemic stroke, major bleeding, or mortality was significantly reduced when you undergo LAA closure. Also significant improvement in major bleeding, in all-cause mortality, and in cardiovascular mortality. This is another propensity score match study in patients with prior ischemic stroke, and you can see again the big advantage of LAA closure compared to anticoagulation. Now, what's about LAA closure in addition to anticoagulation? Well, there's the last 3 study. That is a study in more than 4,000 patients who underwent cardiac surgery for any other indication. They were randomized in a sham-controlled fashion to additional LAA closure during surgery or no additional LAA closure, and all patients continued with anticoagulation according to guidelines. And this study showed a significant advantage of LAA closure in addition to anticoagulation. That is really changing the field a lot because all other studies were comparing LAA closure with anticoagulation. That's why you're now conducting the LAOS 4 trial, where we use the endovascular closure of LAA closure in addition to anticoagulation, and maybe in the future we combine LAA closure and anticoagulation. LAA closure is in almost all guidelines. These are the European guidelines from 2020. It's a 2B recommendation. These are the American guidelines from 21. Again, a 2B indication. And these are the 23 guidelines. So it's a 2A recommendation in those patients who are contraindicated to anticoagulation and 2B in those who can take anticoagulation. Also, the FDA says that LAA closure may be considered in patients who are suitable for warfarin, but have an appropriate reason to seek a non-drug alternative to warfarin. So these are basically all patients. Also, the recent consensus statement recommends LAA closure in patients who cannot take anticoagulation. So in whom should we close the LAA appendage? For sure in those who cannot take anticoagulation. That is in all these patients who are not currently taking anticoagulation. These are candidates for LAA closure, and also in those patients who initially could take it but then stop it for any reason because of side effects or because they don't want to continue. So the majority of patients actually are candidates for LAA closure. So in summary, my take-home message, atrial appendage occlusion is established and guideline compliant in patients who cannot take anticoagulation. Several new studies have increased the evidence for LAA closure for stroke prevention in patients who can tolerate anticoagulation. And in the future, we may combine atrial appendage occlusion with individually adapted anticoagulation. Thank you very much for your attention.
Thank you. Thank you, Horst. Can you join us here so that we can go to the live inbox, please, sir? I think, as I mentioned, it is a kind of democratic choice for certain group of people, like contact sports or any person who is engaged in kind of sports or activities where the trauma is. Anand, please join us. Please. Is involved in trauma and can cause bleeding inside, whether it's a brain or major organs. He has a democratic choice to choose LA closures. So guideline says one thing, and in real life maybe a different thing. So Horst, how much is the gap of the guideline versus real world expectation from a patient? What patient wants, the guideline or a device?
Well, the patients want to have the device. Unfortunately, the reimbursement situation in Germany is actually worse than the US now. So we have more difficulties to get reimbursement for this procedure, but most patients decide for the LAA closure.
Right. Anand?
It's a wonderful meeting. I think for the first edition of the summit, the hall is already full. So congratulations to Ranjan and Ramesh. To comment on a question, I think as you were saying, the numbers for us is low. It's not that we don't have AF, it's not that we don't have strokes. But whenever I speak to Ramesh or any colleagues in US, they don't have enough operators to do the procedures. It's the other way around. The numbers are huge and you don't have enough operators. Is that because you're doing too many, like even those cases where the patients are not contraindicated, but it's a patient preference? Or is it as it is in the guidelines, like?
So in the, excuse me, very good question. In the US, we truly have to follow the guidelines because insurance will not pay. If the insurance doesn't pay, either the patient has to pay or the hospital has to eat the cost. If the hospital eats the cost, then the next time then I ask for a salary hike, they will not increase my salary. So we have to be very careful. So, I mean, jokes apart, that actually the burden will fall onto the patient if the insurance doesn't pay. So we are very careful. We make sure that the patient qualifies for all the data and for all the guideline recommended things. And then we actually have to send it for insurance approval. Once it gets approved, only then we will actually implant these devices. But anticoagulation, whether it is apixaban or rivaroxaban, for our patients in the United States, patients will pay out of pocket $400 per month. So it's not cheap. Compared to what you think that okay, the device is going to one-time cost, but whereas they have to be taking this 6 years or 10 years, however long they're alive. Just imagine that they're spending about 5,000 out of pocket. Who wants to spend 5,000, including myself? I probably will not raise my hand if I have another alternative that can get rid of my cost, right? So as long as it is safe and it is efficacious and it has been shown to be both. So we do not, and we made a couple of mistakes by, it has to be a shared approach, shared decision making. That means if I'm implanting, I cannot refer the patient to myself. You can refer the patient, electrophysiologist can refer the patient, primary care providers can refer the patients to me to implant, and they have to actually fill up a form that has to be done for the government, and then that's called a NICE form that they do it, and then we have to document that the patient, as a host has shown, FDA approved Watchman only for those patients who are eligible candidates for short-term anticoagulation. If they cannot take short-term anticoagulation, or if I don't document that piece, they denied it.
That's actually different to Europe. So a recommendation to give 45 days anticoagulation was initiated during the Protect AF trial. But before that in Europe, we always prescribed only aspirin or aspirin and Plavix. And now the IFU for Watchman in Europe has been changed. So we as doctors can decide whether that patient gets anticoagulation for this time period or not.
Sorry, there's a comment.
Excellent talk, Sivat, and I would like to drive that it's a simple and a local therapy which needs to be driven across to the cardiologist and the neurologist. But what is, we still are facing that challenge. We have a lot of patients with AF with high Chadwick score, but the number of those who are getting LA appendages are still low. So what percentage of patients do you get from, say, a neurologist, a EP person, a general physician, or once they had a stroke and a neurologist sees and they say, now, of course, what is the split?
We have the reimbursement problem. So the payers say a 2B recommendation does mean it's not necessary to do it because it can be considered. It may be considered, but it does not have to be done. So that means they refuse payment in almost all cases, unless we really can prove that that patient has an absolute permanent contraindication against anticoagulation. And they are fearing the cost. So they say, okay, patient had gastric bleeding, that's no problem. Just do gastrectomy and then patient can take anticoagulation. So they are very strict. They do not, I mean, they know that on the long term, LAA closure is cost effective. But when I talk to the leading people in the insurance, they say, you know, I'm judged after 1 year and not after 5 years. So I have to make good business after 1 year. So that's a very short, like politicians, right? So until the next election.
Right. So let me explain. One more comment. Yeah.
I'm Dr. Anil. I'm a pediatric cardiologist. So I'm the end user of the LA appendage. And I work in a hospital called LAAC Hospital where there are 8 adult cardiologists doing a lot of work. They do around 400 angioplasties a month. But the number of LA appendage closure I've done last year is just 4. So what is the message that I should be telling to my adult cardiologist to improve this referral?
So, I mean, I think the most important thing is to bring a therapy awareness to the physicians and including ourselves. I never did appendage closures until 2016 or 2019, and because there was somebody else doing it, and I didn't pay attention to it. Who's referring? What are they referring? So we need to make sure that the patients appropriately are being treated. If the patient is being appropriately treated, meaning they're following the recommendations and taking the appropriate dose of medications, just because in India we might sometimes think, okay, our patients can't handle the recommended doses by Americans. That's not true. You know, we have studied even in Indian populations as well that it is the same dose that is required for anticoagulation. So go back and see if they are actually taking the right dose of medications, then they can be maintained. If they don't have any risk factors such as bleeding, they can be maintained. if they can tolerate anticoagulation. If not, our referrals come from gastroenterologists, from neurosurgeons, neurologists, because they had hemorrhagic transformation of a previous embolic stroke, or GI bleeding is very common for us, and they are all sent to us by these two groups of referring physicians. So I think bringing awareness to them.
So the AF registry, having a good AF registry and follow-up of the patients would
Yeah, we can
improve
do
this
that.
thing.
Let me, time is very short. Let me put my thoughts here. You know, that there are certain therapies, like if you have a gene therapy, which can cure one shot and cure atrial fibrillations forever. That is the best therapy. As Horst has mentioned, this is one therapy, one time, lifetime therapy. It's a kind of new thinking, is a new philosophical thinking that you put a device. This man does not need oral anticoagulant. His surgery, trauma, neuro, brain surgery, appendix surgery, liver surgery, everything will be much easier to handle. Dr. Ranjan, are you ready? Ranjan, please come. So let me explain the non-inferiority or class 2B or 2A versus 1. You have two hotels. One is Marriott, another is Hyatt. Both are equally good, 1,200 rupees, $1,200, $1,000 stay, but I still prefer Marriott because it gives a good ambience, beautiful women, but Hyatt doesn't have so much of good ambient, no beautiful women. I'll still prefer Marriott because I could get to see good women over there. So that is non-inferior. Both are equal. What is superior? Marriott gives good food, good price, but if you go to Hyatt, you eat those foods, you will die because of food poisoning. That is superiority. So we don't have that kind of superiority data on LA closure, but it's non-inferior doesn't mean that many patients do not need LA closure. So you have to find out the right patient in the right time and right operator, right mentor, then the therapy will grow. Over to you, Ranjan,
Yes.
live in box.
Thank you, Dr. Hazara, Dr. Horst Sievert. It was amazing discussion. So we will be now going on with the live case in box because I think live case is not allowed. So almost all cardiology conferences at least have only case in box, but we know that many other departments are actually having live. So can this be played? Yeah. So this is a case, as I told, we have not edited it. We just started just to see the flow. I'll be able to stop it anywhere I want, and I'll be happy to discuss. And I think this probably will be followed by Dr. Horst's lecture after this, the next. So yeah. Hi everyone. So this is a 66-year-old patient who's come with AF, which is persistent, heart rate reasonably controlled, but she's on anticoagulation. She had multiple episodes of bleeding epistasis. So we are planning and multiple ecchymotic patches. So we are planning a LAAC closure for her. So now what you see is the femoral venous puncture is done, only a venous puncture, and it is done under ultrasound guidance. There's also arterial sheath for this patient because we did a coronary angio which shows minor disease for her. And patient is on Dexmat, not intubated. T probicin, Dr. Kavya is on the T, and Dr. Bharat is assisting me. So we already have the catheter which is in now, which is a SL1 catheter for septal puncture. We have imaged the LAA, which we'll discuss later, and we are now going for a septal puncture. So this is, the broken marrow needle. So this initial part is almost like the way we do BMV. I hope the images are getting recorded. For septal puncture, it's done in AP view, and we do under initial, this one is in bicable. So I'm just coming down. You can see in fluoro that bicable view, the catheter is seen. In AP, I'm going to get the catheter down and slowly, Dr. Kavya is on the echo, so she will tell us once the tenting sets in. So this is unlike BMV, we don't change view here, everything under AP. And if you see, the tenting is seen at the SVC. That's a bicable we are near SVC. So I'm going to get it still lower, and you can see the tenting little more lower down. So we're going to come down. Can we go to bicable again? Yeah, it's little close to aorta, so let me position it well. In bicable, we'll see that it is inferior. Yeah, this is, it's slightly, there's too much movement. This is the mid part of the septum, but very close to aorta. I'm going to turn it more back, back.
Ranjan, can you stop for a
And
while?
image it again.
Stop for a while, because this is the most important part.
Yes.
Because this is the moment where you get complications most of the time. And Indians are very good in BMBs, those who have done their DM in medical colleges, but little different. So I'll put my 1, 2, 3 points here. You know, the T probe, if you go below the T probe tip, usually it is almost inferior, almost. And on right side you have SBC, on your left side you have IVC. Now, if your regular needle cannot penetrate the septum, you have to increase the curvature, sometimes the cauterization, etc. But please do it under T so that you go inferior, so that the entry into the LA device, LA is much easier, half heparin, etc. 2, 3 points from you, then we'll move.
Yeah, no, I mean, absolutely. Sometimes we have to, I'll talk about that in my lecture as well. We need to give up what we have learned and relearn some new things. So, as you said, that probably you would have done this blindly on fluoro without TE guidance. But here, TE is important because you will spend, if your stick is not good, you sometimes have to re-stick, which happens very rarely in our situation because we try to make sure the first stick is very good. If you don't pay attention to it, you're wasting time. It'll add more time.
I fully agree with that. And also you need the TE anyway to rule out thrombus in the left atrial appendage. Otherwise you should not. I mean, it has been done, but when we see a thrombus in the appendage, we stop and bring the patient back after 2 or 3 months.
So just to add, I think, this is a combination of two procedures. So I think we should start with the septal puncture.
Right.
That's what the discussion is about. And we are going to have next session.
2 points from Anand.
Yeah.
Septal.
The transeptal punctures become vital for most of the structurals. So as Ramesh said, you forget about the fluoroscopy guided. You have to use transesophageal or ICE guided. The second thing is the site of the puncture and the trajectory. There is something called trajectory. You have to keep learning about it. The site of the puncture is fine. Inferior, posterior, most of the structurals you can do it. But the trajectory becomes very important because appendages are, all of them are not same. Every patient's appendage is different and every patient's ostium takeoff is different. So whenever you indent the transeptal needle, see in your TE or an ICE that you are directed towards your appendage ostium. Otherwise, you move it a little bit up, either anterior, posterior, inferior. Make sure your trajectory is towards the ostium of the appendage, so that whenever you take the device, it makes it easier. It's the same for your mitral procedure. It's same for everything. Apart from the site of the transeptal puncture, your trajectory is very important.
So it can be done under ICE or T, TMVR, MitraClip, Pascal, paravalvular leak, electrolyzer device, BMB. This is the first and most important thing. We'll explain it further. Over to you, sir. Please continue.
Yeah. Thank you. So I think, can I have a raise of hand? How many do TE guided septal puncture in the hall? How many people? Yeah, this is good. There's a sizable people who do it. We also have a TE simulator on top where Dr. Kavya and her team will explain how to image. And so for this procedure, we have to learn it. That's the first message. You cannot do it the way you are doing. And Dr. Ramesh couldn't have said it better. Sometimes it's unlearning. So for this, it has to be posterior inferior. Now, inferior, as everybody, you come near IVC. Posterior means you're going away from aorta. That's posterior. So once you come in bicaval and you tent the inferior part, you ask a echocardiographer to either make a biplane or show aortic view, and you have to go away from aorta. To go away from aorta, you have to clockwise your needle. As you clockwise, you realize you started with something like 3 o'clock or 4 o'clock. Sometime you may have to go to 8 o'clock or 9 o'clock. As you clockwise, you could see your needle actually slipping away. I hope, because we have 5 cases, I'm sure 1 or 2 will actually end up seeing it. It's in the mid part, in bicaval. So I'll come little more down. So you can see the needle moving down. So this is the tenting, which you have to see. So here you're just giving some pressure, but you're not actually pushing your needle in. It's all done in AP. You're not going LAO, you're not going lateral, and half the heparin is already given because it's all done under vision. This is a thrombotic case. Most BMV patients are younger. here they are not young. You realize that if you delay heparin, sometimes the wire itself thromboses when you are doing. So it's important to give good heparin before. Since it's only venous puncture, we close by figure of 8. So it really doesn't matter if you give extra heparin for this patient. I'm sure most electrophysiologists anyway do almost similar to for AF ablation, similar to this. Save that. Now let's go to aortic view and see how are we positioned. Yeah, we are away from aorta. So it's infero posterior, and I'm going to do a septal puncture. It's already in LA, and you know we can see the this one. So we are in LA, right, Kavya? Yeah, yeah. I'm going to move the catheter. Yeah, yeah. So here, yeah, there is lot of sec there. Yeah, and somehow the bronchus looks a little more closer to me. So I'm going to go to LA with the catheter. So we are in LA and we are removing both the dilator and this. So next step is to measure the pressure, LA pressure, and we are going to give some heparin. So in this case, we have already given the heparin. Connect the pressure, please. We have already given the heparin and around 3.5. But I see a lot of sex. I'm going to give 3,000 more heparin now. Can we have 3,000 more heparin and get the LA pressure? Wire with this one. Yeah. So can you trace the catheter? Yeah. The LA pressure is, I think the mean is around 10. It's, yeah, it's around, it's 14.6. The diastole is not coming. And also when you do echoes, in such case, it's more like a therapeutic echo. You know, when you do it in your OPD and you do echo, you're just going down, you're visualizing something and you're taking out. So it has to be two-person job. You can't be doing both anyway. It has to be one more person and they should be able to guide you. Again, we have one full session on that, which will be done by all the people who are expert in echo.
If you have entered through the PFO, what do you
Yes,
do?
yes.
Would you
So-
take PFO or go for another puncture?
Yeah. So ideally, the theoretical discussion is PFO has to be avoided, and you should go
Because it's a tunnel.
infero-posterior.
It's a tunnel. You
But
can get
there are ways you can circumvent because there are cases where you do PFO closure as well as a appendage closure. There are ways you can circumvent. One of the case which we are going to say, we had a very superior anterior ASD, which I'll be showing in as a third or fourth case. And even with that, we could close because now there are multiple type of sheaths which are available. Most of the time you would use a double curve sheath, but there are single curve. I would like to ask Dr. Horst, would he avoid PFO or would he use it if he goes through that? Yeah.
Actually, with some devices, like with the amulet device, it's feasible to go through the PFO. With other devices, Watchman, LifeTech, I prefer to do transeptal puncture.
Yeah. The other option is, as you know, Dr. Horst says, it's not just entering the left atrial appendage. It's about orienting your device right later. If your device it slants, you're going to have a peri-device leak. So infero-posterior is the best, especially for the first 10 cases which you're going to do. Go by the book, follow the same order. Later, you could do a lot of modification. So have some rules for first 10 cases. Later, you see what suits you. You can always change stuff. Well, because there's a slight leak, but it is good. So here, we want to make sure that the pressure is more than 10 so that it is easy. Yeah, pass the wire, pass the wire. So we have had a posterior inferior puncture. Now we want to do the exchanges in the pulmonary vein and we are going to keep it here. Okay, so I'm going
Next
to,
big
can
thing
you
is
make
the
the floor medium?
sizing.
Yeah,
CT,
sizing.
CT scan versus your T. Quickly, sizing.
Yes. So in this case, I think we'll come to that
Okay,
once the
okay.
imaging is done. So here we have decided to use the Lamre device. So one appendage will give different size for different devices. If you're doing a Watchman, numbers are completely different. If you're doing amulet, amulet and Lamre, the numbers will be almost the same. So the question is, are you going to be more neck oriented or are you going to be more body oriented? So let's stick to this device. And again, we have a symposium on each of them. You know, it's also important, I think, first 10 cases use one device and don't change the device. Once you have understood the appendage, once you have befriended the appendage, it's okay to experiment. Otherwise, respect it, stay away from it. Most exchanges you do in the pulmonary vein. I'm sure Dr. Horst doesn't agree with me because he does exchanges in appendage, but he can do it. But it's more important that initially, you make it very safe, because one complication and the program stops. You won't be able to do the next. So sizing, when it comes to this, if you see here, this is the circumflex, and this marks the neck of the appendage. So there are two axes, axis of the neck, axis of the body. Now you are trying to produce your device somewhere here. So you're going to measure this measurement in all views. You're going to do it in 0, you're going to do it in 45, you're going to do it at 90, and you're also going to do it 135, this number. So whatever number you get, typically these devices, whether it's lamprey or amulet, you upsize by 3 to 4 millimeter. And if it is symmetrical, if it is circular, you upsize it still more. If it is elliptical, just 3 to 4 upsize is enough. For these devices, too much upsize is not advisable, and they anyway have double mechanism. There's something to hold there. There is also a disc which covers, so they have double mechanism.
You're right.
And
So about
that's
sizing, there are two methods: CT scan versus T. But he's showing T. On the cath lab, you have on the T you have 0, 45, 90, 135. Your cath lab should look towards the scalp, that is 0 degree. If it looks towards your shoulder, right shoulder, is 45 degree on TE. If it looks to your liver, it is 90 degree on T. If it looks to your groin, the AI, image intensifier to the groin, it is 135 degree. So on your cath lab, on the T, whatever size, maximum size you get, the
upside.
os and tenimometer down. Go ahead.
Yeah. I'm going to keep the catheter in and then turn the catheter a little up, and we are in the pulmonary vein. Can you trace that? Trace the pulmonary vein. Bharat, can you hold it? Yeah. So I'm going to pass this. Yeah. Only this. I'm going to pass the wire in. Now we take the implantar wire. So we are already in pulmonary vein. So we'll take the implantar. Heparin given? Yeah. Total heparin is how much? 6,500. Yeah. Because we want a lot of sec. Now we're going to exchange this. So in this case, we decided to do lamprey. By this time, we can explain to you the LA appendage itself. So in the screen now, you can see the LA appendage. It's a little thin, long appendage, and we have seen it in different views. What are the views, Kavi? I think you'll have to show live once, all the views. The sheath is ready? Yeah. So 10 French sheath has to be ready. We have put a implantar wire. I prefer most of the exchanges to be done actually in pulmonary vein as much as possible, and we'll put the sheath ready. And the pigtail ready? Yeah. Come, the sheath is out.
You're right.
Now we are going
Just
to remove
just
this.
a minute. If the wire goes outside the heart, you know it is pulmonary vein. And if it is inside the heart, it still could be LA or appendage. But wherever the wire goes, please take it. Don't try to be puristic. Ideal way is to exchange, as mentioned, pulmonary vein, right up pulmonary vein, left upper pulmonary vein. But if the wire goes inside to your LA appendage, be a little bit careful, but you take it. Go ahead. Little faster.
Because the device we have chosen is lamprey, and lamprey actually comes with a 10 French sheath. So compared to other device, the sheath of lamprey is small. You can see the sheath here. We're going to put it. We'll also need an underwater seal after that, and a pigtail, and that long wires. This one there. This one. Yeah. So yeah. Perfect. Yes. You're holding now, Bharat? Yeah. So we're going to take the sheath in generally, because I've already put 11 French sheath in the groin. It's actually easy to take this sheath. So we're going to take it, and we're going to enter the pulmonary vein. So at this point, I'm going to push the sheath little in. I think Kavya will be able to see the sheath in the pulmonary vein. See, we are able to see, you can see it in the fluoro, and I'm going to remove this. It might bleed little. So at this point, we'll be a little careful. We have like a 2E which is ready, and I keep the wire because that helps us later to, yeah. So now come, we'll put the 2E, and you can actually profile the wire in the, next to the appendage. You can see the wire in the pulmonary vein, and then exchange is done. The pigtail also. Come, the 2E which is here.
No, I mean, I think the wire is very important, where the wire is. In the beginning stages, even though we can leave it in the left atrial appendage, but I would caution it, be careful. Left atrial appendage wall is very thin, like paper, and especially if you're dealing with elderly women, you can actually puncture just with the wire itself. So be careful, because this is a 2-man or 3-man team. You have to really trust the person who's holding the wire. He is really holding the wire and not letting it go through the left atrium, and that's why the complications could be higher. So we use what you call a jalebi wire, or we call it protract wire. The protract wire is very nice, and it'll be in the left atrium body. It doesn't go anywhere. You don't have to put it in. Maybe it's expensive. I'm not sure how much expense it is.
Yeah.
Just to comment where to place the wire. So I like to have the wire in the left atrial appendage, but it has to be a specific wire. We are using the Amplatz Extra Stiff with a 3 centimeter long tip and a J. If you use the Amplatz Extra Stiff with 7 centimeter long tip, it's much more difficult, and then actually there may be a risk of perforation. So this Amplatz Extra Stiff 3 centimeters behaves like a pigtail, and then it's very safe.
Which chamber is easier to perforate, right atrial appendage, left atrial appendage, or the free wall of the right atrium or left atrium?
I mean, perforation is difficult in any case to do, but I think it's easier to perforate the left atrial appendage, of course. That's why you have to be atraumatic. So either use a pigtail in order to advance the sheath, or use this particular wire I just mentioned.
I think, anyway, it's a controversial. Those who are doing double chamber, wireless pacemaker, Devinar, if history is around, it's very difficult to pierce, perforate appendage. It's a parchment, very thick membrane. It's very easy to perforate pulmonary vein and the free wall. That's a controversial thing. Go ahead, please.
We'll have a talk by our surgeon later. You could check with them whether it's but host, yeah.
Proceed.
And we're going to put a pigtail quickly. Yeah. And we're going to close this. We are going to close this. So we are already in pulmonary vein. The catheter is in. Let's put the pigtail through this. Yeah, pigtail is loaded, and let's keep the dye ready. So now what we want to do is we want to be in the pulmonary vein, slowly come down. I don't want to put the sheath in. The rule is ideally the sheath is the hardest thing. Device is hard. So the rule is that we want to take the only pigtail or a wire to lead. We don't want to just push the sheath into the appendage. And this is especially true if you are doing with this. So the pigtail is now already in. Now what we'll do is I'll keep the wire here. I'm going to ask for a RAO view. Yeah, slight RAO. Not cranial, not caudal, but just RAO view. And we are going to pull within RAO, we know where it is. I think 2000 more heparin, please. I see a lot of sec. And let's see. So I'm pulling the pigtail. I hope you are able to see the pigtail pull down and then pushing it up. So are we in appendage now? Or did we go back to pulmonary vein? Pulmonary vein, yeah, yeah. So I think this case, because the appendage is little smaller, sometimes it is difficult to enter the appendage. Where are we now? Vein, yeah, yeah, yeah. Okay, I think we are still in pulmonary vein. Okay, so I'm going to pull it further down, allow it to fall, yeah, and maybe manipulate it slightly and try to enter the, again, I think it's pulmonary vein, no? Now in appendage, yes. So you can see it in appendage and it has moved in. So this is the first step. We have a pigtail which is already in appendage. So, but are we sure it is in appendage? Can you, yeah, okay. Anyway, we are going to test and see. Okay, okay, we are in appendage. Can you give me the dye, little bit dye? Okay. I'm going to take the sheath in and let's see where we are. Normal,
Just a point. If you do not see any bright structure, the wire most probably in the pulmonary vein. If you see any bright structure, most likely you have entered the L appendage. Go ahead.
Without dye, but we'll have to see where we are. Yeah, so there's a beautiful appendage. Now we come to RAO caudal and we take an angio here. I'm going to take a cine Yeah.
Hand
See, look
injection.
at the shape of this appendage. It is thin, long
Just
appendage.
wait a minute.
And
So Hurst hand injection versus your any other method you do in your lab. Automatic injector, hand injector, or US they use
We have the AKIS system, so we use a AKIS system with 9 by 9, so 9 cc per second is 9 milliliters volume.
Okay, right.
not too deep. Patient, I think, requires a little more sedation, but we have all the information which we need. So our anesthetist, Dr. Karthik, will take care. So let's take the device where our maximum measurement has been 16, 15. So I'm going to take a 22 device and we are going to load it. Just take care of the patient for a minute. Yeah. We will give you the time. By the time we'll load the device, we'll keep it ready. Okay? So we will take a 22, 26 device. 22, 20, 22, 28, I think. Yeah. 22, 28 device or 20, 26. We'll take a 22, 28 device because there's a lot of space. I'm going to start little and then we'll. So when you do the angio here, you know that your device is likely to fall somewhere here.
Finish your comment.
Yeah. So device is likely to come here. So now lamprey comes in two sizes. One is the size of the disc itself, the actual device, and then there is a disc which covers. Now lamprey comes with extended disc. Some are like if you are inside, I'm going to probably be talking about it. If you are inside and if you are in a small lobe, and then if the neck is very small, you may have to take a bigger disc and cover the whole ostium. Something like this, which is like uniform, just going in. The tapering is much away. You would take a standard device, which would be like 22 plus 6 or plus 8 will be the size of the disc. Dr. Ramesh.
No, just quickly, I think if this is the RAO caudal view, probably this is RAO or, RAO caudal, right?
Yeah, RAO caudal, shallow
So
caudal.
this will be very challenging for a Watchman device of the transeptal puncture. The trajectory, as Anant was saying, that actually it's going much more. I think maybe the stick is a little bit more infra-posterior. I would have probably brought it a little bit inferior and slightly less posterior or mid. And so it's better to come from here and this direction with the double curve. That direction, you can implant it, but when you release it, it will not sit in the coaxiality will be lost, I think. Host, what do you think?
No, I agree. I think that was the main point I was making earlier on. In the initial stages, you get away with sort of infra-posterior. In the initial 10 cases, you adapt a safe, that is very important, safe procedure. You go to left upper pulmonary vein, put the wire, get the pigtail, drop it, then take the sheet. All these things is very important. But subsequently, as you sort of do more and more, then you concentrate more on these trajectories and other things, especially if you're going to use more than one device. Initial 10 cases, just stick to one device, and that will lessen your complication.
When I look at the projection here, this is quarter 10 degrees, right?
RAO, yeah.
Yeah.
22,
Okay. So
10, 18.
what we do a little bit different, we go more RAO and more caudal.
More caudal.
And then the diameter of the appendage is usually larger. And we are looking always for the largest diameter, what we can see. Yeah.
Yes. And also, this is because this is a lamprey, we have not really positioned the sheath right. So there is a way to position your sheath right. You have to take the pigtail to the uppermost lobe. What I do is I put the amplansar wire in to give a little extra stiffness. Then anti-clockwise your sheath as much as possible. So as we do Watchman requires a little more learning later.
Double curved or single curved?
This is double curve.
So what is your choice? Double curve? Double curve? Double curve?
Yeah.
Mostly double curve.
90% double.
If you're asked to choose one device for all types of LA or one sheath for all types of LA, which just
So I think this is a good question, and Dr. Horst answered it. When the Watchman trial started, success was 87.5. Today, you have any device on your shelf, you can close 98.5% of your appendage. So it really doesn't matter which one, any device on. But if it is lamprey, the success may be increased by 1 more percent. You could close 99.5%. So it really doesn't matter in today's era which you can learn any one of them. But first 10 cases, learn one, understand it. It's always easy to known to unknown is always better. So you don't do too many things in the beginning. And unfortunately, unlike coronary, you can't choose type A lesion here. You have to do what you get. And whatever imaging you do prior on table, sometimes it's a surprise. Like, however, the T image was beautiful, but the what you got in angio is different. It makes you feel different. So you will have to still position the sheath better, especially if the device is something like Watchman. So
Ranjan,
there
how
is
do
a
you
next step.
Ranjan,
Yeah.
just
how do you
one last point. I think you were mentioning about the sizing. In this case, I'm not sure whether you had a CT or you're doing sizing on just on the echo alone. If you're doing sizing on the echo alone, how much sort of you concentrate on the LA pressure before
Okay.
you select the device?
Yeah. So basically, I was talking about LA pressure being 10. This is a very arbitrary number. Nobody has really studied on this. But when it is more than 10, you feel it's a very sensitive structure. It's going to expand little more, little less. If it is more than 10, you think it is patient is hydrated and the measurement you get is okay. If it is less than 10, you hydrate. But sometimes, even with hydration, the pressure doesn't go up. It doesn't. In which case, I upsize the device by one more. If it was not a full replete patient, hydrated patient, I've taken 22, which is a sizable upgrade because the sizes we got is only 16. I didn't take 20. So little more upsize is what we do. But if you think the pressure is not matching, you would take next size. And if it is Watchman, you could upsize as much as possible. When you see Watchman, you realize it is more the upsize, it allows more upsize. But whereas Lambre and ACP, too much upsize is difficult because it tends to push out if it is there. Watchman actually more upsize, better it is. Dr. Horse, I think we can listen to Dr. Ramesh.
Yeah, I mean, the mean left atrial pressure, we go for 12. If not, we give more fluid challenge.
Yes.
Keep giving 500 ml each time and see reassess it. I think there's one comment and then we can start.
for optimization of this view, what are you looking at
Yeah.
and what angle are you trying to see? And
Yeah.
second, are you going to do an angiographic measurement?
Yeah, this is a good question. I'm not looking at anything because we don't go by this, and most of the time, this is just to show. And since it's a live, we have done most of our cases with zero contrast. We are not really looking at great information. But yes, you are in doubt, you tend to do. I know that most of you are intervention cardiologists, and without a dye, you don't get the kick. So most of the time, we just do it for that sake. It's not a must. Zero contrast is very, very easy to do because 1/3 of your patients are actually kidney patient. CKD patient may, or that is one subgroup where device closure becomes good. So I don't try to optimize it too much. It's just for visual observation. Yeah.
Yeah, we depend on sizing on both. As long as the creatinine, as you mentioned, in those probably 2/3 of the patients whose creatinine is fine, we look at the angiogram of the left atrial appendage and size it according to that as well.
If you have creatinine very high, should not do it. And suppose you have a moderate, I mean, just borderline creatinine. So what you do, take hand 10 cc syringe, fill it up with 7 to 8 ml cc of contrast, then push it with saline. So one view is more than enough. Now suppose you have done one view with 7 ml and the next view you still want to do. The rest of the dye which is remaining in the sheath is sufficient to take another view. So all depends on your creatinine level.
Yeah, but you don't need angio. Because the echo information is much more. See, angio, you're at best getting one view, right? You're not getting all. You don't know what is in between. Echo information is much more. Yes. Mike there? Mike. Yes.
Like you said, when we upsize much more, especially with an amulet or an Lambre device may get pushed out. So at what level of upsizing do you expect that the device will not sit? And with respect to the morphology of the LA, do you change your sizing like the distal, like depending on the morphology, like if it's a chicken wing or a reverse chicken wing, do you change your sizing
Yes.
strats?
So there are difficult anatomies, there are easy anatomies, but now you're mostly concentrating on the neck. So if you have a 10 to 12 millimeter neck, that's enough for these devices. You don't need the depth beyond that. So based on that, the more important is it elliptical or is it circular? A circular one requires more upsizing. Elliptical, imagine all measurements are 18, 18, 18. One of them is 21. A 24 is enough. You still have to upsize, but you don't have to go too much. But imagine it is 21, 21, 21. I might go to 26. thinking that it is, more elliptical. Now 3D echo is possible and easily possible. 3D TE, you could actually cut this particular area in one section and measure, look at it. But sizing is not a big issue in appendage. You can never go smaller than the appendage size.
Yeah.
Sometime even 2 to 3 millimeter upsize is also enough. Little optimal upsize prevents peri-device leak and positions well. If it is too big, there are ways you can still put the appendage because it's about where you implant. That also comes into picture. Sometimes there are cases where we have used amulet or ACP and implanted almost like Watchman. That means you go deep in, start implanting and come out. So there are ways
Yeah.
you can close almost any appendage,
Dr.
but there are difficult appendages.
Yeah, Dr. Ranjan, one comment and then we'll go, actually we'll finish and
Yes,
then take
yes.
questions at the end. So sizing is important mostly for the non-pacifier type of devices such as Watchman, conformal, these are important. Any size less than 10% compression, risk of embolization. Any compression more than 30% risk of pericardial effusions or perforation. So both of them are there. So you have to be, sizing is important only for those. But this is a lambre, for that's why he is talking about that it's not as important and as probably
Load
would be
the
average.
device. Okay, we'll do that. So this, once you do the puncture, pigtail in. Don't push the sheath. Pigtail is okay, and pigtail is doing well. Position is good. I've done a RAO caudal view because that opens up the appendage well. You also see that small, the tail here. For device like lambre, we don't have to be, you don't have to be that deep. So we are just positioning it. And if you realize I've not taken the pigtail out, I'm going to do it later. This is how the device look. It has, part, it has hooks, and it also has this one, disc. So we are going to load it. Yeah. And once we, light up. So we have loaded it fully like usual. This loading is almost like the way you load ASD, and you will slightly anti-clockwise. Still you hear that click, because without that
Right.
it becomes
Ranjan,
difficult.
stop a
So
minute.
we're going to,
Those who are doing coronary angiogram, when you go ariocaudal, you see the ostium of the LAD, ostium of the circumflex very nicely. If you go to ariocranial, then you see the whole LAD. So length of the appendage for ariocranial, the ostium for ariocaudal, that is number one. Number two, so one more point, if you just to attach the device on the wear, then use your index finger. That gives better feeling that you have completed the screw. And 1% minus, rather than holding the device in 5 fingers and turning it around, it's very difficult. So just use your index finger. Go ahead.
and sometimes you need younger people to do it. It may be difficult for all. DR is now. Bharat here is going to flush it like we do. DR and keep it slightly more in. Okay, that's what we are going to lock it and DR it once more, and that is die. Yeah, air only, without air, and we'll keep half of it. Now, just before I move, I will slightly, my catheter is looking upward. I'll slightly position it half, and that's enough. Yeah, enough. Lock. Okay. The device is ready. Sheath is ready. So we're going to do I'm going to do a final check to see. I'm going to rotate it on the pigtail. I'm going to rotate it anti-clockwise and take the sheath a little more in. Now with this, I'm going to take out the device is ready. So this is important. Till now, although the sheath was in, we have not really aligned it because, I don't want to keep the torque till the end because there's a considerable torque. So only when we are ready with the device, you want to take it a little more in on the pigtail and use the anti-clockwise. So it was clock during septal puncture to go away and anti-clock here. If it is more bending down or clocking, your device doesn't, it implants in a wrong direction. I'm going to take out this part with pigtail, with wire, with everything. Now only the sheath is in. It's going to bleed little bit here, and we're going to wait for it, some hydration. Yeah. Come the device. So the device is here now. Yes. And we're going to connect it with the flush. Come. Yeah, can you flush? Yeah. Yes, and we're going to connect this. These become a single unit now. We can disconnect this, and I'm going to take the device very, very slowly. So now we are going to look at the echo. So the echo, you saw the measurement was 16, so I've upsized it significantly here, 22. Little bit dye is showing me where it is. We are in RO caudal view, and device is now going, we are just getting the device. So we're going to take it slow. I can see the device come. At this point, we're going to be gentle, slow, and I'm going to get it till the tip. Now, the part of the device is out. I'm going to look at the echo
Ranjan,
to see where it is.
can you stop for a while? The two things, if you inject air, the first, and if you get sudden hypotension, it's always right coronary artery which has got air embolization, ST elevation, rather than a perforation. Perforation hypotension does not occur so quickly. And secondly, once you are almost reaching to the end of the sheath, please pull it back a little bit. Because this is the moment we'll come to know whether while moving the device, you have unscrewed the whole thing. It has happened. And if you have unscrewed the device and the device is inside the guide cath, you have to snare it out. There is no other way of screwing it again and taking it back. So this is one more step. Go ahead.
We're going to open up the device little bit. Yeah. Can we see in the echo where it is? Yeah, no problem. Take your time. I'm going to push it in and come out. And, we are going to put the disc. And if you see, the disc is already in. So you have a device which is in now. So we slowly anti-clockwise. And here I usually use the method of unsheathing, means go a little more distal and unsheath, and you see the device is already in there, covering exactly the point which we want to cover. Compression is good. I'm going to do a little tug and see the position where it is holding. It is good. And I'm going to do a little push. Now, if you see, whenever the appendage fully endothelializes, there is no appendage there. The device is in. Can you have a dye for injection? Yeah, give the dye. You have to be careful about add. This dye it's not a must. Echo is very important. This is just to tell us that we are in position. So we're just going to take one angio with the sheath in, but I'm actually happy with the position. We might need more dye. Yeah. Yes.
Ranjan, if
bigger sheath. So generally,
tell at this point, what fluoroscopic parameters are you looking at?
No. Again, nothing much here. It is just for this one. So I think Dr. Horst has we'll have to. So what I'll do is we have done this case. Yeah. With this case, I'm sure we'll see more of these. There are 4 more cases and we'll go stepwise. But I think we'll have to this. So what we do is a little more dye to. I'm going to pull it far. Everything looks well. Kavya will do further echo. I'm going to pull the sheath. So just to see that appendage is now completely excluded. The disc is covering when it endothelializes. The whole appendage is excluded. We have also done a tuck to show that the position, it's not really jumping up. The compression, which is not very important here, looks good. You have to decrease the gain and make sure there is no peri-device leak. Nowadays we don't accept a peri-device leak. So it's done in a way that peri-device leak is negligible, and we are going to put a fix. Actually, we tend to anticoagulate a little more because it's just a venous puncture. You're not worried about the sheath removal here. And we remove these knots after 2 hours after the procedure, and that's it. So you can show the grind. So I think we could discuss when somebody's connecting Dr. This one we could discuss that. Connect this.
Yeah, we'll thank you, Ranjan. Please stay on. That's a fantastic demonstration of a very nice and easily done case. Yeah. Yeah, he took 10 minutes longer just because I think it is to be recorded. Otherwise, it would have been done in 10 minutes. So you don't use any contrast. He don't need any other imaging prior or CT. Earlier, you asked a question about CT versus TEE. It depends, I think, which center you are at and what is the patient's contrast, creatinine, and based on that. So in our center, a couple of people obtain CTs routinely. I actually don't do any imaging until the patient is on the table. And I actually look at more now intracardiac echo, don't do any TE either. If I find a thrombus on the intracardiac echo in the left atrial appendage, we cancel the procedure. But that is counted against In the United States, everything is like a report card. I get a report card of my aborted cases. Aborted cases is a bad ding, meaning that we are looked down as one of the poorest hospital. So we have to make sure. So imaging is good in case if you can do it. TE is not expensive in India, so please do imaging.
Okay, thank you very much. So I was asked to talk about challenging cases and complications of LAA closure, and I changed the topic a little bit, more focusing on complications, because as you know, this is a preventive procedure. We really have to keep the complications as low as possible. It's not about to do challenging cases, it's actually to reduce complications. So let's go about the complications which may occur with this procedure. So pericardial effusion or tamponade, then thromboembolism and stroke, then air embolism, then device embolization and thrombus on the device. So these are the major complications which can occur. This was the first ever attempt of LAA closure. That was in August 30 in 2001. A 66-year-old male patient, atrial fibrillation since 1 year, history of stroke, history of severe bleeding on Coumadin, CHAT score was 5. And this patient, the first ever, suffered from tamponade, probably caused by the multipurpose catheter in the left atrial appendage, but I was not really sure about the cause of the bleeding. We did immediate pericardial synthesis and drainage. We retransfused the blood via the femoral vein, and the procedure was abandoned. An hour later, we did the second case, which was actually the first successful LAA closure. What happened with the first patient? Well, he could be stabilized. Pericardial drainage could be removed the next day. I told him that we would try this again in a few weeks. And the patient said to me, why did you not just put the device into the appendage to seal the hole? The second procedure on this patient was performed on October 2nd and was successful. So we learned all we need to know about tamponade from this very first attempt. It's often difficult to say what the cause of the tamponade was. It could also be related to the transeptal puncture or something else. If it occurs during the procedure, then try to finish the procedure and implant the device. That was actually what the patient recommended to us after the procedure. And pericardial synthesis should be done, and retransfusion often solves the problem, retransfusion into the vein of the patient. This is another 75-year-old patient, paroxysmal AF, concomitant diseases included hypertension, congestive heart failure, diabetes, and mild mitral insufficiency. CHAT score was 4. Transeptal puncture performed under TE guidance, as always. This is the anatomy. You can see reasonable for Watchman case. These are the appendograms, osteal diameter 19 and 24. We picked a 27 millimeter device. This was device implantation under TE guidance and fluoro guidance. And this is the tuck test, the final angiogram before release. This is the before release. Fluoro was 20 millimeters and TE also 20 millimeters compression. So compression was reasonable. Everything was fine. This was the final position of the device. So outcome, procedure time 25 minutes, fluoroscopy 7 minutes, contrast 100 cc. We gave 10,000 units of heparin, very small pericardial effusion on day 1, control TE. On day 3 showed no pericardial effusion. Post-procedural medication with Coumadin according to the study protocol. This was a PROTECT AF study patient. Discharged from hospital on day 4. So where's the complication here? The complication occurred on day 10. Admission with chest pain, EKG was normal. Fluoro showed the correct position of the device. TTE showed a pericardial effusion of 2 centimeters with swinging heart. This is not a video, it does not play, but it was unfortunately not recorded. And to do what now? What to do in a pericardial effusion 10 days after the procedure? We did pericardial synthesis, aspirated 800 millimeters of bloody fluid. We put a pericardial drainage for 2 days. TTE on day 12 showed very small residual pericardial effusion. 3-year follow-up was uneventful. So possible causes of pericardial tamponade are transeptal puncture, access to the left atrial appendage, implantation of the device itself, and anticoagulation. Transeptal puncture should always be done under TE guidance, as we discussed before, in order to avoid pericardial tamponade caused by transeptal puncture. When you get access to the LAA, start with an angled 4 French pigtail, exchange over the pigtail or an Amplatz extra stiff wire, appendogram with wire or pigtail in place, and advance the sheath into the appendage only with protection by a pigtail, a wire loop, or a ball-shaped device. How to manage tamponade? Acutely, do pericardiocentesis and retransfusion. But if it is chronic, after 10 days, pericardiocentesis, of course, but no retransfusion. Because if you retransfuse old blood, you can cause all kinds of clotting disorders. Surgery for pericardial tamponade is almost never needed. Does anticoagulation play a role? Anticoagulation is never the cause of bleeding, of course, but it makes it worse. We always stop anticoagulation before we do the procedure. We give heparin only after transeptal puncture, and we give protamine in case of pericardial effusion. Let's move to the second kind of complication, thromboembolism and stroke. Potential causes are thrombus in the left atrial appendage, thrombus formation inside the transeptal sheath. This happens if the transeptal puncture is difficult and takes more time than usual. The thrombus forms in the space between the needle and the dilator. Then thrombus formation inside of the delivery sheath is another cause of thromboembolic events. How to prevent thromboembolism? Thrombus in the left atrial appendage, at least in my view, is a contraindication for LAA closure. Anticoagulate, if that happens, anticoagulate as good as possible, bring the patient back a few months later. How to prevent thrombus in the sheath? Always flush all catheters and sheath intermittently or with continuous infusion. Give a sufficient dose of heparin after transeptal puncture or just a small dose before puncture and then the rest after successful puncture. It should be ACT controlled, target 250 seconds. Or what we do, we give 10,000 units as a bolus, and then if the procedure takes longer, then we check ACT, otherwise not. What's about air embolism? How to avoid air embolism? You should de-air the sheath. You should not aspirate because that brings actually additional air into the system. It's better to wait for back bleeding before you insert a device, and always stay with the hub of the sheath below the level of the heart. The LA pressure should be higher than 10 millimeters of mercury. So if the pressure is lower, then we give additional fluids, and we give the patient, before we bring them to the cath lab, always they get infusions. How to treat air embolism? Well, prevent additional clot formation and give heparin, additional heparin, aspirin, 2B3A inhibitors, and lytics, because the air by itself is not the problem, but secondary formation of thrombus in the vessels, in the brain or in the heart is the problem. And we give 100% of oxygen. What's about device embolization? This is a 66-year-old patient with typical history, which is not important here. So we did all the measurements, angiographically, RIO caudal was 22 and 24, and then another projection 22 and 18. On echo, it was 17 millimeters and 19 millimeters. So which type of occluder and which size to pick here? Well, if you go for a Watchman device, this was not the current generation, the former generation. If we take the measurements by TEE, then we should go for 21. If we take the other measurements into account, we could go for a 24 millimeter device. So this is the implantation of the 24 millimeter Watchman. This is residual compression. This is the position. We did the tuck test to make sure that it's in a stable position. We did this with angiography control. This is TE on long axis. Device was stable. Short axis, stable device. This is 45-degree. This was not stable. And the echocardiographer said, look at this, very nice images. So what to do now? This occluder embolized into the abdominal aorta. And what are the techniques to treat that? Surgical removal of the occluder. This has been done in some patients. Big stent to compress the occluder to the aortic wall is another option. or you can try to snare the device, and that's what we did it. We did with a big snare and an 18 French arterial sheath, and were able to remove this device easily. Why did it embolize? What to do now? Maybe you have paid attention to this. This was a residual compression, 23.5, 24.8. Remember, this is not enough compression. It was a 24 millimeter Watchman that was clearly undersized, but we didn't pay attention. We were relying on the tuck test and thought it's stable, but as you have seen, it was not stable. This was the residual compression, what we wanted to see, 22 at least, and it should be 8 to 20% with the old Watchman. So it was definitely not compressed enough. We did the second attempt with 27 millimeter Watchman. This is, we put it a little more distal, and you can see there was an inferior gap. This is also the gap on TEE. So we repositioned the device, placed it a little bit more proximal, and then the gap was closed. 80 millimeter compression, tuck test, then the occluder was released. 133 degree, stable. Echocardiographer said, looks okay. I mean, she didn't say it was great. She just said, it's okay. Huh? Second attempt was successful then, occluder released. This is another patient, and you can see the sizing here. So we had a tech in the room who liked to do multiple measurements. As you see here, I think the real diameter was 25.5. According to the sizing chart, we used a 31 millimeter Watchman flex device. This is the angiogram during the placement. Compression of 25 looks good. And here the device told me, release me, release me. So I released it. And then I was out of the room for a coffee. And then I heard something is wrong here. Dr. Sievert, you should better come back to the cath lab. If somebody says that, that's always a bad sign. And you look what happened to the device. It's actually tilted here, still in the appendage, but tilted. Indeed, there was something wrong. And now you see the device is not there in the appendage anymore. So it embolized. You see where it is. The good news, it cannot get worse. So it's obstructing the LVOT. What to do now? Let's snare it. So we went in with a snare and tried to capture it. It's actually with the Watchman Flex, it's very difficult to snare it because it's a round ball-shaped device. So it just flips away. When you try to snare it, it flips away. So we could not catch it. Snaring failed. What to do now? Still on the LVOT, obstructing the outflow tract. I had at that time a lot of adrenaline in my body, as you can imagine, right? So I thought, let's give the patient adrenaline. We did this. Blood pressure went up to 300, and plop. The device embolized into the aorta. That's where I wanted to have it. Let's check the aortic valve. Aortic valve is still doing fine, so we didn't cause any damage there by snaring and by the POC maneuver. In the descending aorta, what to do now? As I mentioned, snaring it is very difficult. Actually, we had another embolization. The only way to really snare the Watchman Flex is to grab one of the small hooks, but you cannot snare the entire device. So fortunately, the gastroenterology helped. So they had a bioptome ready, and we captured that with a bioptome and were able to remove it, as you see here. So what to do now after retrieval of this device? Well, of course, we went in with another device, 27 millimeter Watchman Flex. This was actually then straightforward. Here it was a little gap there. We repositioned it more proximal, and this is the final result. Device was stable and good follow-up. How to prevent device embolization? The LAA pressure should be at least 10 millimeters of mercury. Why? Because otherwise the LAA is not expanded and the device too small may be chosen. Or you can just add another size, another 2-3 millimeters. All release criteria have to be fulfilled, not only the tuck test. Correct position within the LAA, no significant residual flow, tuck test, stable, and device compression, and always pray when you release the device, of course. How to treat device embolization, try to snare and retrieve the device. Surgery is rarely needed. This is another case actually ended up as a live case at CSI this year. You can see the history. The LAA was closed with the Watchman Flex device in September last year, a Flex 31 millimeters. This was the initial procedure in September last year. Looked actually straightforward, Flex 31 millimeters. You can see correct compression, everything fine. And then they did a CT follow-up in February this year. And you can see that the device is not in the correct position anymore. It's not really embolized. It's still in the appendage, close to the appendage, but it's not at the orifice anymore. You can see another CT view. So the plan was to retrieve this. We did cerebral protection with the Sentinel device because there was also clot inside of the device. You can see the TEE of that device. And in this one, we used a Raptor grasping device inside of an Agilis shield with a steerable sheath, inside of a 26 French dry seal sheath. You can see we grabbed the device and then we really pulled hard. It was an enormous resistance. I learned this from Devi. I don't know whether Devi is here now. She has much more experience with these kind of retrievals. So really had to pull very hard. So I wrapped the delivery cable, the shaft of the Raptor device around my hand and pulled as strong as I could. And I was not able to retrieve it. And then finally we pulled with two people. So I was holding the sheath and advanced it into the patient, and my colleague was pulling very hard on the shaft of the Raptor device. And then finally, with enormous resistance, you can see at the end of this loop, go faster, please. You see the resistance, it was flipping around. And then, hey, you can see the resistance, right? And then it popped. Okay, then we closed the appendage with an AMOLED 22 millimeters in this case here, and finally we have been successful. So now thrombus, finally thrombus on the device. Well, thrombi come like terror attacks. They are unpredictable. So there are no really hints why a specific patient develops the thrombus. So they come randomly. And this is an AMOLED device after 4 weeks. How to manage these thrombi, anticoagulation as good as possible according to the history of the patient, and then observe. It's not justified to do surgery in these patients. Thank you very much for your attention.
Thank you very much. That was fantastic. Complex and complications of left atrial appendage closure. With that, we close this session. We invite the next moderators for the session. Any key take-home message, Dr. Hazra, and then we'll close it.
Me. Take-home message, keep on doing it. Keep on walking with this device. One day you will feel that it is much better than Ranjan, myself, and Hot Sivat. So nobody has learned anything by birth. You have to keep on doing. Keep on working, put your intelligence, mind, philosophy, passion, everything into the
so just one more comment. I mean, we are all enthusiastic about LAA closure, and I'm the first one being so. But LAA closure is not an easy, straightforward procedure. And when I compare, for example, TAVR with LAA closure, I still would say LAA closure is more difficult. With TAVR, you can only make two mistakes, too high or too low. But here you can do many other mistakes. So be careful.
Yeah, I know the TAVR is much easier to do. Only the problem is the cost. That's what I mentioned initially. But LAA closure definitely a little bit tricky. That's my take.
Okay, thanks to Dr. Ho Sivat for coming in all the way, and I know you have to leave, but round applause, please, for Dr. Ho Sivat.
Now we come to the end of this first session. I request Dr. C.B. Patil sir to come up on the stage and give mementos to the moderator and chairperson and speakers.
Host, can you come back one time?
Dr. P.K. Hazra, sir. Dr. Host Seward, sir. Dr. Dr. Ramesh Dagupati, sir. Dr. Deepak Padmanabhan, sir. Dr. Neeraj Avasti, sir. And Dr. Anil S.R., sir. Dr. Anant Raman, sir.
We, we would like to thank all the speakers, moderators, chairperson, and the panelists for the wonderful session. Moving on to the second session, I would like to invite the moderators for session number 2, Dr. N.S. Devanand, Head Senior Consultant, Cardiothoracic Surgeon, Bangalore. I welcome Sir onto the stage. The next moderator for the session, Dr. Edwin Francis, Director and Senior Consultant, Pediatric Cardiologist, Kolkata. Sir, I welcome you to the stage. I would like to invite the chairpersons for the session, Dr. Ashish Jha, Consultant Intervention Cardiologist, Patna, Dr. Rohit Manoj Kumar, Professor, Department of Cardiology, Chandigarh, Dr. Chandramani, Senior Consultant, Intervention Cardiologist, Nepal. The panelists for the session, Dr. Bhushan Shah, Senior Consultant, Intervention Cardiologist, Bhopal, Dr. Sham, Senior Consultant, Intervention Cardiologist, Bangalore. I request the moderators, Dr. N.S. Devanand and Dr. Edwin Francis, to take their seats on the stage. I request the moderators to please introduce the speakers for the session.
Good afternoon, everyone. Has been a great session, the previous. Now we'll go to the specificities of each, starting off with the applied anatomy of L8 appendage from the surgeon's perspective. Dr. Murali Krishna, please.
Good afternoon, everyone. So after first session, this is the. So when Dr. Ranjan told me to speak on applied anatomy of LAA as a surgeon, we hardly look at the left atrium when we do the cardiac surgery. So right atrium is sort of on our face, but left atrium we have to really look for. Occasionally it peeps from the side of the pulmonary artery. If you don't want to deliberately look for it, we hardly see it. So now the LA appendage interventions have become very common. So it's imperative for all of us to know the anatomy of the left atrial appendage and how the various devices and various procedures to implant it are really suited anatomy wise. So just to give a brief introduction of how the left atrium develops, left atrium starts from day 18 to 21. It starts when the endocardial heart tubes start forming the arches. You can see the bulge there, called the primitive atrium. The primitive atrium takes a leftward turn, takes a rightward turn, and it is formed from the primordial ventricle. So the primary atrium, what happens is, once it gets resorbed, the pulmonary venous bud which develops will form outgrowth which fuses with the left atrium, and then it forms. You see the cut section of the primordial atrium, which shows the pectinate muscles. So that pectinate muscles is a characteristic feature of the left atrial appendage. Unlike the left atrium, which is smooth, the left atrial appendage is always trabeculated. You see the pulmonary veins coming and fusing with the with the primordial atrium there. And then you see the blue color, that is the smooth left atrium. And the protrusion, what you're seeing is the left atrial appendage, which retains the only part of the primordial left atrium which comes. So by day 50, the formation of the left atrium and the left atrial appendage is complete. So this is the cut section of the left atrial appendage. What we see, it is not a vestigial structure unlike the appendix. So what actually, where the left atrial appendage, where exactly it is situated, it is a long, most of the times it is long, narrow, crenellated tube with lot of trabeculations, and it has got a crenellated lumen. And it develops on the pulmonary venous bud. So there are different shapes of the left atrial appendage. And what is the functions of the left atrial appendage? There are various functions, and most prominent of it is a neurohormonal role of the left atrial appendage. Both the left atrium and the left atrial appendage have got specialized cells which are involved in the production and release of natriuretic peptides. The left atrial appendage produces atrial natriuretic peptide as a mechanism when the heart is distended. The distension is the trigger for that. And the concentration of ANP in the left atrial wall is almost 40 times higher. It is situated both in the right atrium and the left atrium, and it always releases when the heart distends. Left atrial appendage also functions as a reservoir. Since it is the most distensible structure within the left atrium, it acts as a decompression chamber during volume overload. And in patients with sinus rhythm, when they took out the left atrial appendage, amputation was done, it diminishes the reservoir, and also the cardiac output also comes down. So what happens when the left atrium loses its rhythm? That is, in left atrial appendage, in the atrial fibrillation, left atrial appendage remodeling occurs, which results in the left atrial appendage forming a dilated and static pouch with decreased Doppler flow velocity. So when Doppler is done, there is very reduced flow velocity, which acts as a nidus for thrombus formation. So this is the mechanism of exactly how it happens, atrial fibrillation and stroke. You see, once the left atrium loses its rhythm, there is increased thrombogenicity and endocardial dysfunction, which triggers the mechanism of thrombus formation. So dilated chamber dilates, the rhythm gets distorted, and you can see the clot formation happening in the left atrial appendage. So long-standing atrial fibrillation also leads to atrial remodeling, fibrosis, and inflammation of the endothelium of the left atrium. And they also lead to focal triggers and re-entry arrhythmias. And this is the third. Now, the good function of the left atrial appendage is acts as a reservoir, it acts as a conduit, and acts in the release of hormones. But what are the bad effects of left atrial appendage? Left atrial appendage acts as a source of thrombus, and it also acts as a source of rhythm, the arrhythmia triggers. So studies have reported that left atrial appendage is a source of thrombus is almost 90% of the non-valvular AF cases. So this is a brief history of what the left atrial appendage and left atrial appendage does. Now we'll go in brief about what are the mechanisms, what we are doing to prevent the stroke from happening. Why left atrial appendage occlusion? Because as I already alluded to, it's a source of frequent systemic emboli. So oral anticoagulation is imperative to be started in any patient who is having atrial fibrillation, and for patients who are unable to take anticoagulation, for patients who are prone to elderly patients or more prone for bleeding tendency, the patients who are able to fall, more prone for falls and all, and for them who are simply non-compliant, who do not want to take any sort of anticoagulation, for them left atrial appendage occlusion is one of the main modality to reduce the risk of stroke. So what are the benefits of left atrial appendage occlusion? One is it eliminates long-term coagulation-related complications, the need for routine drug level monitoring, compliance, long-term cost savings, definitely. But it does not completely eliminate the need for anticoagulation in all the patients. There are some patients who do need to take anticoagulation in spite of having left atrial appendage occlusion. So just to mention brief of left atrial appendage anatomy, because this is very crucial in planning any procedure on the left atrial appendage. Left atrial appendage, most of the times it's a finger-like pouch with various bends and shapes originating from the main body of the left atrium. As the left atrium grows, the primordial pulmonary veins become integrated into the left atrial wall. So if you look at the embryology which I showed earlier, it's the only remnant of the primordial atrium is the left atrial appendage. So this is the specimen which shows the left atrial appendage in the explanted heart. You can see the left atrial appendage lying behind the pulmonary artery. So pulmonary artery, the main pulmonary artery and the left pulmonary artery are superior to the left atrial appendage, and it has got a very close relation with the coronary artery, circumflex coronary artery, the great cardiac vein, and left pulmonary vein, and the left-sided pulmonary veins. Blood supply comes predominantly from the left circumflex coronary artery, and it's located in close proximity to other vascular structures like left-sided pulmonary veins. And this is an important chart for you to know the relations of the left atrial appendage. The left atrial appendage, you can see in the picture, which is pink in color. You can see that yellow line traversing, it's the phrenic nerve, which is posterolateral relation to the left atrial appendage. The left atrial appendage tip can be pointed either superiorly or it can sometimes go behind the pulmonary artery. It can be in the transverse sinus. You can see the circumflex coronary artery and the great cardiac vein in the groove, circumflex groove there. And you can see that, sorry, the pointer is not working, but you can see just adjacent to the left pulmonary vein is the ligament of Marshall, which is the remnant of the left SVC. So that is the epicardial landmark. If you go interiorly and see inside, you can see that Q ridge near which separates the, sorry. Yeah, you can see the Q ridge which separates the orifice of the left atrial appendage from the left superior pulmonary vein. You can see number of pits-like things near the orifice of the left atrial appendage. Sometimes what happens when the left atrial appendage is closed, these pits are left unattended, and these can be a source of clot formation. So this is the commonly known classification system of the left atrial appendage. There are various types. The commonest classification morphology of the left atrial appendage is a chicken wing. It's almost 46% of the left atrial appendages are of that shape. The second comes the cactus, lobulated morphology, also called cactus. The third is the windsock, and the last is the cauliflower, which is only in 3% of the left atrial appendages. So this classification aids in guiding procedural decisions and predicting technical challenges, because I will show you how it looks exactly. You see that the topmost is the windsock. Windsock is having a one prominent lobe, and many accessory lobes can be there, but one prominent lobe is there. The second one is the second one is the chicken wing. The chicken wing is the main lobe folds upon itself in the proximal 1/3 part, and it is the commonest. Almost 46% of the left atrial appendages will have the chicken wing configuration. The next third one, what you're seeing is the cactus morphology. The cactus is having multiple lobes. It's the second most common morphology. And the fourth one is the cauliflower thing, which is which with hardly any lobe is there, which is very variegated. A lot of pectinate trabeculations are there and more prone for thrombus formation. So compared with chicken wing, patients with other left atrial appendage morphologies are more likely to have a stroke. So this is what I told you. You could see if the patient is having chicken wing morphology, it is nearly 40% less incidence of having a stroke as compared to other morphologies. So these are the resected specimens of chicken wing, cauliflower, cactus, and windsock. So imaging, you can see on the right-hand side, the topmost imaging is by multi-detector CT scan. The second one is by cinefluorogram or fluoroscopy, what we see. And the third one is the CT rendering of the and reconstructed images of the various types of LA morphologies. So this is the general anatomy of the left atrial appendage. And what is the cardiac surgery relevance in this? Patients undergoing cardiac surgery, we usually do not address the left atrial appendage at all. But now so many things are coming, like in patients with valvular pathologies or patients who are having long-standing atrial fibrillation. Since the left atrial appendage is a commonest source of clot, it is imperative for us to close the left atrial appendage when we are taking the patient for concomitant procedure like bypass surgery or a valve procedure. Left atrial appendage closure during cardiac surgery will not have any additional risk. But there is one caveat in that inadequate or incomplete closure can significantly increase the risk of thromboembolic events. So we have to make sure that the complete left atrial appendage is completely occluded. We should not leave any residual left atrial appendage because that can, future going ahead, it can be the future source of left atrial appendage thrombus. So there are different techniques of left atrial appendage closure. You can see as in this chart. Percutaneous, I think there are a lot of sessions which cover the percutaneous thing. Surgical, usually we do three things. One is suture closure, another is device closure. Device closure as a part of thoracoscopic or minimal invasive procedures where the different procedures like AtriClip, endoloop, ligashore or stapler are applied. And suture ligation where there are again three techniques. One is epicardial where we just ligate the appendage as much as we see. The second is endocardial. When we open the left atrium to do a mitral valve procedure, we close the left atrial appendage from inside. It's a complete end occlusion of the left atrial appendage lumen. So, and the third one is amputation and epicardial. We amputate the appendage completely and we take an over and over double layer closure to completely eliminate the residual space once we close the left atrial appendage. So these are the important things. One, what we have to make sure is there is nothing, no remnant of the left atrial cavity which is left. Because I didn't tell it before, because the left atrial appendage, there's a lot of variations in the anatomy, there are a lot of variations in the morphology. Even the left atrial appendage ostium, if you take for this thing, it's usually oval shape, but it can be teardrop shape, it can be oval shape, it can be pectinate shape, or it can be like a dog's feet. And even the location of the left atrial ostium, when we see from inside, usually 50% of the cases, the left atrial ostium is at the level of the left superior pulmonary vein. But in 30% of the cases, it can lie above, and in 10% of the cases, it can lie below. So I think when doing fluoroscopy procedures, I think you need to take that into consideration. So Madden suggested a surgical resection of the LAA in patients with AF, which could prevent recurrent arterial emboli. So the high complication rate of the procedure prevented its widespread adoption until the 1990s, when interest in the procedure was rekindled by the development of the Cox-Mace procedure. So now what we do is we left atrial appendage, we routinely close as a part of the part of the Mace procedure, where we completely take out the left atrial appendage. So this is one Cox-Mace 4, as you all know, is one of the main modalities of long-term treatment of atrial fibrillation. So the two general approaches I already alluded to. You can see in the top is the device closure. That second one, what you see, that lariat device closure, which is a hybrid procedure done both surgically and in the and endoscopically. Surgical occlusion we use by doing AtriClip, and the last picture what you're seeing is an over and over closure after excision and amputation of the left atrial appendage. And the top left figure, what you're seeing is the closure of the left atrial appendage from inside when we address the mitral valve. The second one below is the amputation and excision of the left atrial appendage. The third one is the AtriClip, what we are doing through thoracoscopic ports, atrial appendage clip. But when we do all these procedures to occlude the left atrial appendage, so what is the efficacy of LAA closure? Efficacy of LAA closure, you see here, AtriClip is only 1.6% of the residual defect is there, but and which only suture ligation you do, almost 60.8% of the patient will land up in thrombi formation. So there are various gradations of the residual defect of what we leave the left atrial appendage. So we should need to be very, very careful in considering what type of procedure we use to occlude it. So coming to conclusion, so as a part of the class 2A recommendation, any surgical procedure what we do, whether it's to address the long-standing atrial fibrillation, or as a part of patient who is having paroxysmal AF, who are prone for recurrent stroke, who had a recurrent stroke, the ideal class 2A recommendation is to obliterate the left atrial appendage, occlusion of the left atrial appendage. So further studies are required whether it needs to be a part and parcel of every cardiac surgical procedure what we do. Thank you very much for your patient hearing.
Thank you for an excellent comprehensive talk. How often do you do a actual LA closure on the surgical table, and what scenarios?
No, generally, if a patient does not have any history of stroke, we do not address it at all, as I said before. Only if the patient is having long-standing paroxysmal AF, like most of the patients, what we see will come as a valve patient who are having mitral valve pathology and who are having, most of them will be in atrial fibrillation, long-standing atrial
Those
fibrillation.
patients you regularly.
Yes.
Which method do you use?
For them, sorry?
Which method? You mentioned multiple methods in the surgical
No,
phase.
surgical, for long-standing AF, we always do a MACE procedure, radio frequency MACE.
No. For the surgically, the LA closure, what methods do you use?
Endocardial occlusion.
Endocardial
We
occlusion.
close it completely from inside.
Inside. Post CABG was routinely see proximal AF, na post-operatively. So why can't we routinely do it in a CABG patient? Is it difficult,
Yeah,
or is it
we
delay
can,
your procedure time?
we can do, but as I said before, it's the left atrial appendage forms a role as in neurohormonal role, and it drives compression. So as a routine procedure, we don't do, but only if the patient is really indicated, then definitely yes.
Basically, I think in the future, randomized control trial will solve the solution.
Solve the solution.
And it's very easy. In fact, for a surgeon to do this trial will be the best one. But of course, for cardiologist also, if the operators are well trained and there is no complication and the valve are in the near future, even the randomized double-blind control trial will solve this issue immediately. Because as Dr. Post said that it's a 2B indication, but in cardiac surgery, 2A indication. So there is a difference between 2A and 2B in transcatheter as compared to the surgical. So in the near future, if randomized control trials are there, that will, of course, this BNP plays a very role. It is not a vestigial organ. We did a study in atrial fibrillation in coronary angiographic that is published. I think in this 70% of the patients had endothelial dysfunction and also obstructive coronary arteries. So all patients of atrial fibrillation, angiography is the must before doing any procedure. That is also, in fact, everybody present on the Google. Thank you.
Next one. So we'll go to the next presentation. Let's invite Dr. Neeraj Awasthi for his presentation on echo assessment for transseptal puncture.
At the onset, I would like to thank the organizers, Dr. Ranjan, and all the whole team for bringing all of us together at such a wonderful discussion on left atrial appendage. My topic is a transseptal puncture, and it will be a general topic. And as most of the recordings on echocardiography starts after transseptal puncture has been done. So disclaimer is, I don't have recordings of most of the transseptal puncture I'm presenting. So if I can have the slides. And but believe me, transseptal puncture is the most crucial step for many of the procedures which we have to do, be it LA appendage, well, BMVs we all know, be it for paravalvular leak closures, be it for mitral interventions, mitral valve, valve in valve, mitra clip. So that's definitely there is this resurgence in the transseptal approach, and that is why the development of this technique and echocardiography approach has become so crucial. Can I have these slides? Next. So left atrial is the most difficult chamber to access. If technically we have to see, it's the most difficult chamber to access. It can be reached via left ventricle, mitral valve, manipulation of the catheters takes almost 280-degree turns. So definitely the transseptal puncture permits a direct route to LA via interatrial septum and through a systemic venous approach. That is what the transseptal puncture is. The technique of transseptal puncture was basically to gain access to the left atrium for pressure measurements. And when it started, it was actually historically a very, very safe approach. This is for history that a suprasternal approach was initially used, and one would actually pass in a catheter, and whatever has been a publication in those areas, you would find hardly any complication. So practically, very thin needles tolerate a transseptal approach very well. Why I say so? Because many of the times our needle crosses into the aorta, and we are really afraid. So a very thin wire does not really, the reindeer has actually done multiple publications on this showing various pressure measurements doing a suprasternal approach. And this was his publications again showing and just to emphasize that it is relatively safe to go through vessels provided you are going through a very thin vessel. They tend to constrict. The initial transseptal puncture was developed by Ross, Bronwart and Morrow, and subsequently Brockenbach modified, Mullins modified the whole technique, and this is what we use today. This is among the original publications from Ross, where they talked about the transseptal puncture. And what is the difference? Most of us have a Brockenbach catheter, Brockenbach needle, and whenever we are using a Brockenbach catheter and a Brockenbach needle, our needle is almost 1.5 centimeters outside the particular sheath. Many a times we are using a Mullins sheath. The Mullins sheath has a protrusion of almost 1 centimeter outside the particular sheath. The difference becomes very, very important when you are particularly using either of these two sheaths. How liberal you can be. One of the techniques is, of course, you can slightly push in a contrast and see whether you are really keeping a distance from the end of the sheath. Being a pediatric cardiologist and talking of a transseptal needle, my talk would be incomplete if I don't give ode to this man, William Rashkin, who actually did and they described the procedure of septostomy and shows how a septostomy can salvage so many kids with TGAs and all those septal dependent procedures where ASD was so crucial. It was initially used by interventional cardiologists for mitral valvuloplasty, as most of us has been using. The explosion of the interest went on to AF for dealing with pulmonary veins by EP people, and over last many years, this is what has been a trend. Initial hemodynamic assessment to maybe pulmonary vein isolations to left atrial appendage, the session of today, the percutaneous left assisted devices, the mitral valve replacements, the TMVRs, the mitral clips, the PVLs, and that is what the evolution of transseptal puncture has been. My work has been made easy by the previous talk. The embryology and anatomy has been well described. But from an international perspective, the embryology or the fossa vallis is usually located posteriorly at the junction of the mid and lower third of the right atrium. And this particular small gap which you see there, the circular thing, is actually the target of our transseptal puncture. What I am trying to do, usual photograph present in almost every book, but what is the importance? In a AP view, do you have a cursor here? Do you have a cursor here? Yeah, we are trying to come from the superior vena cava, and as I am coming from the superior vena cava with my needle which is directed towards the nominate vein, I am directed slightly posterior and towards the interatrial septum. As I come down, I see those bulges, and then I see that limbus where my catheter drops. In a AP view, let's see how does it look at. Can we go to previous slide? So this is what my catheter is actually coming down. As it coming down from the superior vena cava, it is having those bulges here, the first and the second bulge, and as it drips down the limbus, this is what my area of interest is. And this is the area where I'm talking of whether I'm doing a superior puncture, a postero-inferior puncture, or I'm trying to way away from the aorta so that why aorta? Because aorta is a very, very stiff element. If I have to do a transseptal puncture adjacent to the aorta, all my manipulations are going to be very, very difficult, particularly for mitral valve interventions. So I have to really stay away from this particular thing. And my LA appendage persons are going to be somewhere here or in the mid septum, and as I will be showing in the next slides. Well, we have talked about the various lesions which are now being used for transseptal puncture. Absolute contraindication would be a thrombus whenever I'm doing it. And of course, for distorted anatomies, huge LAs, aortic root, interrupted IVCs, there are the ways out. Whenever doing a transseptal puncture, hardware, anatomical landmark, and image guidance becomes very, very important. Hardware is a separate topic, and which will be discussed with Dr. Kavya, I think, is already discussing it. So and of course, most important is how we are actually starting off from the IVC. As I am keeping my plane from a 3 to 4 o'clock position, my catheter is actually pointing, my, as in this particular position, my catheter is actually pointing towards a septal plane like this. If LA is to dilate, I might have to go up to 6, 7, or 8 o'clock position. So actually to turn my needle more medially towards the interatrial septum. Now, for all of us doing BMVs, this is something which we have been used to. May write what happens in a RAO view. In RAO view, we are actually looking at something like this with a end-on orientation of the septum, so that my catheter is actually looking away from me. My end of the needle is looking away from me, and that is because it's almost an end-on of the septum as I come down. From a AP view, which is most of the interventions nowadays when are doing in for all the, even for LA appendage, we are doing an AP view guided by absolutely by echocardiography. And how it is working is, the problem kya hota hai? Problem is when you are bringing down your catheter, your needle is at times not visible in an echo. You say, oh, my needle, my indentation is not visible. How do you manipulate that catheter? There are only two things in AP view. Either you are going to move anteriorly, posteriorly. So that means a counterclockwise and a clockwise loop. A counterclockwise and clockwise loop is going to move you away from the aorta or towards the aorta. That means either you are going to come anterior or posterior, and towards the SVC or below the SVC. That means up and down, and that is going to make you whether you are superior or you are inferior. So this is what you are going to play in a AP view. We will be showing by examples on an echocardiogram, but lateral view, remember, is very, very important whenever you are doing fluoroscopic guided punches, because this is how the lateral view looks. You have come from superiorly, your LA is absolutely posterior. That means your needle is to pace posteriorly, and when the LA is dilated, it tends to enlarge like this, and the more down you might have to come, and you might have to actually vertically, almost puncture vertically. So same, the orientation of the septum in RAO view, in a LAO view, and this is how the orientation which we have seen in the previous slides. So we have seen how the anatomy is for a percutaneous intervention. So let's allow how imaging is actually trying to show it. For imaging, most of the time we will, the most of the experience has been with the TE and transthoracic echo. Personally, ICE, we have done just 2 cases, so not much experience with ICE. Initially, it is just transthoracic echo and TE which we have been using for all our transeptal punches. Whenever LA is enlarged, we have to go more 6 o'clock, 7 o'clock position whenever we are puncturing it, and might have to give a little more curvature to our needles whenever we are puncturing, as is being done in this particular case, vis-a-vis a smaller LA like this. Pressure monitoring is a very important step because it can actually tell you if you connect a pressure transducer as to how you have changed from LA to RA, from RA to LA actually. And this ICE is, so this is the most important slide of the whole presentation. How we do a transeptal puncture, particularly when we are doing a LA appendage closures. So what we are trying to do is, as Dr. Ranjan has beautifully shown in the previous case also, as we are trying to come down initially in a bicaval view, which is obtained somewhere between 90 to 110 degrees with a multiplanar probe, which we commonly use, we try to look for this particular indentation, and this indentation is actually pointing you that I am more towards the IVC in this particular case. Next, you go on to almost 30 to 60 degree view where aorta is an anterior structure, and this is going to tell you whether you are towards the aorta, you are more anterior, or you are more posterior. So here the indentation is much more posterior, and there you can see you are posterior and you are much more inferior, and this forms a very suitable site for a puncture for a left atrial appendage. Many a times the contour does not allow, and particularly when doing a mitral valve indentation, the height of the interatrial septum becomes very, very important, and a 4C view where you have to keep your higher puncture, and that means you have to keep almost 3.5 to 4 centimeters over the mitral plane, then AP view becomes a very, very important aspect when deciding for a mitral valve intervention. So this is what we discussed for LA occlusion. It is more important to have a room within the left atrium so that you can work around, so that the catheter can move slightly freely. So you would like to have slightly either at the slightly actually posterior, not exactly at this location, slightly inferior and posterior. And of course, many of the interventionalists would like to work in this particular area. For a mitral valve interventions, I like to go more higher, so that the delivery system should be 3.54 centimeters above the plane, and you could easily negotiate across the mitral valve. For a pulmonary veins, which are much more postero-inferior, so you need to keep much more posteriorly, and that is why your site of puncture tends to be much more posterior to the limbic area. Just to show how the indentation would actually look in a fluoride guided position. Beautiful indentation you see here, and another beautiful short axis view. This point, one point is very, very crucial. Once you are giving an indentation, remember there is a needle and there is a sheath. So what happens, you get that pop, and as soon as you withdraw the needle, you are actually not in left atrium, you are actually in the right atrium. So it is very important because it tends to spring back. So it is very good idea that you really give a good liberal tug at this point once you left into atrium. We had times where we actually thought we were punctured, but we were actually, the pop are actually given when we were in the right atrium. So this is the three septal view. One, the septal can be aneurysmal, or it can be very, very fibrotic. Fibrotic, we are very used to. We have BMVs, we're still doing in young age, but later ages as mitral valves interventions where the septum is quite thick, at times the trajectory, which has been discussed in the previous, becomes very, very important. The trajectory of the whole curvature, how it is looking at, how the trajectory is going, whether it's going to face the particular orientation which we have to. Say for LA appendage, I have to face the mouth. So whether my trajectory is going to face the mouth, by my trajectory for paravalvular, which is onto the freer side, whether my trajectory is going to face the free side of the LA appendage. So always look at the trajectory of the catheter once you decide your final point of puncture, and not just just the indentation site. This was a case which was done yesterday. This was a 67-year-old, severe MR, LV dysfunction, and the procedure planned is MitraClip. So one of the usual procedures any busy cardiology centers. But look at the patient, no? He has already had a CRTD. He had all those wire inside. We never really thought is going to give us so much, is it going to give us a trouble in visualization? But I'm sorry, I took it from the, can somebody play these videos? But look at the amount of, these videos were supposed to play. So this is so much extra noise which you see in the right atrium. So what actually is happening is we are not able to visualize the tip of the needle as we are coming down because of there was so much additional additional CRTD catheters which are actually inside it. So that times the puncture becomes very, very difficult in this particular scenario. If you can click on this slide. Yeah. So this is not the catheter. This is the lead. These are the ends of the leads. And we are actually not able to identify when the indentation is going to happen. So finally, what really helped to us, can you play this particular thing? The usual classical bicaval view and a short axis view are giving lot of imaging artifacts showing as if there is an indentation. There is hardly an indentation here. What really helped us is going into almost a 4C view. And there you see the view which you normally do with mitral clip, and you see the height where you are puncturing. This particular view actually showed up the real indentation where we actually helped us puncturing. So at times with dilated atrium, with additional wires into the CRTD wires into this, the classical bicaval view and the short axis view may give you so many artifacts, and a 4-chamber view or a modified view might actually give you that particular indentation we are looking at. So once we are talking of 9 out of 10 cases which will help you out, but at times you might have to modify, particularly in these scenario patients. Coming to complications and last part of the presentation, well, Echocardiography is so important. Why is it so important? Not just the presence of the procedure. The echo machine is important because pericardial effusion and tamponade, echocardiography will fit. RA or LA needle puncture, you have to be careful because you have to see whether the collection has happened. The aortic puncture perforations, air embolization, aortic perforations, in and doubt whether you are not there, just give a contrast, hand contrast, air contrast, and you will see some bubbles going, and you will identify, okay, where you are. So that air contrast can help you guide. Of course, then uh, otherwise, transient ST elevations and persistent ASDs are, of course, echocardiography is going to help you out. So one must learn pericardial synthesis when doing a transseptal puncture is a rule. Although the mortality is now low, and particularly echocardiography, it has become much more safer, but pericardial synthesis is actually one should be prepared. Vena cava perforations, coronary artery dissections, detection of adaptation of the sheath, and acute pericarditis are some of the other complications. To conclude, why an echocardiography in cath lab? Because it is very important for planning. To define the anatomy, to look at the potential risk and the associated comorbidities. The procedure itself, because you visualize the needle, and that makes the procedure very, very safe. Unlike BMVs, where we were so struggling, at times we were actually worried about effusions. T guidance makes it very, very simple. Diagnosis and management of complications such as pericardial effusions, residual ASDs, and cardiac perforations, we can just give a whiff of contrast echo and help you guide all these things. So to conclude, understand the anatomy, know your fluoroscopic landmass, use TEN's IC. It's not that when you're doing a transthoracic T guided puncture, you don't have to use a fluoroscopic guidement. That you can always rely upon. Be prepared to deal with challenging anatomy and be prepared to deal with complications. Thank you.
Thank you, sir, for such a lucid talk. I have one question. In LLA appendage closure, you need to go posterior. So how much posterior is safe enough? Because many times you go too posterior and you land up in stitching up. So what's the echocardiographic landmark?
So what two things we have to see, which was we discussed in the previous case also. It is not just the puncture site, which is very actually important. It is the trajectory of the catheter also, which is important. Ultimately, if you are planning the lambre, or you're targeting the mouth or the body, watchman here in the body, that is what is your target? You have to identify. If you have to target the mouth of the trajectory, you have to look for the site of the puncture and the trajectory of the catheter, which is very, very important. This is what you.
No, I wanted to ask how much posterior we should go. Like on it, is it safe?
And particularly with the availability of deflectable sheets, edgely sheets, things have become much more comfortable. At times, we were initially struggling with all this, but after these sheets, the not just for LA, for other left side interventions, the presence of these sheets actually you can overcome this. In case we are not really able to move it, we only shift the sheet, take another sheet, park our pigtail into the appropriate place, and actually exchange with the appropriate sheet again.
So we'll go to our next talk, which is by Dr. Shai Satish sir, difficult transeptal puncture.
Yeah, I'm filling in for Dr. Sai Satish as he is not able to make it today. So thank you very much, chairpersons and the panelists. So I think to answer whose question, how posterior, usually you start at 3 o'clock, but by the time you track it down, be around 4 to 6 o'clock. You don't have to go beyond 9 or 10 o'clock. That's how much posterior you can go. But if you're going beyond 9 and 10 o'clock, just remember that it'll actually maybe go back and you can start hurting the patient. So it's not too posterior beyond 9 or 10 o'clock. So difficult transeptal puncture is the talk that we have today. So atrial septum has become a hot real estate, right? Everybody wants something to do with the atrial septum. So many device companies are actually spending huge amounts of money, whether to cross the septum or to keep it open, right? So now atrial septal punctures are done for various implantation of devices, and as well as treatment of heart failure. We created an atrial septostomy now for heart failure with the preserved ejection fraction or with reduced ejection fraction. The trials are ongoing. So septal puncture definitely opens the door to the LA, and precise puncture can be done with imaging guidance, as we just heard. And safety drives innovation, and new devices emerge frequently. So the first thing is transseptal puncture, the appropriate location, and it determines the success of the procedure, what you're trying to do, for what procedure and where do you want to be, right? For mitral clip, as we just talked about, you have to have a good height. For degenerative MR, primary MR, you want to be 4.5 and above. And for secondary MR, you could be about less than, above 3.5 and less than 4 is also acceptable. If you're too posterior for left atrial appendage occlusion, it is going to be really a headache. And so you have to be, in our own experience, better to restick and be actually inferior is the most important. You have to be as inferior as possible, because that actually a nice trajectory you will form. And actually it is either don't be too anterior, but at the time don't be too posterior. Mid is okay for these, most of the left atrial appendage occlusion. So this is from my previous partner, tips and tricks and pearls for transseptal success, where you want to be. And so for PFO closures, you can be superior. For vein procedures, it's, I think earlier they said posterior, but depending upon which veins you're accessing. And actually, when I go back, I have to do a pulmonary vein venoplasty. We have already done. Now I have to do a stent because PVI procedures created a stenosis in that patient, and we have to bring him back for a redo. And so mitral clip is posterior in the fossa. And all septostomies for heart failure, they are actually mid. And for transcatheter mitral valve replacement, you can't be too posterior like mitral clip. So even with that simple mitral valve repair with mitral clip, mitral valve replacement with a valve-in-valve or valve-in-MAC, there is a difference. So the subtle differences, maybe just one from 9 o'clock to 6 o'clock makes a huge difference in those patients, and how much you struggle afterwards. So and you might have to, sometimes you cannot get the valve into plane in the mitral valve. So you have to do an, I mean, obviously some of you have done now transapical puncture and to snare the wire and create a rail. So all that could be avoided if you spend time on the transseptal puncture. And for left atrial occlusion, so this is more of infero slight posterior, not too much posterior. So CT planning will help in the future. Exactly, this is what my imaging cardiologist will tell me exactly. This is where to stick. I said you're not in the lab, but the problem is actually CT fusion or overlay is going to come up. So this image, exactly what he tells me where to puncture, will be visible on my fluoroscopy. So when you drag it down and with overlay, Philips has that as well, and every other companies, it'll tell you exactly where to puncture for left atrial appendage occlusion. For mitral valve, it may be different. So these are the usual ones that as you want to be a little bit superior and posterior, that for mitral clip, just because the device is constructed in that way. All those knobs that we do, anteroposterior, medial, lateral, is because of the device. Maybe a newer device might have a different ways. Like we are using Pascal. They don't really care where exactly it is, because it has a very different way of actually rotating and flexing the knobs. And so here is one of the cases that we just did. That was my fellow, and I will avoid the noise. So thick part of the septum, we are doing an ICE-guided left atrial appendage occlusion. So we could only see a small part of the fossa where we could not actually poke because it is very small part, and we had to stick in the thicker part of the septum. So when you stick the thicker part of the septum, obviously we have some difficulty. I don't have the controls to move it faster. So anyway, please bear with me, and I'm just playing with both, usually because my first year fellow, for structural fellow within 1 month, and an interventional fellow in the first month, so he doesn't know how to do the ice. So I'm playing with both the SL1 and BRK needle, and I'm adjusting the ice with the other hand. And the echo tech who is in the background, she is telling me where my needle should be or should be. So now I'm asked him to help me out and hold it, and so that you can see there's tenting, but I'm not able to poke the BRK. In people with the mitral stenosis, you guys don't really care because the huge left atrium, you're not going to make a free wall puncture with the transseptal.
But in people who have smaller atria, and there are two types, thick septum or floppy septum. These two are both the problems. Floppy septum will keep on going, and then when you poke, you might poke both the septum and the free wall, and the patient will bleed. The patient bleeds because of two reasons earlier host was talking about. We give 10,000 units of heparin. I give 100 units per kilogram body weight heparin when I'm on the right side itself. I don't wait until I go on the left side. So when I puncture, the patient will start bleeding, and when the procedure is completed, the patient now will become hypotensive. So even a small puncture will bleed profusely. So this wire is called a safe sept wire because I'm not able to stick properly, stick comfortably. So what it is actually is just like a coronary wire. So this safe sept wire is very slightly expensive. So I said, okay, next time let me try a regular BMW wire. It goes through the BRK needle. If you're having a difficulty in pushing it, don't push it. Just put a BMW wire and it'll go in, and wherever it goes into the left atrial appendage or even pulmonary vein, it is fine. And then track the needle and the SL1 or Mullins over that short 018 wire. It'll go that very easily. Okay, so once that is done, then you don't have to worry about it. It'll track easily over the thick part of the septum. I tried injecting bubbles to see if I was on the left side, and I wasn't. So I used that wire. Once I'm in the right position, you can just take it out. Okay. So otherwise, if you can expend, this is about nearly, I think, $1,800. Okay. Versa Cross, now which is bought by Boston Scientific. It is a radio frequency wire. It's still, I don't use it because I'm cheap, and it's very expensive compared to $300 for a SL1 and BRK needle, and this is about 1,800 or so for us. And so, but occasionally I do use it, as you see in this patient. So there's a pigtail type of wire, and it goes all the way into SVC. Then you bring it back, and the tip of the wire has a radio frequency energy that you can deliver. It's actually much nicer and smoother to stick with this rather than trying to advance the needle. And for younger people, I think this is much easier if you have not done more than 10 transeptals. And I think this is much easier and very less risky procedure. So, and once you puncture, you deliver radio frequency energy over 2 seconds, and then you can advance the same wire into the left atrial appendage or wherever it sits in the free wall. And because it is less traumatic of the pigtail, and you can remove that and change that over whatever sheath that you're putting, whether it is mitral clip here or a left atrial appendage closure 15 French sheath, you can go with that. So the height of puncture, as I mentioned, it depends upon different devices, and everything is, we talked about that. So in some part, you crossed, sheath won't follow. So these are another thick part of the septum. Whatever you do, the sheath will not follow. So number one, hopefully you have a longer, you made the stick, and you at least got the needle across, and then you exchange the needle over, over the sheath. You were able to advance the sheath over the needle and pull the needle back and have a stiff wire, 032 or 035 wire. Then you're okay. What if you're not? If you're not even having that, I would say that keep the BMW wire and remove the needle, put a multi-purpose guide catheter. Through the guide catheter, put a 2O balloon, coronary balloon, and just like how we use the BAT technique or balloon-assisted tracking, you try to do with the balloon-assisted tracking in the atrial septum. If it goes, it's fine. If it doesn't go, then obviously you have to restick. Okay. So the other one is in case if you have an 032 or 035 wire, if it doesn't go, use a dilator. Take the sheath out, SL1 out, and put a dilator, and try to dilate it. If you have probably, for us, opening a dilator is very expensive because Inouye, the Torre Inouye balloon, that's the only place where we have a dilator, transeptal dilator. For you, probably transeptal dilators are available as a separate one. So I don't do that often. That because it's cheaper for us to take a peripheral balloon and we balloon it. What if septum is thick? Here is a dilator. You can use that dilator. If the dilator doesn't work, and you can, once the dilated, you can follow that. But if the dilator doesn't work, and then you actually use a peripheral balloon. The peripheral balloon can be of different sizes, and I at least start with 10 millimeter balloon. Or you can start at 6 millimeters as shown in this picture. It depends upon how big of a hole do you want to create. If it's a mitral clip, or if it is transcatheter mitral valve replacement, you want to go with the 12, 14, even up to that. So you have to do that anyway. If septostomy has to be done. If it is mitral clip, usually I use like 10 millimeter balloon. And if it is just for, I think, left atrial appendage closure, occlusion or closures, 6 millimeter will be enough. Don't don't be very shy. Just make sure that it dilates and keep it there for a couple of 40 seconds or so, and then that should eliminate any difficulty in doing that. Do we need to close it? Now there's lots of studies that came out that in mitral clip we leave ASDs up to 8 millimeters alone, and we don't have to close it. So I don't think we need to close it. Okay. So my take-home message is septal puncture can be done in many ways. In difficult cases, we can use a coronary wire and advance the needle over the wire along with the sheath. And otherwise, you can put a dilator or a balloon tracking technique, and if not, actually do a septostomy itself. And ultimately, small point is don't push. If something doesn't want to go, stop. And maybe you can use imaging guidance and maybe restick again. Okay, so I think that is the most important. So, and earlier I was telling in the session, when any real progress is made, we unlearn and learn anew, and what we thought we knew before. Okay, so don't be dogmatic. And actually, when I came to here in the beginning, and I was trying to train for mitral clip, and they said, no, don't worry about transseptal. We know transseptals. I said, I know you know transseptals, but that's different. This transseptal is different. So, it takes some time for people to be convinced and to have success. Thank you very much. Thank you.
Use the mic.
Here with only fluoro, when you were doing it, do it.
Mic on karo.
We used to do with just fluoro, and in the 2005, we were doing a lot of balloon mitral valvotomy. We were just doing it with the septal delineation technique. From the aorta to this one IVC left lateral view, we used to give an injection, and in that superior and inferior was very easy. So with that, the complication of septal puncture was almost zero. But this anterior, posterior, and other things for mitral valve and LA, this can be done better with TE. But usually for BMB, when we are doing it, we are not using any TE, because with TE, the procedure becomes so much longer, and otherwise, with that septal delineation technique, you can puncture the septum very nicely at appropriate. We published 85 cases in Indian Heart Journal 2005, but it was not in fact, presented in so many conferences. But that is very, in fact, direct septal puncture on the septum. So that can also be done when this TE and other things are not being done.
No, I mean, absolutely. With BMV, there's no much risk, because what you are already doing it is you're not using too much heparin, and you don't really want to keep devices for too long. You're probably the BMV time itself is maybe takes 10 minutes or 15 minutes for you. And so that's a shorter time duration, less amount of heparin, the complications are less. Here, the devices are large. The BMV balloon is what, 10.5 French? And probably, so now we are talking about 15 French, 18 French, and 24 French for mitral valve. I think those are the ones that actually probably increases so the hole is bigger, the duration is longer. My first mitral clip ever I did in 2009 took only 45 minutes. I even received the phone call from Fred Saint-Gore, who was the one who invented mitral clip. And the second one took 4 hours. Same day. 45 minutes one, and second one took 4 hours. So you have, now it's back to 45 minutes, but usually it takes a long time to do these procedures. So don't be shying away from heparin, because thrombus will form. And one of my colleagues actually, while doing left atrial appendage closure, a 15 French sheath, nothing was flushing. And he was worried what's going on. And so the entire 15 French sheath had blood clot. Okay, so it's like the
Ramesh,
duration is longer.
good talk. Like our knowledge and expertise should not be restricted to BMB only. Now it has progressed from BMB to your mitral valve therapy, even your atrial stent. If you really want to put AFR, you have to know where to puncture. It has to be exactly in the middle. So this stent or shunt is put for HEPEP exactly in the middle, and sizing it's very important. In our hospitals, we have learned from PGI that it can be done without anything. It blindly can be done, some experts, but it's better to have T as a safety. Now, if you cannot puncture, like if you have ASD patch, if you have ASD thick patch, then you have to use the cautery. So how do you do the cautery? You put the needle, you push it, and 30 watts, 30 to 35 watts at the back end of your needle, you can puncture easily. Some people use this BMB jalebi wire, you know, that round wire, and they put the Mullins dilator. The problem with this jalebi wire, you cannot exchange with your that small, I mean the short leg of the wire, wire, you cannot exchange with your sheath. So you cut the JR or multi-purpose to half, then you push that multi-purpose inside the LA, then you put this thing stiffer wire, then you exchange. So jalebi wire is not the ideal for LA closure because
No,
you
the
don't have
jalebi wire is available in two lengths. So
in our country, you cannot exchange.
Pardon me?
It is not exchange length.
No, it is. That's what I'm trying to tell you. So jalebi wire, the ProTrack is the company that makes the wire. It's available in 260 centimeters and 180 centimeters. So obviously, I also had an experience of actually doing the same thing here. And I said, okay, let's exchange.
Okay.
And so that it's not available.
No.
So anyway, I think we're running short of time.
Thank you, Ramesh. There's a small announcement. The Chief Minister has come, so you have to stop here. We have to go for the inaugurations. That's a request from the organizers. So you'll go for the Ranjan? Yes, please. Chief guest. Chief Minister.
We will now be starting the formal inaugural function. A very good evening to one and all. I, Dr. Sneha Karekar, Resident Department of Cardiology, Manipal Hospital, Bangalore, on behalf of the Manipal Hospital and Department of Cardiology, welcome you all to this grandiose event. We all stand here today at the brink of something extraordinary. We are honored to have you all as guests on this occasion of inauguration of Left Atrial Appendage Closure Summit 2024. It's the first conference in India which is being held. I now request our chief guest to come up on the stage, Dr. H. Sudarshan Balal sir, Chairman Manipal Hospital and Senior Consultant Nephrologist, Mr. Dilip Jose sir, CEO Manipal Hospital, Dr. Manish Rai sir, Hospital Director, Manipal Hospital, Bangalore, Dr. Ranjan Shetty sir, Consultant Cardiologist and Head Department of Cardiology, Manipal Hospital, Bangalore, Dr. Ramesh Dagubati sir, Director, Structural Heart Disease and Associate Cardiology Chief, West Virginia University, USA. I request all the dignitaries on the stage to perform the lighting of the lamp, symbolizing the dispelling of darkness and victory of knowledge over ignorance.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि.
I request Dr. Kavya Malikarjun ma'am to come up on the stage.
राजेशानाय भानुचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय
Thank you, all the esteemed guests. I request all of them to take place on the stage. Now, as we proceed further, I invite Dr. H. Sudarshan Balal sir to share a few words about the occasion.
A very good evening to you, ladies and gentlemen. Please pardon my hoarseness of the voice. I'm just unable to kick my cold away. I'll make sure I don't infect you. That's why I'm at a distance. Our dynamic CEO, Mr. Dilip Jose, Director of the hospital, good friend, Dr. Manish Rai, Star of the Day, Dr. Ranjan Shetty, our proud alumnus, Dr. Ramesh, distinguished guests, ladies and gentlemen. I'm not very sure of what I'm supposed to speak. However, I can never say no to Ranjan. So I'm here to say a few things. If it makes sense, fine. If it doesn't, please excuse me. I've always found cardiologists to be a very smart breed, much better than the nephrologists for sure. And we're one of the first few specialists to embrace technology in a big way. And the use of transcatheter valve replacements, aortic stents, impeller device, innovative pacemakers, which are like the Spider-Man, stick onto the heart without needing the surgeon. And to a large extent, they've made the cardiac surgeons extinct. So no one wants to take up cardiac surgery now. About 60% of the seats in MCH cardiac surgery is gone because of people like Dr. Ranjan Shetty. So that's where we were. And I always curse my fellow nephrologists for not getting into interventional nephrology earlier. We could have sort of made the urologists extinct. Be as it may, that is too late. So it's a privilege for me to be here at the Left Atrial Appendage Closure Summit this evening. Atrial fibrillation was something that was always kept as a long case for us in MD medicine. You had to find the irregular pulse, so on and so forth, the difference between the pulse and the heart rate. If you didn't find that, your examiners were sure to fail you. As you're aware, it's a very common ailment in the elderly, has a high risk of thromboembolic stroke and needed lifelong anticoagulation, which is fraught with grave risks of intracranial bleed in the elderly population. However, technology has come to the rescue of these patients with the LA appendage closure device, about which this conference is, which when used appropriately mitigates the need for long-term anticoagulation. We are fortunate to have Dr. Ranjan Shetty, Dr. Ramesh and others with us today who are experts in the field. And I would like to congratulate Ranjan, Dr. Ramesh and the team for organizing the summit to enlighten us about this field. I wish this function every success. God bless. Jai Hind.
Thank you, sir, for your insightful speech. You have always been a pillar in planning and execution of this conference. I now invite Mr. Dilip Jose, sir, to share a few words.
Dr. Sudarshan Balal, our chairman, Dr. Ranjan Shetty and the organizing team, my colleagues from the Manipal group, and of course, the wonderful participants what we have today. I believe over 200 cardiologists are there in the room, and it's wonderful to see so much of participation. I know I'm one of the few people in this room who would not consider time, without a catheter in my hand is a wasted time. I know I'm one of those rare guys in this room who feels that. And to be honest, till Ranjan came and talked to me about, I did not know I had a left atrial appendage. I had to actually look it up. Yes, I do have one. Is that I figured out then. And But on a serious note, it's incredible that 200 cardiologists came together on a Friday and Saturday to learn on such a specific topic. I think that gives a lot of hope about the future, because every one of you is already an accomplished cardiologist. Every one of you have put in several years of training and actual practice. And if many of you feel the need to assemble, watch a procedure, attend a live workshop, and talk to each other, and on such a specific topic, I think that gives a lot of hope for Indian healthcare. That, I think that is the first thing that I wanted to say. Secondly, irrespective of what hospitals do, Manipal Hospitals is probably the largest hospital group in the country today. But that size is of no meaning if we are not able to deliver the highest order of care to our patients, each and every patient that we come across. Therefore, being up there in terms of our preparedness, in terms of our capabilities and skill sets, I think that that's the most important thing that a hospital can aspire for. And as the clinical team, the core of everything that we do in the hospital, if we all feel the need to train yourself, I think that's a fantastic thing to happen. And I just wanted to wish you all the very best over today and tomorrow, the wonderful workshop that you have. A lot of faculty who have traveled from all over the world to be here. I wish you 2 days of learning, 2 days of making friends and catching up with old friends. And thank you, Dr. Ranjan Shetty, Dr. Ramesh, and others, and the organizing team for putting it together. Have a wonderful conference, and God bless you all. Thank you very much.
Thank you, sir. We now come to the end of this inauguration ceremony. It was heartwarming to see all of the dignitaries, young cardiologists, and students reveling in the new opportunities. To bring this ceremony towards conclusion, I thank all the dignitaries on the dais. I request Dr. Manish Rai, sir, to say a few words.
Good evening, dear friends. And I think it's almost operatic that it ain't over till the fat lady sings. But a huge thank you to our dear seniors, Dilip sir, Dr. Balal sir. They are the guiding lights for the Manipal Hospitals Enterprises Private Limited. And I would reiterate that we are the largest hospital group in the country. And Manipal Hospitals, Old Airport Road, where I work, this is the flagship hospital of the group. And we are extremely proud and privileged to have star clinicians like Dr. Ranjan, who are associated with us from many years. I know Ranjan right from the time that he was doing his MD medicine in AIMS, and then DM cardiology from Chandigarh PGI. And he is an exceptional teacher. My dear friend Ashish is there amongst all of you. He used to teach students on how to read ECGs. And even now, for our referral physicians, he does that. So please enjoy his company. Thank you so much, Dr. Ramesh, for being part of the organizing group. And I'm really proud that we have a full house today. And huge thanks to the organizing team. Wishing you happy learning. Thank you. Thank you.
I thank all the dignitaries on the dais for their valuable time. I wish all of you have a great time, great day ahead today and tomorrow. Hope you all have a good time and acquire immense knowledge about left atrial appendage closure at the end of this conference. Also, I wanted to say that for Dr. Ranjan Shetty sir, I think this is an inception of dream, a step towards progress, and a landmark moment he has been waiting for. Thank you, one and all. We now continue with the second session.
We're going to resume with the second session. I would like to invite the moderator, Dr. Edwin Francis, chairpersons, Dr. Rohit Manoj Kumar, Dr. Chandramani, the panelist, Dr. Bhushan Shah, and Dr. Sham onto the stage. The next presenter for session 2, Dr. Kavya Mallikarjun.
Dr. Kavya, you may proceed with the pre-procedural evaluation, 2D evaluation for LA closure.
Thank you. A very good evening, one and all. I'm actually happy to see so many pediatric cardiologists in the group because I am a pediatric cardiologist basically. So I'll be discussing about how do we image the left atrial appendage prior to closure. So this is a brief overview of today's discussion. These slides we have already seen in Dr. Murali Krishna's talk, so I'm not going to elaborate too much on the anatomy, except that the 4 types which are commonly seen are windsock type, cactus, chicken wing, and cauliflower. And the chicken wing is supposed to be the most difficult one for a device closure, and the windsock is supposed to be the easiest one to do so. So this is in brief about the anatomy of the left atrial appendage, along with this is the ostium of the appendage. The landing zone, the distance between the ostium and the landing zone, this is called the neck of the appendage. Briefly, the transition from the smooth part to the trabeculated portion, that is where most of the device measurements are taken for positioning of the device. Device specific measurements, I'm not going to be talking on this session because we have separate sessions for that. So we'll be dealing with each device individually in the next coming sessions. So this is about how do we go about assessment on initially transthoracic echo, a very brief one, and then majorly transesophageal echo. So we have to assess the complexity of the internal anatomy of the left atrial appendage and its relationship to the surrounding structures, evaluate the ostium size and shape, the most important part, morphology of the appendage. Basically morphology, rather than defining chicken wing, cactus or cauliflower, it's important to see how many lobes the appendage has and how they are oriented, what is the distance between the 2 lobes, and what is the depth from the landing zone. These factors are more important rather than anatomical definitions of these appendages. Detection of either thrombus or probably pre-thrombus. Characterization of flow velocity using pulse wave Doppler. And in transthoracic echo, we can add harmonic imaging, which can improve imaging for and detect presence of thrombus formation. Contrast imaging can further enhance our imaging in transthoracic echoes and Doppler studies. Most important in imaging is transesophageal echo, both 2D and 3D. 3D, Dr. Satish Govind will be speaking on after mine, so I'll be dealing only with the 2D imaging. And contrast transesophageal echo. ICE guided, we don't have much experience because we do all TE guided procedures. So in transthoracic echo, basically parasternal short axis view at the level of aortic and pulmonary valves. Apical 5-chamber view with upward tilting of the transducer and apical 2-chamber views. So visual inspection of the appendage, assessment of thrombus by complete, this is on transesophageal echo. This is a complete sweep. Though we say it is at measurement is at 0, 45, 90 and 135, it is better to do a complete sweep from 0 to 180 degrees. LAA volumes and ejection fraction, more of theoretical interest, but we don't routinely incorporate these measurements during appendage device closure. Coming to color Doppler, color flow imaging again is very valuable in assessing for a thrombus. Suppose we have doubt of thrombus, but we are not very sure about this, we can reduce the Nyquist limit, adding color Doppler so that the areas are filled on color Doppler. So if that happens, obviously it's not a thrombus. So color flow Doppler imaging can reveal areas with decreased or absent color flow within the appendage, which is highly suggestive of thrombi. Again, coming to the views, most important are these 4 views: 0 degree mid-esophageal view, 30 to 60 degrees short axis aortic valve view, 80 to 100 degrees, 130 to 180 degrees. Device sizing is crucial to device stability, as we saw in challenges which Dr. Host presented. So again, most important in all these is the 30 to 60 degree measurement and the 135 degree. It is important to achieve optimum sealing of the ostium and minimize the risk of leak. And this, if there is significant leak, this again adds a new source of future thromboembolic events. So this is where the transesophageal TE probe is going to be positioned in the esophagus, and the plane of imaging extends. We can see that there is mitral valve and aorta in this plane of imaging, and this is in the other view. So see, we can see many structures around the left atrial appendage which are important when we are actually imaging it on TE. So these are the imaging planes 0, 45, 90 and 135, and these are the images how they look in each of these views. So these are the actual images at 0 degree. This is the appendage, the left circumflex. This is the pulmonary vein ridge, or what we call the Q-tip or vein of Marshall. This is at 45 degree where it is better profiled, and 90 degree again at 135 degree. 135 degree is sometimes very difficult to get on TE. So we can take a 45 degree and explain it so that we can look at the 135 degree. But this is a very good view to look at the additional lobes of the appendage and also presence of thrombus. The best view for device sizing, I would say, is 45 degree, wherein we take from the circumflex artery towards the about 1 to 2 centimeters inside the ridge towards this side. It's a little different for Watchman, and Amulet and Lambre devices are almost the same way that we size them. The measurement what we take in 45 degree, the depth is best assessed in this view, and the width or the size to be chosen for device implant is best assessed in 135 degrees. So this is at 0 degree. As I told you again, 0 degree, it may be a little suboptimal imaging, and we are putting color Doppler to assess for any. We look at the pulmonary vein flows, detection of mitral valve regurgitation pre-procedure. Before planning an implant, it is important to have a baseline echo looking at the mitral regurgitation, the pulmonary venous flows, and any presence of any pericardial effusion, because if there is a new pericardial effusion, it's difficult to say whether it is procedure induced. So baseline, we should always have a evaluation of these factors. And this is on, and always remember to reduce the Nyquist limit to optimize the pulmonary venous flow and the LA appendage flows. This is at 45 degrees, wherein we see this is the measurement that is taken for Watchman device. So this is the circumflex, the landmark from where we draw a line towards the pulmonary vein ridge about 1 to 2 centimeters inside. And from the midpoint, we take a perpendicular line to the apex of the appendage. And this is most often the best view where we can get the optimum depth of the left atrial appendage. This is at 90 degrees view. Again, we take measurements in multiple views. We can see the trabeculations. Also, the number of lobes can be better assessed in 90 and also 135 degrees. And here we draw a line from this circumflex here, and then this is mainly for Watchman device. And this is at 135 degrees. And also this view may not be the best one to look at the depth of the to assess for the depth for device positioning. So best done in 45 degree, but measurement at 135 is taken to assess for the size for Watchman device. The other devices, Amulet and Lambre devices, it's usually an average of all the 4 measurements that we take, but for Watchman, it is what we see in 135 degree. Sometimes if we have difficulty in getting 135, we can take a 45 degree and explain. This is also called the implant view. Once we are in this view, we can guide the operator, the intervention cardiologist, towards the position of the sheath, and later on during device positioning, where exactly how far inside the appendage he or she is. So these are some of the landmarks we look at. And this is in 135 degree, looking at the anterior and posterior aspects of the appendage, and in 45 degree, looking at the lateral and medial aspects. And this is the circumflex, the pulmonary vein ridge, or the Q-tip, or the coumarin ridge, what we commonly call. And as I mentioned, these are few landmarks. This is the circumflex, pulmonary vein ridge, and the appendage. Again, coming to pulse wave Doppler, this should be ideally taken at the mouth of the left atrial appendage at its entry into the left atrium. So most important velocity is the left atrial contraction velocity, which should be between 40 to 80. Anything less than 40, increased risk of spontaneous echo contrast. Anything less than 20, more likely there is going to be a thrombus there. We can add tissue Doppler imaging, strain imaging, and using ultrasound contrast enhancement during TE, but these are little time consuming and not routinely used during procedures. Again, transeptal puncture, we already know we need to be at the posterior and inferior part of the interatrial septum. I'm not going to, Dr. Neeraj has already discussed about this. This is because the coaxial device deployment can be best achieved by a posterior inferior septal puncture. And these are some of the landmarks. We see SVC, the catheter coming down, dropping from the SVC towards the interatrial septum. We need the transeptal puncture somewhere in this area. So this is the following the needle from dropping from superior vena cava downwards, and this is how the person performing the echo can guide the intervention person. So this is on bicaval view. We can see the tenting. This is what all speakers were mentioning. The tenting should be seen in bicaval view and then switch to 45 or add biplane imaging to look at whether it is further from the aorta. Ideally, it has to be away from the aorta, and when the person is actually, the interventionist is actually puncturing the septum, it's better to be in this view if we are using only single plane imaging. It's always better to do it in 45 degree. And this is the transeptal puncture with the catheter in the left atrium. And after that, as Dr. Ranjan said, we always do exchanges in the pulmonary vein. So this is how, using biplane imaging, we can see the catheter in the pulmonary vein. And then from pulmonary vein, we can guide them to get it into the left atrial appendage and position the catheter. The pigtail catheter can be used at this stage, and a small angiogram, if required, can be done to exactly size the appendage, and also to look at additional lobes. Sometimes TE can miss. That's where the advantage of 3D TE comes in. So this is how the catheter should be positioned during device deployment. It has to be ideally coaxial. This should not be too lateral or too medial, because the device can have either lateral or posterior shoulder, and which is not acceptable. So it has to be ideally in the center of the appendage. So these are some of the devices we use for closure. The most commonly used ones are the Watchman, the Lambre by LifeTech, and the Amulet by Abbott. So this is very briefly about how do we size for Watchman from circumflex towards this and the depth. Device should be about 10 to 20% larger than the diameter of the appendage. And this is for Lambre. This is the ostium of the appendage, the landing zone, and this is actually the neck of the appendage. So the device size is chosen according to this measurement, and this should be 3 to 8 millimeter more than the measured landing zone. This applies both for Amulet and Lambre devices. So this is post-procedure. The procedural guidance for Watchman, what are criteria to be checked, will be doing it in the Watchman Symposium, Lambre and Amulet, subsequent sessions. So this is very brief to say, if any leak which is more than 3 millimeter is there on this post-device deployment echo, then it's not acceptable. So anything less than 3 millimeter, we accept it and release the device. So finally, to summarize, it's important to determine the size, lobularity, and shape of left atrial appendage to guide device size selection. Suppose the appendage is very short, it doesn't have too much depth, then a Watchman may not be a good idea. So we may have to choose an Amulet or a Lambre device in those circumstances. So guide transeptal puncture, a very important step in this situation, because the puncture has to be inferior and posterior. Verify the position of delivery sheath in the appendage, guide delivery and deployment of the device at the ostium, and assess position and ensure correct orientation of the implant relative to left atrial appendage wall. This is what is coaxial deployment. Then check for leaks around device using color Doppler before final deployment. Check for disruption of transmitral flow. Any increase in MR is not a good thing. So we need to check whether there is compression of the circumflex coronary artery. Check for disruption of pulmonary vein flows. Great success of occlusion post deployment. This is based on the device residual leak around the device. Anything less than 3 millimeter for lamprey and amulet, anything less than 5 millimeter for Watchman is acceptable. Check for device migration and instability post deployment. And most important, screen for hemopericardium throughout the procedure. This one, we need to check for device evidence of thrombus formation around the device, more common with Watchman, where the threaded insert can project and a thrombus can form on that system. So most importantly, I would like to emphasize three-dimensional TE offers a real-time comprehensive imaging modality, which we are going to be discussing in the next session. Thank you very much for a patient hearing.
Thank you, Dr. Kavita, for an excellent presentation. Basically, this is the most important thing before planning a LA closure, because a proper evaluation of the LA appendage, not exactly the structure, but the landing zone for the amulet and the lamprey devices, that is most important to avoid a complication. And the use of explain more often may give you more information. I think, any more questions?
Next, we call upon Dr. Satish Govind sir for a talk on 3D echocardiography in LA appendage closure.
Yeah, good evening to all of you. Many congratulations to Ranjan, I think, for stitching up this great show and putting the left atrial appendage on a much bigger scale on the Indian structural heart map. So after a wonderful, I'd like to talk about the 2D and how it helps in the appendage closure assessment. So 2D is the mainstay, and if I have to use the 3D, it's more like a supplementary supportive act. But it is a growing area where a lot of data is coming and how useful it is going to be. So let me sort of walk you through how 3D is going to be useful in the appendage closure. So we have had enough sort of slides on the types. So just briefly, updating you about a little more. So you have this chicken wing itself. So you have the chicken wing which can have an early sort of bend, or it can be a little lower down also. So the one which is very early in the bend, so that is the one which will be posing a lot of technical challenges, and it has a lobe. And the windsock is one smooth, long, dominant lobe, while the cactus will have a single dominant lobe and multiple smaller lobes. While the cauliflower doesn't have any dominant lobe, but it will have smaller lobes spread all over. So these are sort of some of the characteristics as far as the different types of appendages concerned. Now the assessment itself. So when we talk about 3D, we generally talk about the 3D data set, but there's also some part of the 3D probe which is less used, but I think has its own value. So use of the what is called as the X-plane or the biplane. So starting from the 0 degrees, which we start off with, and then you see that the second image down, the frozen one has the reference image is at 0, but what it gives you is a orthogonal 90-degree image, which is on the opposite side. And as you keep going forward, so you come to the 45 degrees, and typically again it gives you at 45 degrees, it gives you the 135 degrees. So very early on, if you're going to use the X-plane, you already know what's going to happen as you keep going through the different angles and how the
appendage looks like from the different cuts. And this again, as you go further down, this is 90 degrees. And then again, with the explain, you can see that you start to sort of relook at it from a reverse direction. So now you're sort of going all around it, and then you're sort of making a very thorough sort of investigation. And finally, you end up with the 135. And this again, you're back to sort of 0 degrees in the opposite, the other image which is seen over there. Now, when we talk about 3D, this is the classic view. It's a very familiar image to all of us. You have the aorta at the top, the surgeon's view, and then the left atrial appendage, the AML, PML is there. And then we have the appendage which can be seen from the side and which can be seen from the cross section also, where you see the ostium over there. When you look a little closer, so when you start to have the cross-sectional view, so you see the appendage ostium over there, and then the left upper pulmonary vein also can be seen in the close proximity, and then the coumadine ridge is also seen. And now you have these different type of imaging modalities, what is called as the photorealistic or the true view or the light source, where you can see it. And the one below shows the color over there. So you can have a very sort of detailed and a very sort of anatomically sort of understandable view of how the appendage looks like. And this is again, an actual anatomical specimen where it has been electrically activated. How the actual sort of the structures look like. You can see that the orifice of the pulmonary vein and also the appendage also, and in between you have the coumadine ridge. Now, there are some structures which are adjacent, which we have to be careful of. So the mitral valve is there, and then you have the circumflex. Now, when we take the 3D itself, so this is again a 3D which is available to us right now. So it is with most of the vendors. So this is what is called as the true the light source or the photorealistic view. So here you can see that the structures which can be identified by 3D, you have the left upper pulmonary vein there, the appendage in the center, the circumflex somewhere approximately there, and you have the antemitral leaflet. And the color float shows you how the pulmonary vein flow appears into the left atrium. Then many a times you might end up seeing the aortic valve also. So this again is very close by. So as you're manipulating the 3D data, the aortic valve will be seen in certain angles. So be aware of it, and it can pop in sometimes. The next is going to the actual appendage. So this again from the 3D perspective. So you have the ostium, the neck, and then you have the body over there, and then you have the lobes on either side, the apex. And then you have the photorealistic, which you can sort of move the torch around, and you can see it from any angle, and you can highlight it a little more closely as you can move the torch around, and you can use another torch also, which you can supplement it. Then within the appendage, one can look at the trabecular lesions, the pectinate muscles a little more clearly. So these are the multiple sort of muscular ridges which are over there. The more they are, the more likely they are going to throw thrombus, and this again gives you a better anatomical perspective. Now looking at the lobes from the 3D. So you can see that in the far side, the thin arrow which shows there are two small faint sort of lobes which are seen. But when you look at it in a cross-sectional way, you can see that there are two sort of circular structures with a ridge in between. So those are the two lobes. Now, as we go closer, using the photo view, the photorealistic imaging, we can have a very sort of better view of how the actual sort of opening of the appendage, the lobes look like, and you have the ridge in between also. Then there's a lot of some publications have come as to how the what is called as the glass view. So this again, it gives you a transparency. So this again, there have been some publications, recent publications, where they've shown that the use of this glass view, we can better classify the different types of appendages, whatever I have shown you earlier. Now, one can sort of look at it what is called as the MPR, or what is called as a flexi slice. So here again, one can look at it from different views. So you have the transverse view, and what you see on the other side, the 0 degrees, is that you just sort of rotate it and you get again a very clear view of the appendage. And then this is again using the same data set. You're doing nothing. It's just the same data set. You're just rotating the trackball, and you're sort of using the rotation knob, and then you're getting this 135 degrees. At one go, you have everything. And then again, another knob, gives you the chance to look at your regular 3D. You want to go look at the photorealistic, or you have the transparency or the glass view. So you get sort of all sorts of, choices which are there to look at the structure more closely. Then you have the slice also. So this is the 3D slice. You can move the slice right from the orifice at the ostium all the way down. So that is the upper slice, and you have the line very faintly seen right at the ostium over there, and then you sort of sweep it down. So you can see that how the shape or any other abnormality in the structures you can sort of get through over there, and you come to the mid slice, and then again the lower slice where you come almost to the level of the appendage. So the last image which you see over there is the two lobes over there at the right at the bottom. Now, when it comes to measurements, again, the 2D sort of really is the one which where measurements are done. But again, from the 3D point, you see that the orifice, the ostium, has various shapes. Most of the times it is going to be elliptical, and this is how the ostium of the appendage is going to be. Now, the ostium sizing has been shown to be much more accurate with 3D than the 2D itself, and you get to see both the major axis and the minor axis. So this is just a rough view of how the ostium looks like, and you have those two lines which measures it. And one can be more accurate using this MPR, or the multiplane reconstruction, or the multi-view, what is called, depending on the vendors, and what is the other vendor calls it as flexi slice. So again, sort of, you get into the appendage, you go into the slice, and then you start to sort of you sort of go back from the 3D data set into the 2D itself, because the 2D measurements are much more accurate that way, and you utilize this. So from here onwards, you start to take the measurements, whether it's at the level of the ostium, or you want to go further down at the landing zone, and you want to look at the depth itself, and then at different areas. And then you can also get to see that the measurements done in the minor axis and the major axis. When you look at the 45 degrees, it's primarily the minor axis which you're looking at. And when you're coming to 135 degrees, it's a major axis. So you have a larger diameter in both the views, and this is how it looks like. And in peri-procedural, again, sort of, just briefly to dwell on the septal punctures, enough has been spoken. So again, to look at any PFOs, and then you have this atrial septal pouches which are there. So once in a while you can come across this. So we should be aware of this. And this is just a 3D how it looks like. Of course, we can see it on the 2D itself. And looking at the fossa ovalis. So what we want to do is the really sweet spot is where we want to really hit the needle is in the fossa ovalis. We don't want to go into the thicker area. And this is how the fossa ovalis looks like, both on the right atrial side as well as the left atrial side. From the 3D itself, just to look at it, we are not going to use this, but just to show you how 3D and the left atrial side, the septum looks like from the left atrial side. So that's the fossa ovalis. Looks very smooth, not very sort of interesting. But what is of real interest is on the right atrial side. So this again is a view just to show you how the anatomically sort of, how the structures are. So you're coming down with the sheath. As you come up, you get into the IVC and then into the fossa, and then go up to the SVC. Anteriorly, you have the aorta. Posterior, the other side is a posterior, and you have the eustachian ridge and the coronary sinus and the tricuspid valve. So this is how it looks like. So what has been told to you is that one has to go inferior and posterior. This is for the left appendage closure. So there are other various points which have already been elaborated, but we are looking at inferior and posterior. Now, when you go back to the earlier view which I showed you, so this is how it's going to be. The trajectory is going to be sort of a natural curve. So the more inferior, so more likely you're going to hit the left atrial appendage. So this is the septum over here. So you're going to go posterior, you're going to go inferior, and the sheath goes across into the left atrial appendage very easily. The puncture itself, one has to understand the fossa. The fossa is the thinnest one, and this is where one wants to go in. So the one on the other side, this image which shows you have this very thick portion. So these are the imaginations of the folding of the atrial wall itself. You don't want to go into this wall, because once you go in, you're going out of the atria and coming back onto the other side. That means you have gone through the cavity, and that's an invitation for the pericardial effusion. So you really want to hit this very thin portion here. So these are sort of various ways of looking at how it is. So you definitely need to have the tenting. So tenting tells you that you are where you are, and that means you still haven't entered into the other side. Moment the tenting is lost, that means you're already on the other side. So if you're too high or too low, so you can decide where you want to be, and something in the mid, that is at the bicable, and the lower set of images are at the short axis. So you don't want to go too anterior, so that's where the aorta is going to be. Too posterior also, you have these very thick muscular folds over there, and that you don't want to hit. So you really sort of want to go into that really thin portion over there, and that's where the puncture is going to be made. And this is just 3D showing how the puncture is, not that it is going to be used in a routine manner, but just to show you how the needle comes across on the 3D image as the puncture is made. As you can see that it sort of, as it pops in, and that's how it looks like. And that's where it's seen from the left atrial side. Now, there have been some, publications also as to how 3D, this particular 3D modality can be used for septal puncture. The use of the MPR can be done, difficult punctures, so they can be utilized as a standby. And of course, if one has the luxury of fusion imaging, so one can use it. So this again is again going to sort of, shown that it is useful, but it's far and few and expensive and has its own challenges. And now we move on to sort of, the devices in place. So you're going to look at the device. You have this nice figure of eight as far as the amplitude is concerned. And then you look at the stability. So post-procedural, again, you're going to look at the stability and going to look for any leaks. And this is what 3D is going to be helpful. And of course, 2D is always going to be the primary imaging over there. So to conclude, 3D has made its mark, and you can see that increasing prominence is being sort of, focused upon. So there is 3D printing. Again, the key words are that it is safety, efficacy, and improved outcomes. So can these three magical words, be sort of, transformed by use of 3D? So as far as 3D printing is concerned, it is helpful. ICE 3D also is showing some remarkable images now. So again, there's a lot of information coming in. In India, obviously, because of the cost and the availability is definitely not there. So this again is more of literature for us, but again showing a lot of value. And just to sort of round up, 2D has its own value. So that is something which can't be taken away. And 3D has its own value. And this is again being shown that in this particular study, which they showed that when you use 3DT, the MPR, the multiplane reconstruction, it gives you better sort of reliability. And of course, when you use glass, they've shown that it can give you a little more incremental value. And this is again in looking at it in terms of the classification, the morphologies, and of course in terms of outcome and efficacy and the safety, 3D also has been shown to be useful. So I would like to end with this slide saying that with 3D, you have a better understanding of anatomy. You can sort of probably have a better understanding of the classification of the type of appendage which you're dealing with. And of course, it can be helpful in terms of procedural guidance, and then it is useful in terms of safety and better outcome, and also in the post-procedural monitoring. Thank you.
Thank you, Dr. Sadish, for an excellent talk and beautiful images. Even though I'm not a big fan of 3D, especially in this LA, I mean, do it for more often parabolic. But do you really depend on the 3D for image, I mean, for sizing? How often do you measure the exact size, or you purely depend upon 2D?
In practical, routine, clinical routine, very low sort of utility as far as 3D is concerned. It's always when, you have sometimes you have loading issues, so you would like to sort of relook at the sizing, you want to increase the volume, and maybe at those times, difficult appendages, difficult orifices, I think, and those, sorry?
It gives an added value.
Yeah, definitely incremental, more reliable, would be more confident in putting up this right size.
2D measurements versus 3D MPR measurements. So which you will prefer more?
The 2D measurements are always going to be a less reliable as far as the recent literature is. That last slide which I showed you was data on that, where they have showed that the 3D MPR is much more accurate, much more reliable, because you are going exactly at the cut, the slice, everything is very accurate. The landmarks, everything is very precise.
And 3D MPR and CT?
When we talk about MPR, it's 3D.
CT. Comparing it with CT
CT, I don't have, I haven't come across data. Maybe it is there. I'm not sure about that.
We don't routinely do a CT for a.
Yeah.
Nowadays, we don't routinely do a CT for the LA evaluation. Any questions from the floor? If not, we'll wind up the session. Thank you, Dr. Sadish.
Thank you all. We now come to the end of session 2. I request Dr. Ranjan Shetty sir to come up to give the mementos to the moderator and chairperson. Dr. Edwin Francis, sir. Dr. Bhushan Shah, sir. Dr. Chandramani Adhikari, sir. Dr. Rohit Manoj Kumar, sir. Dr. Kavya Malikarjun, ma'am. Dr. Neeraj Avasti, sir. Dr. Satish Govind, sir.
ಬರ್ತಾ ಇದೆ ನೋಡಿ ಬಂತಾ
I would like to announce that case presentations have been started in Hall B in the first floor. Anybody interested in case-based studies can go and join in Hall B. Here we will be continuing the Watchman Flex Symposium Session 3.
So, session 3 will be starting now. We would like to announce moderators, Dr. Kavya, Dr. Ramesh Dagupati, Dr. Bharat Vijay, chairpersons, Dr. Mukul Bhargav, Dr. G.J. Shetty, Dr. Ravindra, Dr. Bijulal, and Dr. Bipin Kumar to come on stage. Dr. Bipin Kumar, Delhi. Yeah.
Okay, so let's go ahead and start the next session, which is the Watchman Flex Symposium, session 3. I have pleasure to invite my co-director, Dr. Ranjan Shetty, to give a live in box number 2. Thank you.
Thank you, Dr. Ramesh. So now that we have had a lot of discussion, I think it's time for the next live in box. So this one is specifically about watchmen, because you realize that when you plan, although they all look the same, there's a different planning which occurs. I think what's common to all of them is septal puncture, anticoagulation, care of appendage, all these are venous access is common. But when it comes to device, there is a different planning which occurs with each device. And Watchman, as you know, has a huge data. All the trials which you saw is Watchman, except Prague 17, which had other devices. Otherwise, there's always Watchman. So we'll go through this. We will discuss step by step. So can the slides?
59-year-old patient.
Yeah. Slide 7. Okay.
Patient with atrial fibrillation and is a polyvascular patient, and we are planning to do a LA closure with for him with Watchman device. So we already taken a femoral venous puncture here, and we are taking the catheter for septal puncture. The catheter it's in left brachiocephalic vein, and we are taking the puncture needle now. And echo-wise, we have first done the echo, which shows that appendage is visualized, and the measurement which Dr. Kavya has got is 15 to 16 with depth of 29.
So most of the time what we do is we don't do pre-TE, at least in our center. Only when I go to Proctor, or we would ask for to remove clot. So in our center, because the pre-TE, it's not that comfortable for the patient. They get upset. So we admit, we start with Dexmed, they are under sedation. No puncture is taken till T is done. So T is done to rule out LAA clot, and after that a venous puncture is taken. By that time they're sedated, they're comfortable, and it is, most of the time, although it is done under more like a sedation, they don't remember anything. There's no GA here, it's safe, but once you finish the procedure, most of them think that it is not done at all. We had one patient who complained to our brother that I'm not yet been taken in. And the procedure was over. Yeah. This needle, we keep it up like this and keep it at 12 o'clock up, and we are taking it in. And we will do the septal puncture now. As soon as the septal puncture is done, we'll enter to LA. Okay. So we are coming down. Okay. So echo can be seen there. Fluoro, we are coming down. Please keep saving all the fluoros. Yeah, yeah, coming down. So we are coming down here. Yeah, yeah. And yeah, so if I can ask, is there a mic around? Where would you puncture in this view? In anybody in, this is a bicaval view, and when there's a mic, yeah. Anybody, just more for, sometimes people sleep off and you don't even know. So where would you puncture in this case?
Towards the thinner side of the.
Yeah. So it would be on lower part because this is SVC, this is IVC, but you still don't want the thicker septum. So you would be puncturing at that point, lowermost point here, but not in the thicker septum. So thinner septum, and you see the septum is slightly floppy here. So that these are the times when you may not get that particular point. That's where I think Dr. Ramesh's talk of how to manage when it is floppy comes, and you need to use it. Sometimes you may have to use the opposite end of the coronary wire because that goes through the your broken barrow needle. Just puncture, remove it, put the normal end, and that don't push the opposite end. Once you puncture, remove, put the normal end. That goes to LA, on which you can slide your catheter. You can use the cautery. These are real problems which you could face. Look for tenting in the echo. Yeah. So can we see the tenting cover anywhere? Yeah. So we need a posterior inferior. In the catheter is seen, but the tenting is not clearly seen. It's slightly a floppy septum. I'm going to take the needle a little more in. Tenting is not seen yet, no? Yeah. Tenting is seen. It's in a bicaval view. This is where we want to puncture, or little bit lower, but I think I'm okay. Now, so once you get that in that view, you ask them to go to aortic view. And now this aorta is seen here. So do you think this is okay puncture, or you think it's okay, but maybe little more posterior, that doesn't matter. And how do you go posterior? You turn it clockwise. If you do clockwise, you can see it, you could see it just split out. No, Dr. Ramesh? Yeah.
I agree. I think this is where you have to be very careful how much posterior you want to do, that somebody was asking earlier. I think this is a perfect place to stick, in my opinion.
Now in the aortic view, see the way we are going back, and fluorosave please. Yeah. And it is showing there, and this will be the point of puncture. So we have done a septal puncture which is posterior and inferior. But if you look at the fluoro, it looks funny sometimes. This is not the position you're used to. Sometimes it looks very funny. It looks very, not what you're used to. You're not comfortable when it turns this side, but you will get it sometimes. So don't worry about fluoro once you have a good position. Go by the echo. It will look funny. When you think you're superior, see the position looks very superior in fluoro by conventional teaching, but it's quite inferior because we know it is inferior. Pressure line and the wire catheter. Okay, I'm pulling the needle back, and catheter is in LA, which Kavya can now see. It's little, yeah. Now let's see the pressure, LA pressure. Heparin, how much did we give? Not 5,000 heparin to be given. 5,000 heparin, little more high. So generally here, half the heparin is given before, half here because it's on. So around 5,000, 6,000, even little more is okay. So we don't have to. Yeah. And LA pressure, we were thinking of 10. Dr. Ramesh thinks it is 12. There's no definite number, but it has to be high. Otherwise, you'll underestimate the size and it could embolize. That's what Dr. Horse fever stock. That's one of the key points to remember, that the patient should be adequately hydrated. That's also the reason why CT may not be very accurate, because patient is always fasting for CT for 4 to 6 hours. It's a OPD procedure. Nobody gives IV line. So the measurements what you get in CT may not be very accurate. So that's the reason, I mean, most of us don't do pre-CT. Hydration, the pressure seems to be little low, and the LA pressure which we have. Now let's take the catheter to go to, yeah, with wire, we'll go to the pulmonary vein. Now you can see the appendage beautifully there, which is, and the measurement for watchman would be at level of brachiocephalic. First, you have to take, give a MPA with thermo, and then we'll go to the LA pressure here is 11 or 12. So we go with the MPA with the thermo. Yeah. Yeah, measurement. How much is it? Yeah, 16.9. Yeah. So most measurements I think is 16 and with a very good depth. And since the creatinine is normal, yeah. So I'm going to take the pigtail in. Okay. And I'm passing the, yeah. I'm taking the this one in. So I'll try to enter the pulmonary vein like we did. Now we'll put Amplanza and we'll put the 14 French sheath there. Heparin 5000 given? Yeah, yeah, yeah. So we have had some discussion where to do most, because now this sheath is going to be bigger. With Lambre, it was 10 French. It's going to be 14 French, little stiff. And you could be in a position which is not very optimal. Like here, it was thin. Sometimes the septum is thicker. You don't dilate like BMV here. So you don't want to transmit that push to the appendage. Like Dr. Ramesh told, it's 2-3 people's job. You may not actually transmit. So it's preferable if you could do it in the pulmonary end, at least for first 10 cases. Come. So we have put the Amplanza, and so because the size is 16 and the depth is okay, we will choose, general rule is 4. You upsize by 4. That will be around 20. So 21 device is fine. So now just the thing, because this is the Watchman Symposium, there will be some more talks on Watchman. How do you size it? So in echo, you would measure, now for Lambre, you would measure it like this, because the Lambre is more neck-based device. The Watchman is more body-based device. So usually the line drawn will be from here to here, and you measure the depth too, because you need depth. It's more like a box. So you would measure this from here to here, because you want to close that area, not the neck area. When you measure this came 16 in, but 1 is not enough. You'll have to do the same thing in 0, 45, 90, 135. 135 is tricky. It's not that easy to get that view. So if you can get say 45 or 90, and if you this one has multiplane, you will get it. Otherwise, it's difficult. Once you get this number, you decide the size. Now the rule for Watchman is, general rule is 16 plus 4. You add 4 to whatever you got, the maximum. So if it is 20, 24. And take the neck size. The neck size here will be 21. 16 plus 4 is 20. So 21 or 24. If your depth is good, because we discussed this, Watchman could be upsized to a great extent compared to other devices. More compression, better. Both the case which Dr. Horst Sievert showed, because it was smaller, it tend to embolize if it is not compressed well. So take a bigger size. So most of the time, if the choice is between 21 to or 24, and if the depth is good, we would go for 24. Unlike other devices, there you have to be choosy. Here, try to upsize little more than normal. It works. Then naturally the peri-device leak also is lesser because you are having a bigger. But only this one is there should be enough depth. Sometime a shallow appendage or a immediate chicken wing, something which bends immediately, you may not get that depth. But if you're getting that depth, always go for little bigger. That works well. But I think we'll take the next size of Watchman flex. So we'll take the 24, which is the Watchman flex. Okay. So little upsizing with Watchman is always better, and we are going to put it here. So come. Now remove this sheath. The wire is already there. And now what we are going to do is take the, do we have a Watchman sheath, please?
double curve watchman sheath. Yes. Yeah, I'm going to remove all this, and we are going to remove that sheath only when we need. LA pressure was fine, catheter is in. Now next is we are going to keep this wire. Please hold it here. And where is the watchman sheath? Yeah, watchman sheath you give. Come, flush this. Flush this, come. Yeah, with 20 cc flush the sheath. Come, hold it here. So the sheath is double curve. You get single curve. They're all 14 French for Watchman and AMOLED. And you get single curve and double curve. Most of these needs a double curve. So 90% of your case will be double curve. But unless you're going through a PFO or a ASD, in which you want to take a single curve. Otherwise, it's almost, if you have done a septal puncture, which is posterior inferior, just take the double curve sheath.
So the true seal
we'll
sheet.
press the sheath.
So now they came with the true seal sheet, which is less bleeding on the back end, and also you can actually put a Versacross through it, and the radio frequency wire as well, because everything can be done in one step. So you go up all the way to SVC with the true seal sheet, the Boston sheet, and 15 French, come down and make the radio frequency puncture and advance the wire and advance the sheet and everything. Remove the dilator and put in a pigtail. So it avoids like 1 or 2 extra steps, and we don't have to do all of that. So it'll be easier, but at the same time, it's a slightly more expensive. So
Yeah. So Watchman comes with the, like a two sheaths, single curve and double curve. We are taking the double curve sheath. Together in, okay. And yeah, can we prepare the 24 device and keep it ready? Yes. Come. Now let's take that 14 French Watchman sheath which goes up. Come. Put it here. Yeah. Did we do this one? And this one is done. Yeah, crochet is done. No, let's do the crochet. Come, crochet incision. Come. Hold it. Yeah. Hold it. Yeah, hold. Yeah. Crochet incision. Come. Leave. Yeah. So we'll give a little crochet. Something about the venous puncture for the structural heart. Ideally, they should be vertical. They should not be too horizontal. If you make it more horizontal like others, you'll unnecessarily have a bigger tunnel to go through. More vertical, better it is. Whether it is BMV, whether it is ASD, little more vertical, like, it's better. And then the cruciate incision, because skin has resistance at 2 points. So just one cut like this and one cut like this works well. Then you're not stretching it. Anyway, we close by figure of 8, so it's not a big deal.
yeah,
And it heals.
that's a very good point. Even when our fellows have been trained, they always create a tunnel. And the tunnel will actually, next thing we'll do is it will kink the wire. And now you're done already, your wire is nicely in the pulmonary vein. Now what do? Your wire is kinked. You have to remove the wire. So you're starting from bottom again, from first step 1. So, it's a big headache to do that. Prevention is better than cure. And these people just put 60-degree angle, as you're saying, that's what I tell them. I say maintain 60-degree perk angle. When you go with the needle, you maintain that 60-degree angle. You always, for artery, you look at 45 is okay. But here for the veins or whatever, even now towers, I always tell them, don't go like a 45. Even, outpatients are much obese, much more bigger, and lot of subcutaneous tissue. And creating a subcutaneous tract is the worst thing to happen. And so it happened to us a couple of times, and that's why I'm saying that it's very important. And put a big nick, dilate it with a mosquito or hemostat, whatever you have. And sometimes if you're very rich hospital like Ranjan, you can use a dilator. So you can use a dilator as well. There comes something called Kuhn's dilators. They're very nice and smooth dilators. And so that's what I actually sometimes prefer for MitraClip, and where it's large. And if I'm feeling resistance, I stop, take it back, and use the Kuhn's dilators.
And this also works well for BMV. The struggle which you do with the groin.
goes down if you do a more vertical this one. Again, you are also worried that you may go above the ligament because you are so much. So go more vertical, it works very well. Yeah. Incision so that the catheter can easily go. We had already put 11 Frenchie, but this is going to be 14. So we are going to go in. Yeah. So we are up. Can you get the pigtail now? Okay. Pigtail here. I'm going to take it in. I think Kavya will be able to see it. We are going to the flush. Can you connect here, please? Yeah. Come. Pigtail is here. No, the flush. This one. Yeah. Out. Here. Can you on? Yeah. Can you on? Yes. On. Okay. So I'm going to take this out. Is the pigtail in? Can you hold this please here? Yeah. Yeah. I'm going to take it out. Please load the pigtail on this. Other thing is, if you remove that wire, loading a pigtail becomes very difficult. The best is to keep that wire in and keep it till end. Don't remove it because pigtails also need extra strength. Even when you enter appendage, I don't remove this amp-lancer wire. These are the things which shorten your procedure later because, this was also not edited. This whole thing is as we did it and it's 15 minutes only. So we have not, no step has been edited in this case too. Okay, come. Load the pigtail and you can see in TE how beautifully we are in the left upper pulmonary vein. Load the pigtail.
Yes, so
Yeah.
that's a very good TE view.
Load
You
the
can see
pigtail.
the left atrial appendage, mitral valve, and pulmonary vein, and you can see the wire in the pulmonary vein, and and the circumflex origin. Everything. I mean, everything is very clearly seen. That's what we need to keep an eye on.
That credit goes to Dr. Kavya.
Yes.
You want to comment on? Yeah.
Thank you, sir. Some patients, we do get good images, like the first ones which Dr. Ranjan presented, the images were not great, honestly. Sometimes there is a lot of struggle getting TE images, but I think the trick is to try and anti-flex the probe a little and rotate clockwise or anti-clockwise to optimize the images. And the other thing is, I should have mentioned in my presentation, if on 45-degree, the LA appendage is, when we see it, we see the aortic valve, probably it's more anteriorly oriented appendage. And if we see the mitral valve during this view, then it's probably a more laterally oriented appendage. So that's one thing which gives clue for transeptal puncture as well.
So, Dr. Kavya, do you empty the stomach contents with the NG tube?
So we keep them nil per oral for almost 8 hours.
So I've seen my anesthesiologist. Sometimes we have echocardiographers, cardiologists, and anesthesiologists. The anesthesiologist, they used to doing all of this under general anesthesia, right? So they put under general anesthesia, put an NG tube, and suck away all the contents, and then they put the TE probes to get better pictures. So I mean, now we don't do it under general anesthesia anymore. So yeah.
Even we do it under Dexmed infusion continuous. We don't intubate.
So I think the one message is
like
that both are
like conscious sedation, that's all. Just like TAVR, conscious sedation. Okay.
Dexmed. But as I was telling, even though it's a conscious sedation, it's not that patient realize it at all. For them, it's almost like GA, but without the side effect of GA.
Right.
It's not that they have any discomfort or even recollection of the procedure. They don't have. So I think I don't know whether our anesthetists are here.
Any other questions?
Yeah, Mike there. We want it to be more interactive, so please ask things if there is. Mike. Yeah.
Also from the panelists, please feel free to ask the questions.
I do have a question, what Kavya pointed out. You said that 45 degrees when you see the ostium of the appendage. If you see aortic, the mouth of the appendage is anteriorly oriented. If you see mitral, it's more posteriorly oriented. So what do you tell your operator to take the puncture as? Posterior, high, low, depending upon this input.
If the appendage is more laterally oriented, you can get away even with a mid puncture, not necessarily very inferior. But if it is very anteriorly oriented, you need to go much more lower down. Posterior, inferior is mandatory. Otherwise, you may not be able to place the device in the coaxial way that we presented.
Thank you.
Especially with watchmen, coaxiality becomes much more important. Otherwise, if it tilts like this, the whole purpose is lost. So there are some steps we have to do.
No, you saw the Dr. Host even showed a case that where he released it And I think at next day or the same day that it completely was a
Reverted.
non-coaxial, that he then went back. I think after several days, I think
Yes.
he went back and he snared it with the raptor. So that actually is because too much tension, and even his stick was too high in that position in that patient. So we were making a comment earlier in that patient. So too high, and then you are not coaxial because you put a lot of torque and counterclock rotation torque will be applied to have coaxiality, and then when you're letting it go, it can actually change its position. So I think one
you had
What about de-airing this sheath? Do you do it underwater or?
can't hear you, sir.
So the de-airing of the sheath.
DR, yeah.
Are you
So
doing it
DR
underwater?
is generally underwater. Generally underwater.
Here are we?
In this case, once if you are sure your LA pressure is higher, then you're not too much worried. If it is around 12, 15, yeah, and if you see a black bead, it's not a big deal. Otherwise, DR is underwater with the kidney tray. That's
You
what.
have to go very slow.
flow.
If you are not
Yes.
constant infusion is not there, then you have to go slow.
Correct.
So that at least some blood should trickle back.
Yeah, yeah. After that, you connect your this. You don't
Yeah.
connect it before. Yeah. So now from the But I think the message also is it's two-person, both are learning. As you are learning to put the device, the echocardiograph with you is also learning to show you exactly where it is. So, this problem you see when you're proctoring and, people, there are places where we proctored and after we went to lab, the echocardiographer has come from home because people are not understood. It's two people procedure. For this one, we are going to get the this. The device, is it loaded? Can you keep the device ready? Yeah, yeah. Because we have decided to take 24 device. We may not take any other, because multiple measurement showed 16. So we are going to take a 24. So this is now where it is. If you have a pigtail, I have a wire. Now we'll go RAO slightly. I will look at this one. Come to RAO table, yeah, and keep saving all the steps. Yeah, from RAO, we are going to get the catheter down. See, you can see it in, we should look at both fluoro and echo, and we are going to get it down, allow it to fall. See, you can see there, please save, allow it to fall. Now it has fallen. As it has fallen, push the pigtail in. And now it is inside the appendage. You can see it inside the appendage in the upper lobe. I want some dye to be ready. Now with the it's basically, you see it come down. Most people get scared. They think the whole thing will come out. So in Arrow, you have to see it come down. Once you see that some sort of a fall, which is visible, just push the pigtail in. It generally just walks into appendage, like here if you see. The wire, I'm going to keep it here. Hold both the system, and I'm going to, with a little torque, I'm going to take the this one in, the sheath in. Anti-clockwise it actually takes it up, and we are in now. So we are going to take one RO caudal angio. Please stop this. Little more dye. Yeah, RO caudal. Although the cine is not a must, we are still probably going to take just to recommend, just to see how it is. Okay. So I need a little more dye. Okay, ready? Okay. So we can see a bilobed appendage here, which is with a much upper lobe, and this. So I'll try to put the device little more in. So 24, we'll have to start little more in for. So this is say caudal angio, which is most preferred for watchman. But now how would you position your, because it's not that forgiving, you have to make it fine. So that pigtail now will have to go little more in, but not too much. And we would want it to look up. It's looking down now. You'll push it in, put the wire in, make it look up. Using that as a stability, this one, you'll anti-clockwise your sheath and take in. So generally that much step can be done later. You don't have to do it at this point. Make sure your device is now de-aired, kept ready. You have chosen your device. It comes preloaded. De-air it, keep it ready. Just before removing the pigtail, make sure you are adjusting it. Otherwise, that torque can't be held. The next person whom you give is not going to hold it if you are moving. So before that, this is not the position. You would want to take it a little more up, torque it, make it look up, and then once you remove the pigtail, you don't want your sheet to go front or back. You just want it to be there. This. So 24 is what we want to take, and we are trying to put it in the upper lobe now. And I'm going to, with the anti-clockwise torque, I'm going. So in echo again, you see two lobes there. There's upper and lower. It's almost mandatory for watchman to be in upper lobe. You have to try to put it upper of the two, and then try to take the sheath looking upward. Otherwise, it will slip down. Going to put it way in the upper lobe. Okay? Is the this one ready? Device ready? Yes. Can you hold it here, please? And just go through. See, this 135 actually shows that 135 there actually shows a pigtail and the upper orientation of the this. The device once. Yes. Yeah. So did we unlock? So 24 is what we decided. We're going to go out. We're going to go here. Yes, exactly at the tip. We're going to close it. Is one more flush? Yeah, flushed it. Yeah, flushed. Did we do that? Yeah. Yes. Okay. Come. Come. Get it here. Yeah. Yeah. Keep it here. Let's connect this to that. Connect this there. This one there. There. Connect it. And we keep two flush, one for the sheath, one for the this one. This is all high pressure, like IABP kind of high pressure. See, the sheath is in, it is in the upper lobe. Kaveh can see it. Yeah. On, open it please, and flush. Okay. Let's see that flush is coming. Yeah. Now with this, with the anti-clockwise, I'm going to remove this, and we are going to take this device in. Can you hold it here? This one here. Yeah. This is needed. The way it looked up from that time. Now finally when we remove, you'll realize that it's actually looking up. See? Okay. So we're going to go this way. Slowly,
So that's why the
comfortably,
double
we are
curve.
going to go. Yeah, it's double.
I mean, the double curve helps here for that actually,
Correct.
to make that curve and remain in that
Remain
position when you put the counterclock.
Go in, and I can see I don't want to push the sheath in or out. I'm going to take it slowly, and you can see now it's not yet come. As it comes, you will see there will be a click. Yeah, now the sheath is come. The device is at the level of sheath. This is Watchman Flex. It's a softer device, but I don't want to push the sheath. Some atrial ectopic. I'm going to be here very close to that area. So now what we are going to do is I'm going to pull it back. Can you show it here? And click. So there's a point, there is a marker on the device, the round, there are three markers on the sheet. There's a point when the two markers merge, when they're together, you actually pull the sheath back and join it. You don't push the device, then it will act like a single unit. So both the markers connect, you pull the sheath back. Now this marker goes ahead, but whole this becomes single unit. So you're still maintaining your anti-clockwise torque at this point, and then unsheathing the single combined sheath. Okay, pull it back and click. Okay, now with this in, I'm going to unsheath it. Not push, but unsheath. It's a soft device. We'll see in fluoro. So as we are unsheathing, the bulb is formed. I feel the depth is enough. I'm anti-clockwising and coming more and more in and producing the device. Once we do this, we have to hold it for 10 seconds. I'll count 1. Can we have fluoro medium? 1, 2, 3, 4, 5, 6, 7, 8, 9. Look at the angio. So once you see that blob, you know where the position, you continue unsheathing. And then once you release it, you need to push it again, because it's a softer device. This is different for Watchman Flex. The original Watchman did not have this step, but the original Watchman, the other end, the distal end was actually free, and it was pokey, it was dangerous. Here you have distal end which is covered and it's very soft. So device related perforation is much lesser with Watchman. This is the only one available now. The echo, it's actually very beautiful. It's exactly where we want, completely compressing and nothing. So now what we are going to do is we are going to give a little tug to make sure it's not coming out and it is positioned in.
I feel this is a very good position. The smooth part of appendage is done. We can do one angio and then show the position. Kavya will do the pass criteria. P is position. Almost all of the device, if it is within circumflex, it is good. A is anchor, which we already did. S is size, which he is going to measure and see that there is at least a 20% compression. And then the last is the seal, because we oversized the device, which is now beautifully positioned. It should be fine. So I feel it can't be better. The position is good. It is perfect. The seal is good and nothing to worry. If live fluoro, we can see once. Live echo, yeah, measurement, what is the number you're getting? 1.7 for a 24 is a very good compression. And if you see, it looks good to me. Position is also good. Movement is also good. So I'm going to release the device and we are going to put a figure of 8 after that. Device is released and in fluoro you can see that it is in right position. Good movement. There's nothing to worry. It looks well anchored. And I think this position, this is a different view in echo, but look at the way it has, held itself and it is good. So I'm going to pull it now. Yeah, we'll get the figure of 8. Position looks good. Yeah. See that 135 degree which Kavi has now taken, that's probably one of the best view to see how it is. This one, the 135, the way it looks here, one of the best. When you go in between, you see some shoulder. Shoulder is acceptable now with Watchman. That is also the reason why 87.5 in, from Protect AF to now, the success is increased to 98.5. It's because you learn how to put it. You're going more deeper. You're also accepting some shoulder. You're sizing it right. That's how it is. And the complications have consistently come down.
What do you mean by
The device
shoulder?
is fully in, no ammo.
Can you explain? What do you mean by shoulder?
Shoulder is the protrusion which is seen in that. Generally, the shoulder should not be more than 40%. Yeah, that is the shoulder, which is protruding above the circumflex and the orifice. And generally, up to 40% shoulder is acceptable on echo. Anything more than that, we may have to recapture and use a different one. And the measurement.
Just like
Yes, if it is oversized, no, whether it will call the compression of
yeah,
circumflex. It's reported, but it's with the probably with the flex it should be less because it's much softer device. It's been reported, but very, very rarely. The circumflex compression. You can see the circumflex, you can see the size. Have you had any experience of
No,
circumflex?
I mean, luckily not, but I know somebody had it actually with the first generation Watchmen, but it's very uncommon. So, but can it happen? Yes. Okay. So
As Dr. Ramesh told that time, when you oversize, the chance of pericardial effusion increases slightly,
Yes.
but it's still better than undersizing. So if you have to, with Watchman, if you have to choose between an oversize and undersize, it's always oversize. That's the rule for Watchman.
And finally, can you comment on the double curve of the cathedral?
Yeah. So double curve is the sheath itself. So at the end, so there is a 45 degree, 45 degree. It's one angle 45 degree, other angle 45. The sheath bends. Now this helps you to go to the uppermost lobe and also keep that anti-clockwise torque. If it is single curve like a ASD sheath, which we use, it's just like this. Now this becomes difficult for a appendage. So you want something which is this, because tendency of all these devices to fall down. Their tendency is to go down. But when they fall down, they will obviously position themselves in a slanted way. So your job is to maintain the torque to make it upward. So anti-clockwise the rule once you are inside the appendage.
Same direction, two curves in the same direction or double
Yes,
curve?
so that it will try to fall back little, but because you are anti-clockwise, it doesn't fall back fully. But if you start in a clockwise position or clasped downward, it will look like this. Half device in, half device out.
You have
Can
to
I ask
be
a question, sir?
very slow while pulling down this sheath, so that and gradually anti-clockwise rotation, so that you will look into the LA appendage. That's the trick, I hope so.
Yes, I agree. Totally.
Can I ask a
Device
question,
is
sir?
coming. Compression is very good and it looks good in every way, And AP and the position looks good. and Kavya will do further echo, and we will do the this. So this is a good. So I think you are seeing some modified view. This is the view where we deployed the device. It looks. This is how we deployed. It looks perfect here. There's a compression here. So using there is a pin here. That is the one which Kavya has to take to measure. If you otherwise in a slant view, you'll get a lesser diameter. You'll feel it's compressed. You need to include a pin in your measurement to make sure that you are not artificially cutting it. So you need to see the pin, measure the maximum width at that, and that should be between 8 to 20%. I feel 30% is good. Little more compression, good. Less peri-device leak. It's perfect here. As you do modified, it will go up and down. And now we do a figure of 8, which comes here. So that's the pulmonary vein on top. So any electrophysiologist here can still do ablation if they have to do, because everything is fine. There's nothing projecting. So Watchman is good if you are considering a future ablation or simultaneous ablation. Yes, yes, close that. Yeah, yeah. The finger on that. Please. Finger on that. So,
Sir, I have a question.
Yeah, yeah.
For an ASD device,
Yeah.
for an ASD device, there is a system called as Trivasive system with Amplat, sir. They have a flexible cable on top of it. So, do you think such a flexible cable for a delivery like this will be little
Whether it
safe
will
for,
help? Yeah.
whether it
So
will help?
here, actually, you don't see a tug. It doesn't reposition itself later. Very hardly, rarely ever you see it repositioning it, unlike ASD. In ASD, there is always a tug. You are never sure what would be the final release position.
Especially large ASDs.
Yeah, large ASD. But here, you're almost, it doesn't change much, because I think the sheath is adjusted in such a way that all those torque is taken by the sheath here, not on the cable. So I don't think so it matters here.
This one is just a comment. Please take it positively. So your company fellow has not scrubbed actually. He's just wearing a gloves and preparing the device.
Okay, okay, the behind, yes, yeah.
So one question regarding the sizing and the depth. So when does this depth becomes crucial enough to consider changing the device? Or probably when we are considering the sizing of the device, oversizing, would you like to take a smaller size because of the depth, or would you like to change the device altogether?
Correct. So for that, it depends on whether it is the first generation or the second generation. The first generation Watchman, it was more like a rectangle device. So, it was this and the width was little more. Like if it is a 23 year, it would be around 20, 23. The present one, this is 18. For a 23, it is 18. So depth is not that important. I think it all depends on planning. So if you look at world over, Watchman number of device to procedure is 1.5. That means every second case, 3 devices are open. But fortunately for us, I think it is 1 in 10 that you have to change the device. It all depends on how you plan it before, and there is also, you know where to implant it. So little bit positioning also comes as you keep doing, that there is always a place where you can implant it right.
So if you capture and release it and capture, and if you do that 2-3 times, maximum recommendation is 3 times, and once you do it 3 times, you need to change the device. If not, you can deploy it.
That's the IFU.
Yeah. Okay.
But we won't be able, we don't
Yeah.
follow it that strictly. But the IFU, at least for the previous one, is 3 times, remove, take the next one.
Yeah.
But again, the first time is the best. Take your time,
Yeah.
position, and position it right rather than struggling too much.
Any other comments? If not, thank you very much, Dr. Ranjan, and we'll go on to the next speaker.
I would like to call upon Dr. Munesh Tomar for her imaging session on Watchman device specific imaging for Watchman device pre and post imaging. And for all those of you who want to make actual TE images, there is a simulation TE kept in first floor, room number 3, conference room. So kindly make use of that. Now 5 to 6, 7 sessions are being taken by Dr. Satish Govind. So kindly whoever is interested, please go to first floors of simulation TE after these. Tomorrow morning, one more session is there, simulation TE by Dr. Edwin between 9 to 11 o'clock. So kindly make use of the opportunity.
Good evening, everybody. LA Appendage Summit. And that full hall at this time speaks a lot about Dr. Ranjan. Thank you, Dr. Ranjan, for inviting me, giving this important topic, that is Watchman device, LA appendage occlusion. I'm a pediatric cardiologist and more into congenital heart disease, both for imaging and the intervention. That's why I'm being called by the adult cardiologist, and Dr. Balbir Singh is the EP person who is primarily doing the intervention at my place for LA appendage closure. LA appendage anatomy is important. Like my presentation is basically all summarization, whatever happened since afternoon session. So it is important to understand the anatomy to choose the device, which device, how to deploy, and knowing its limitation and the possible complication. So this is the area which is of interest here, LA appendage, which is part of the primitive atria, and rest is smooth. That's why the thrombus formation is everything into this rough part of the left atrium, which is the appendage. That's why it is called the most lethal human attachment. And the closer indication being done for the left atrial appendage. Role of echocardiography for device closure, and special focus will be on the Watchman device. The person involved, there are two important persons, like anesthesia team is one, but the interventionist and the imaging person. These two persons has to be on the same understanding, same thinking when we are doing the intervention or the device closure for the left atrial. So we need to know the device, both has to know the device, both have to know the anatomy, know the limitation, contraindication, and the possible complications. That's why imaging become very important, very crucial when doing the device closure for the left atrial appendage. So various views have described by the Kavya and Dr. Satish, about 2D and 3D we have discussed, plus it's the angiography. So a common language between the interventionist person and the echocardiography is very important here. So what RAO, it's basically RAO view where we define the left atrial appendage. So long axis by the T, how I am seeing, and the short axis by T and the angiography I am seeing. It is important because I have to keep my view same as for the intervention to help him to orient better with the imaging during the procedure. So this is the Watchman device. Just we have shown a beautiful case done by Dr. Ranjan Sethi, and we have discussed all about this device. This is parachute-shaped implantable of nitinol and have a polyethylene fabric membrane cap, which is towards the left atrium itself, and this part towards the left atrium itself, and this will be into the body of the left atrial appendage. Me as a imaging person need to understand, need to have all understanding of the procedure. So this is a very basic thing, how the catheter goes, how the device goes, and how the operator is implanting the device. So all views I have to show him that we are working in a safe zone. We are not causing too much damage, or we are not putting a very loose device. So LA anatomy, a roadmap for the transesophageal echography for the LA appendage device closure is the anatomy to decide about the size, the septal puncture, device deployment, post-procedural assessment, and the 45 days follow. So this is the minimum imaging needed for the left atrial appendage closure. On 2D and 3D transthoracic, transesophageal, basic cardiac anatomy, ejection fraction, LA size, volume, pressure. So this part is very important. So in which phase of cardiac cycle I have to measure, that is also become important. Obviously, you need to exclude whatever the possible contraindication for putting a device inside the heart, whether it is across interatrial any communication or into the left atrial appendage.
So again, these three are very important. Ostium, that is the mouth of the left atrial appendage, the landing zone, and the depth or the body, the lobes. So these three things I have to understand clearly and give the information to the operator, to the interventionist, what best we can choose for this device. So the views are basically at the mid-esophageal level, and you have to swipe throughout. So roughly 0 degree, 45 degree, 90 degree, and 135 degree, but there is plus minus 10. Means whole of the from 0 to 130, 140, you have to get the maximum landing zone, maximum orifice area where I am going to put the device along with the depth or of the left atrial appendage. Like you require, like as Kavya explained, some rotation, some manipulation. So there is nothing fixed. Every heart have a different orientation for the different structure. So appendage could be downward pointing or the anterior pointing. So we need to know how it is pointing, and you need to modify your imaging accordingly. The timing is end systole because we need to get the maximum volume here. Maximum, so it is the end systole where these things are maximum with the normal left atrial filling pressure just to avoid undersizing. We cannot undersizing because risk of embolization is high there, which is obviously a very difficult complication. We can oversize to some extent, as we just seen in one of the case done here. 2-dimension, 3-dimension with MPR with 3 reprinting, whatever way you are comfortable, you need to apply. 3D is a very important modality when we are using here. For the watchman device, where to put, that comes the question. So this is the LA appendage orifice area, and this is the landing zone, around 1.5 to 2 centimeter inside the tip of the, this is the edge of the left lower pulmonary vein. Left upper pulmonary vein. So this is the landing zone. Okay. So orifice is not of much interest. The much interest thing is the landing zone and the depth. So depth is important. Depth should not be very shallow, as we have just discussed. And the landing zone should not be very small or should not be very wide. It has to accept that particular size of the device, whatever range we have. So these are the important, the number of device we have. So we know what device we can deploy within that particular range. Again, in zoom view, this is the orifice, this is the landing zone, and from the landing zone to the maximum depth I have to take to know the depth of the apex of the left atrial appendage. It is important because the depth should not be very shallow. It should not be smaller than the landing zone diameter. That is why the depth is important. Otherwise, distal area, you are going to just exclude the left atrium. So the rest of the anatomy there does not matter much. So these are sizes of the device, watchman device, which are available. Obviously, all views, the maximum size you have to choose. So at this level, this is 26. Here it is 19, 18, 19. So I have to go by the 26 millimeter. For 26 millimeter, roughly around 30 millimeter. So around 3-4 millimeter bigger, we need to choose for the closure of the left atrial appendage here. These are the exclusion criteria. As I said, the diameter should not be very small or very big. It should not be very shallow orifice. Most of the time, the left atrial have multiple lobes. So the lobe should not be very proximal that you are leaving it uncovered. Again, you are keeping a focus for the thrombus formation, and obviously presence of thrombus in the LA or in the appendage will be a contraindication. Now comes the question of 2D or 3D. Now, in 2-dimension, I am checking at all the views, all the angles about and taking the maximum diameter. But the question comes whether I am at the same level in all the views. Then obviously 3D will be better. 3D multiplane reconstruction for that. So this is by 2-dimension, this is by 3-dimension. You can get the en-face view of the landing zone. So you can, this diameter you can take in 2 perpendicular views, and you have to take the maximum diameter to check about to decide about the device, what you are going to deploy. Same multiplane reconstruction to know the maximum size of the orifice landing zone area there. 3D printing, if available, obviously people are using it. I am not, but that is also a tool to decide about the size of left atrial appendage device closure. Transseptal puncture we have already discussed. It is important where to puncture the left atrial appendage because the entry, it has to be coaxial views. You have to enter the left atrial appendage. So you cannot accept a middle or the high puncture. Posterior inferior site of the left atrial puncture is important. So these are the 2 important views. Plus help with the 3-dimension echocardiography to know the area where your sheath is going to enter in from the right atrium to left atrium. And obviously during procedure, you are seeing everything. You are seeing where the puncture is being made, how you are entering into the left atrium, how is your wire is going to left atrium. The wire has to be, or sheath has to be in the center. If it is eccentric, it is not, you are going to expect some difficulty in deploying the device. So wire and sheet in the left atrium. Surrounding structure should be focused when you are putting any device in the heart, wherever you are putting. So for the left atrial appendage, the pulmonary veins, mitral valve apparatus, circumflex artery, great cardinal vein. So things are there, or obviously pericardial perfusion can happen anytime. So you need to be aware of what you can create complications surrounding that particular area. Sizing we have already discussed is around 20%. Compression should happen. So you have to little bit oversize the device while you are selecting the device according to your landing zone. Tug test is important. It has to be gentle. You cannot be very aggressive. It has to be gentle. And the echocardiography person will show how it is holding and the device is being put stable there. Pass test is important. We have already, this is position, anchoring, size, and the complete seal. So there should not be a significant paravalvular leak. For the Watchman device, less than 5 millimeter is accepted. And to look for the leak, you have to come at the Nyquist limit very low, because it is a very low flow situation. So here my setting should be very important, not to miss the significant paravalvular leak. So all views, all steps are important, starting from beginning while you are deploying the device and while you have released the device. So 0 to 130, 140 angle, you have to swipe with 2-dimension and 3-dimension during the procedure. So this is the device being deployed. When you are clear, you have passed test and you are happy, the operator is happy, you release the device, it's being there. You again remeasure it, again check everything. You are still in cath lab, your sheath is in the left atrium only, so check everything again. Final check, you have to look for device position, stability, interatrial communication. You are using a 14 French sheath, so obviously you are going to create a significant communication, but if it is less than 10 millimeters, it is not to be worried. Para-device leak, thrombus, surrounding structure, and the pericardial effusion. Non-complication, we all know device embolization can happen. Suboptimal device deployment with leak, pericardial effusion, again interatrial communication and injury to the surrounding structure. So if protrusion is more than like within 30-40% is accepted, a shoulder is more than that, then it is not good. So less than 1/3 of the device, if it is protruding, like with time you will accept, you will come to know that what is not looking happy when you put device across some structure. Thrombus should be looked during procedure and on follow-up also. 40 days follow-up become as a part of device closure. For left atrial appendage, this is must to be done in all patients who underwent device closure. So again, all views and check all possible complication and the stability of device when you have to ask this patient for follow-up. So take-home message, LA appendage device closure is fast imaging, rapidly acceptable options for non-valvular atrial fibrillation. Careful sizing, so that is very important role of the imaging echocardiographer here is 2-dimension, 3-dimension transesophageal echocardiography has a very critical role in percutaneous closure of left atrial appendage. The new specialty intervention echocardiography is emerging, and obviously the way adult cardiology is going towards the structural intervention, we as a pediatric cardiologist more into the septal defects, but this role is expanding, and that's why the importance of intervention cardiologists is very crucial in these interventions. Thank you.
A fantastic presentation, Dr. Manish Tamar. Very nice. I think most of this, actually, this is a procedure, again, it is better to partner with an echocardiographer in your lab to have a successful left atrial appendage closure program. I mean, you can think that you can do everything, but it's not possible. So the reason we switched to intracardiac echo is just because there are certain steps we could avoid to bring the patient to the cath lab sooner for the device implantation. Otherwise, in the United States, you can't do MAC and TEE. That is because our lab is situated in the operating room. It's under the control of anesthesiologist. They will not allow TEE to be passed with the MAC. And so that's absolutely no. So they need to get anesthesia, and anesthesia needs a pre-admission, pre-anesthesia visit. So that delays our procedure from office consultation to the procedure timing. So to avoid that, even though it is more expensive to use intracardiac echo, we do that to allow much faster throughput of the patients. But fantastic. Otherwise, TE is a standard of care. I think that should be done in routinely. Then please join us, and we'll see what are the next speaker also join us here. Thank you. Any questions from the audience? Okay, next we'll move on to Dr. Ajay Swami will be showing us some interesting cases. Thank you, Ajay, for coming and showing us. Thank you very much.
So good evening, everybody. Before I begin, my salutations to my teachers, some of whom are in the audience and some of whom are not. It's very difficult to add anything to what has already been said. So it's a pretty comprehensive talks that have come before mine. So I don't know that we can add anything, but still we'll see. These are my disclosures. So this is my case. This is a 75-year-old lady with intermittent AF, fairly well preserved. She had 2 TIAs and she carried on after 2 TIAs. But then she had a transient hemiparesis plus an aphasia. And then after counseling 6 weeks earlier, she was started on NOAC, which she took happily for 18 months. But then after that had an episode of a massive GI bleed. She had multiple AV malformations in the lower GI, and there was no way that it could be done short of a colectomy, that they could stop the bleeding. Now, what do we do with this patient? A little bit of history, theory is required. Lifetime risk for AF in the absence of heart failure is about 16%, and this increases the risk of embolic stroke 5-fold. Up to 20% of all strokes are related to AF, and these strokes tend to be particularly large and disabling. We know all this. Almost all strokes in patients with AF are caused by thrombus. Almost all, not all, but the majority are caused by thrombi that are formed in the LA appendage occlusion, in the LA appendage, and this comes from our surgical data that is quite well validated. I'm not going to go through the details of this, but these are the large studies which showed that NOAC and DOAC actually reduced the risk of stroke. But just look at the bottom line, the discontinuation. In all these large randomized trials, nearly 20 to 25% of patients actually had to discontinue anticoagulation for some reason or the other. Now, these were patients who were carefully selected and followed up in clinical trials, and even in them, nearly 1 in 4 patients were not given finally anticoagulation and did not get the protection that they should have for one reason or the other. Now, AF patients thus are suboptimally treated. Wherever anticoagulation is contraindicated, we can't give them anticoagulation. Wherever they're unable to tolerate anticoagulation, we can't give them anticoagulation. And those at risk of bleeding, somebody like the frequent fall, they are also unable to be exhibited anticoagulation in the doses and in the kind of protection that we need to give. We're not able to give them. We close it for primary and secondary prevention. There's no symptomatic improvement in these patients. So we need to do a safe procedure in all of them because the patient walks into the hospital and needs to walk out. It's very difficult to manage in case you have a complication. Now, these are the recommendations which have already been gone through. I'm not going to look at them at all. Patient selection and planning also we have seen. These are the devices available, and we're going to look at the Watchman today. These are the competitors, and these are all the various devices that are available. Now, Watchman, these are the basic structures of all of them. The Watchman and the Watchman Flex, what's available in India, are all preloaded onto a 14 French sheath. And we've seen the procedure pretty carefully. We'll just see what we need to do. The randomized trials with Watchman resulted in its recommendation for use, FDA approval for use of this device. But there was just one problem, that because of the design of these trials in which they were given anticoagulation for about 6 weeks, any patient who cannot receive anticoagulation was actually a contraindication at the time of the initial FDA approval, but that has been worked away with, done away with now. It was approved in 2015 for patients at increased risk of stroke and systemic embolism based on the CHA2DS2-VASc scores and deemed by their physicians to be suitable for warfarin therapy. Now, this is a little funny because in the whole point of doing it is in patients who cannot tolerate anticoagulation, but this has been pretty much done away with now. and they have an appropriate rationale to seek a non-pharmacological alternative to warfarin, taking into account the safety and efficacy of the device compared with warfarin. It still remains the only device that was compared head-to-head with warfarin to look at safety and efficacy. The LA Appendage Occlusion Registry, which was published in 2022, looked at 36,000 patients who underwent Watchman procedures between Jan 2016 and December 2018, a mean age of 76, a mean Charles score of 4.8, a mean Hasbled score of 3. Now, 25% of these patients had a prior history of stroke and 69.5 had some clinically relevant bleeding, including 11.9% having intracranial bleeding. So this group of patients were actually much sicker than what were recruited in the trials. They had many, many more comorbidities. They were older than the patients who were recruited in the trials. What did they find? Primary endpoint of ischemic stroke as 1 year was 1.53, and the secondary endpoint of ischemic stroke or embolism was 2.19%. 1 year major bleed was 6.93, and most of the bleeding was within 45 days of the procedure. This was because the FDA approval was only in those patients who could receive warfarin for 45 days. This has been done away with now in most places, even in the US. The data is useful, that's what the editorial said, but it's dated because the Watchman device has been replaced by the next generation devices, and that's true. Future studies for risk of anticoagulation, and the newer generation Flex was not part of these 36,000 patients. So you can imagine that we used an older generation device, was used in these group of patients, and still they had excellent results. And a real world analysis of Watchman LA appendage occlusion provided reassuring evidence of efficacy and safety, and reaffirmed this as a viable therapy for stroke prevention in AF, who are not good candidates for anticoagulation. This is the trial versus registry. As I've already said, the clinical trial participants were actually sicker, older, had more comorbidities, had higher CHA2DS2-VASc risk score, and the hemorrhagic risk, stroke risk was much, much lower, with a lower mortality in the clinical trial patients in contrast to those in the registry. Now, the other issues, the ASA Plavix feasibility study with Watchman showed that all-cause stroke and systemic mortality was 2.3% per year, and this was 60% lower than would be expected in a population with this mean CHA2DS2-VASc score. That means it was actually half or less than the risk of bleeding, which was theoretically predicted by that CHA2DS2-VASc score. And the ASAP2 showed that the assessment of the Watchman device in patients unsuitable, they used DAPT, as I said. The warfarin recommendation has pretty much been done away with now. A common refrain is that it is more expensive than anticoagulation. This is just a chart which shows you the cost of patients having either receiving NOAC or receiving warfarin, and the cost of a bleed or a cost of a stroke in these patients. And it's estimated that if one uses warfarin, it pays itself back in 3 years. If one uses a NOAC or a DOAC, it pays itself back in 5 years. So if a patient has got 5-year survival, this is an excellent modality to treat him. And you're actually going to be saving money and not losing money. It's just that you pay it all upfront and you don't pay it distributed over time. So currently, it's offered as an alternative to anticoagulation, but it can be offered, but we usually use in patients who cannot, will not, or should not take anticoagulation. So we optimize patient selection, define the risk. There is some stroke risk even after the device. Right at the beginning, I said most, but not all strokes originate in the LA appendage in this group of patients. And it's important to eliminate residual risk, leak, because that remains a significant risk factor for residual stroke risk in these patients. What happened to our patients? As we've spoken about, once we counseled, what did we do? This is done in a controlled environment, as has been shown beautifully. Ideally, the echocardiographer should be involved in the screening. We always take the measurements on the table again, because you don't know what the LA mean pressure is going to be, and sometimes that makes a difference as to what size you're going to use finally. General anesthesia is preferred. We still use general anesthesia because we try and use sometimes apnea at the time when you actually want to deliver the device. All members of the team should be familiar. It's best to go over step by step, especially rehearse the important steps with each member of the team so that everybody knows exactly what they're doing. Keep the cardiothoracic surgeon informed. He's your best friend if you need him. Have a pericardial drainage kit, but don't be scared. With the newer devices, this risk is pretty small. Consider protocol for anticoagulation procedural antibiotics. This is important because in India, we still don't have idarucimab easily available. And if you do have a leak, then you're in trouble, because if you've got a DOAC or a NOAC on board and the patient has a bleed, it's very difficult to reverse the anticoagulation. So we have switched our practice. We switched them to warfarin or we stop it 3 days before and take the risk of whatever happens. We're going to screen them anyway on table before we actually start the procedure. Again, I'm emphasizing this because we had a patient in whom we had a leak, and then we struggled for a couple of days until we were able to get him to stop bleeding and stop leaking from the effusion. So we do a TE at the beginning, as has been spoken so elegantly. We look for a baseline pericardial effusion, because if you've not done it at the beginning, you find at the end, you're not sure where it's coming from. So if it's there at the beginning, you just measure the size and be sure that yes, because these are sometimes sick patients and they have effusions for other reasons as well. We assess the mitral valve, look at the left upper pulmonary vein, and as been said, ideally you should put the echocardiography screen right next to the fluoroscopy screen so that you don't have to turn your head or look at the back somewhere to look at the screen of the echo machine. Assess for the thrombus, and if it's present, treat with an anticoagulant for at least 4 weeks. Assess for the size of the PFO and the location of where you're going to puncture the septum exactly, and assess the size. Again, we're not going to go into the details because that has been spoken of. We select the size based on the maximum LA appendage ostium, and the depth must be as long as the width. This was especially important for the old generation of Watchman, but not so much for the Flex, because the length of the device is actually much shorter than what used to be available earlier. Right femoral venous access. Consider no arterial puncture. We're gradually moving to this, and we use the radial artery for pressure monitoring. You can just put in a 4 French small pressure monitoring sheath and use that to monitor the pressure. The septal puncture is done under TEE guidance. We don't need to go through all the views. You just need to put in your Mullins sheath where you want to and check on the echocardiography where you are. Look at these two views. You should be posterior and inferior so that you can reach the superior structure that the LA appendage is. This is how it's done. You don't need to change any view. This is done just in an AP view. Your echocardiographer will show you exactly where you are. You can tent it nicely, and then after puncturing, heparinize and get the LA mean up to at least 12 millimeters of mercury. This is important because the size measurements need to be done after you have an LA mean of 12 millimeter mercury. Heparinize, we used to wait for the septal puncture to do the heparin. This also we have changed. We now give about 2,000 units of heparin before starting or before doing the puncture, because you've got arterial access on board. And if you don't have, and then sometimes you have a little bit of thrombus, it's a little bit of an issue. We complete the anticoagulation after we have crossed the punctured the LA septum. We measure the pressure, and then you can give up to 500 to 1,000 units of saline, LV function permitting, to try and get the correct size that you're going to measure, both on the echocardiography as well as on the angiogram. And this is obviously dependent on the ability of the patient. Now, we perform the sizing after the LA mean measurement. There's a screening TEE done usually before, but the exact sizing is done after we have got the LA pressure up to where you need it to be. This is sometimes often different. Up to 20% of the time, it's actually better, it's little larger. So many times they're empty stomach because the anesthetist wants them empty stomach, and they are not actually volume optimized prior to taking the measurement, and you end up with the wrong measurement at the end. CT scan, multi-slice CT is something that we are working on to try and get the size and shape of the LA appendage, but that is, we are not yet good at interpreting that, and there's a little bit of a learning curve with our radiologists. As has been spoken, we place the wire in the left upper pulmonary vein, advance an exchange length super stiff wire there, place the Watchman access sheath through our septal puncture. This has been elegantly shown. I'm just going to summarize the steps. And now we introduce the pigtail into the LA, confirm the size, and this is the time when, after doing this angiogram in the views that have been shown, the caudal and the cranial, we look at the echocardiography, we look at the size, and we look at how many lobes we have, what size of device we're going to get, etc. And then, as has been spoken of, we bring the pigtail back and gradually maneuver it into the superior most lobe. Now, this is something that is extremely important, especially when we're doing the Watchman. And you'll see that in this case, we didn't use the double curve sheath. We had the single curve sheath. And this is up to you. Once you have an appreciation of the anatomy and how much of clockwise and anti-clockwise torque you need to do, it's important to get used to one system, and you can continue with the same. We were students of Saibal Kar because he came and taught us, and he taught us with a single curve, and we've managed with the single curve perfectly well. We use the pigtail to manipulate into where we need to. And we use the double curve for the amulet, but for the Watchman, we're still with the single curve, and we've not had so much of an issue with it. You can see it's going up into the superior most lobe, and all sheath manipulation is done on the pigtail. Once the sheath is in the superiormost curve, now the watchman access sheath should not move once we've positioned it there. So the left hand is fixed, and this is the time when we need the anesthetist to make sure that the patient is absolutely deeply sedated. We don't want him to move at all. Sometimes even remember the LA appendage is a very, very thin structure at its thinnest point, and we don't want the sheaths to go and meet the tip at all. The watchman delivery sheath is already available preloaded. So we have taken away all the air from it. Usually at the time of the septal puncture, after we make the first measurement, is the time when we decide what device we're going to use. It's completely flushed. There's no air in the system. And we introduce the delivery sheath with the preloaded device into the watchman access sheath. The marker bands, as have been shown, it will allow you to position the device with the sheath. And we retract the access sheath until both snap shut, as has been shown in the nice live case that was there. Now, this is the device deployment, and you can see that we are actually unsheathing it. Before the unsheathing, it's important to appreciate the axis of the LA appendage in relation to the axis of the sheath. I think somebody had asked the question about the cable. It's a great point, because sometimes if you do have a little bit of different axis, you may have to do it again. And this will reduce your requirement of resheathing and unsheathing and then taking the device back again. And the device is gradually unsheathed. And then you do a small tuck test for stability. And you can inject contrast at the same time, and that will achieve both your aims at the same time. You can see that the device is being tucked, and to see whether it goes back into the same position again. This is the echocardiographic position. These are the two classic views that have been demonstrated earlier, the 45 and 135. Now, does the device pass? We've spoken of the position. That means if it passes only, then we let it go. So the position, the anchor, that's the tug, the size as to whether it's been compressed enough, and the seal. Is there a 3 millimeter or more leak that we need to cover? Once it passes these 4 criteria, so position is both on the superior, the inferior aspect. The anchor is whether you're able to tug it and push it back into the same place. The size is whether it has been compressed adequately, that you can see both on the fluoroscopy and the echocardiography, and the seal, which is almost exclusively on the echocardiography. The injection of contrast actually enhances your ability to pick up if there is any inadequate seal. These are the same 4 that we have spoken to. All the lobes need to be covered. This is very important. And this is the post-deployment echocardiographic assessment and the 3D as well. There's no doubt the 3D gives a completely different and excellent perspective on whether the device has been seated properly or not. You can see that we have managed to get the axis of the device perfectly well with the axis of the LA appendage, so that you get sealing off of the device perfectly. So the IFU says that there should be only 20%, but most of the time it's much, much more. Up to 40% is acceptable, but usually it's around 30% or so shoulder beyond the mouth of the LA appendage. Oral anticoagulant for 6 weeks, this is what we used to do, but we are off now. We just use DAPT alone for 4 weeks and then come back to a single antiplatelet depending on the baseline risk of the patient. We do a follow-up TE at 45 days. Yes, always it's done. And then a follow-up TE at 1 year, because there are some small incidents of delayed leaks. In summary, non-valvular AF patients at risk of embolic stroke with bleeding risk, or they have a contraindication for anticoagulation, is the subset that we're actually looking at. This should be performed at a center with expertise for structural heart disease and at low risk for complications. And this is important as far as the the procedure is concerned. We need a little bit more randomized trials before extending indications to other ones. And currently we are using it for patients with no alternative. But for us to reach a stage where we're able to offer it as a parallel therapy to anticoagulation, we're not yet there. As I said, we're still using it for patients who cannot, will not, or should not take anticoagulants for some reason. Thank you for your attention. I should be glad to answer any questions.
Sir, a very excellent presentation. Two things we want to know from you. One, which are the patients who are at high risk even after deploying the disclosure of the left atrial appendage? That's the one. And second, you have already told that 6 months of anticoagulant is required, and you are shifting to the DAPT. So that is for 6 months or for even longer time, DAPT?
So DAPT is essentially for 4 weeks. After 4 weeks, we're switching to a single antiplatelet depending on the baseline risk of the patient. I mean, if he's got an indication for DAPT because of a PTCA or something, he goes on DAPT, but we are just using 4 weeks of DAPT presently. That's the first thing, not 6 months. I mean, I don't know, it was 6 weeks.
6 weeks, yeah. 6 weeks, yeah.
6 weeks, not 6 months. Yeah. And the earlier question was yes.
Yeah, the
So
first question was
device-related thrombus and the residual risk of stroke. This is the Achilles heel of the LA appendage occlusion therapy. And we all know that there are patients who are going to have a prothrombotic milieu because of their intracranial disease and because of their carotid disease. So they remain at risk of stroke. Every patient is going to have multiple factors which are going to cause him to have a stroke. This therapy is ideally for those in whom the risk of stroke is almost exclusively originating from the LA appendage. There will be a group of patients who have got risk of strokes from other sources because of atherosclerotic disease of the carotids and indeed the intracranial vessels as well. And you can't say that we are not going to save them, but it is important to remember that we are not eliminating the risk of stroke, we are reducing it. It is estimated that nearly 15 to 20% of patients, this residual risk of stroke will still leave them at risk of stroke. And this group, in fact, is the group who are going to have a stroke even after you do put the LA appendage. We are not yet perfectly at that stage where we can predict this to perfection or even with any degree of certainty. All trials are designed for populations. And the only thing we can say is that large registry-based data of 35,000 patients or more from US and nearly 15 to 20,000 patients, registry-based data has shown a significant reduction in the risk of stroke and bleeding in patients who undergo LA appendage. But there is still a subset who are going to have a stroke, and this is not just device-related thrombus. This is also related to the underlying stroke risk that the patient has when we started out with.
Thank you. Thank you.
Thank you, Dr. Ajay. Now I would request Dr. Ramesh Dagubati to discuss about mitigation of LA closure device-related thrombosis and post-closure patient care.
So this is probably towards the last talk of this session, and you have heard a lot of talks about how to implant the device, and you have seen fantastic case in boxes. Can I have my slides, please? But then this is a contentious talk, and what I'm going to tell you about. So just because we put a device in doesn't mean that we have taken care of all the issues all the time. So this is a moving target. When we started, similarly, we would like to say that, there's no problems at all with the Watchman device, or ours is a predominantly Watchman device until last year. Now we are, it used to be 100% Watchman. Now we are about 80% Watchman, 20% amulet. So I have no relationships for this talk. I'll skip these slides because we heard about it. Okay, so this one also you saw in the morning, so we are now doing concomitant procedures. You can do it with the EP procedure, ablation plus Watchman at the same time. And that's called option trial. The results will be out soon. And the new trials are looking at actually not even considering anticoagulation. Right now Watchman is indicated on only anticoagulant intolerant patients, meaning they have to have a risk of bleeding and had to have bleeding and all that, intracranial or GI bleeding. But can it be given as an alternative to anticoagulation? So that will boost the guideline recommendations to much higher 2A or even class 1 in the future. So it has become very simple, right? The procedure itself doesn't take that long, and so it is now quite simple. And the safety endpoint is also very good. I mean, we do now about 200 procedures in the United States. The registry is about 86,000. I'm just looking at the this year, rolling 4 quarters, meaning including quarter 1 of 2024 to 3 quarters of 2023. We have done about 174 Watchman procedures, and we fluctuate a little bit between 175 to 200. So we had 0 ischemic strokes, and in this 1 year after the followed up, 0 any other complications, but the only complication, one patient out of that had a device embolization in a clinical trial with a device which is the conformal device, but that will count against us in registry as well. So, but that said, if you look at all the devices, it's only 0.5% event rate, and of ischemic stroke, all-cause death is 0, and 0% pericardial effusions. And so we had one patient, so that actually makes it higher. Device embolization, we had one, so that actually makes it higher. So this has become very safe. The issue has always been with the device-related thrombus. And here, we have 4 people who are performing structural interventions. We have 4 of us are not in agreement. So that's why I made a policy, because we have to make policies sometimes to make sure that if 4 of us don't agree, then the senior person, which is me, I'm not the senior most person, but I'm the one who's holding the position as the director of structural heart. We have to come to an agreement, but this is how it is going to be, because 3 out of 4 are in agreement. So one person was not in agreement about device-related thrombus. So what we are trying to say is that one person wants to use only DACT in all the patients. And as I mentioned earlier, in United States, there's a national coverage database, which is a NCD, that is the one CMS or Medicare insurance company like Ayushman Bharat will mandate that they will pay if you meet these criteria for left atrial appendage closure. One is the patients have to have a CHATS-VAS score of more than 2. The next one is has to have a Hasbled score that he cannot tolerate, history of bleeding. Number 3, that he should be a candidate for a short-term anticoagulation. So the first 2 are met very easily. The third one, if we don't document that he is a candidate for short-term anticoagulation, they will not actually pay the money for the procedure. But that said, it also made sense. So we used to discharge the patients on DAPT. And after looking at our device-related thrombus in our own institution, we said, we are probably doing something wrong. And we went back again to actually giving short-term anticoagulation for 45 days. And I have reviewed several abstracts that came to ACC that actually device-related thrombus is higher, and people have increased the anticoagulation period for 3 months. So this is a moving target. So just because we can use it, we can use DAPT in majority of these patients, doesn't mean that is the right thing. So if you start looking for device-related thrombosis, you will find a lot. And especially with Watchman Flex, initially when we got Watchman Flex and we started doing CTA, the CT heart morphology started detecting, or at least our images started reporting higher DRT rates. That was not actually DRT, that was the fabric of the device. So you have to be clear, is it a truly thrombus or a fabric? So then on TEE, this is actually looking at it, even amulet is 2.1% and 5.5% in Watchman Flex. And so it is higher with the Watchman devices compared to amulet in these 2 groups of patients. We need to, this is a Swiss Epiro study, and obviously it's not a huge number of patients, only 107 in each arm or so, but take it with a pinch of salt that maybe if you start doing more and if you start looking at each and every patient with a highly sensitive imaging test, you will find more device-related thrombus. But let's look at another registry. This is the Evolution registry, 835 patients. Incidence of device-related thrombus is 4.1%. And predictors of DRT are long-standing AFib, spontaneous echo contrast, and large left atrial appendage. And medical treatment did resolve the DRT in these patients. There's no increase in risk of stroke, because I think the moment you detect thrombus, you have to start oral anticoagulation immediately. So, but if you look at other trials, what is the incidence of DRT? And the DRT rate, is much lower. Only DRT positive is 65 patients in that. So it is like about 4% again in these trials as well. But people who had DRT or device-related thrombus had ischemic stroke and systemic embolization is much higher, and all stroke or systemic embolism in those patients with all is also much higher than people without DRT. How about device-related thrombus in CAP2 and Protect AF and Prevail. So Protect AF and Prevail, the DRT was much higher, and ischemic stroke or systemic embolism is in both CAP2 and the Protect AF Prevail studies was not much different. So these suggest that the longer the patients are studied, there might be a higher chance of DRT. So look at this risk of stroke. Yes, compared to patients who are not on anticoagulation, their expected expected risk of stroke based on CHATS-VAS score is 6%. And with oral anticoagulation, it comes to maybe around 2%. And in the LAAC cohort, they still had DRT negative with about 2%, and only about 0.3 or 0.4% had a DRT positive. But that small group of patients did really bad in terms of strokes, and one stroke itself is very harmful for those patients. So how do you make sure that there's no DRT? Place the device properly. You need to assess them very clearly. Don't don't keep the Watchman device a deep implant. Deep left atrial appendage implant is actually a risk factor. More than 10 millimeters from the pulmonary ridge itself is a risk factor for DRT. Renal insufficiency, and again, long-standing atrial fibrillation has been shown. And the outcomes on these patients in major adverse cardiac events, as we talked about, is very bad. So then the next thing is actually sometimes you also can, somebody commented about the person who's preparing the device was not scrubbed in with the gown. Absolutely. This is one of the procedures that actually, along with all structural procedures, coronary procedures, I know we can walk in without washing our hands and put gloves and go in and do the procedure. The risk of infection is very low. The risk of infection could be high. We actually explanted another hospitals in the same town. That patient was referred to our surgeon because there was actually pus coming out of the left atrial appendage through the Watchman device. I don't have that picture, but it's really bad. So you want to make sure you really scrub like a surgeon for at least 10 minutes before going in. So this is our own study looking at from our institution about cardiac CT in evaluating Watchman flex devices and single center retrospective. So, and then we started talking about this hypoattenuated thickening, such as similar to what we have in TAVR patients. So this is a device shoulder we were talked about earlier, how much device the shoulder is extending. So that is a gutter. So that gutter is a place where thrombus will form. How deep is that gutter? So sometimes it is better to tug back and let it release. Don't push it back. Obviously all of you have done so many ASDs, your tension, we all tend to do. Tug means push and pull, right? Pull and push it back. No, don't push it back. In Watchman, you are not supposed to push it back. You are supposed to tug is pull and let go like a pinball and let go. Let nature take its own course. But by pushing, you'll create a gutter, and the gutter is the place where device thrombus will form. So here you see TE images without contrast, and there is you can give definity if you're in doubt, and you will definitely see clots over there. And where the arrows are pointing in those places, and those are the points that we want to avoid. And so even recently I saw like just a 0.5 millimeter clot on an amulet, and I gave a patient was on DAPT, and that's, as I said, that sometimes we put on DAPT because IFU of both of these devices say DAPT is okay, but the government doesn't agree. So we still made a policy that we'll follow the government rules, and because that's what actually will help us get paid. So that patient who had a DAPT and because of high risk of bleeding and cannot tolerate, I said, okay, let's try for 3 months, and patient was able to tolerate it, and repeat TE showed there's no clot. So CT is really good. CT is very sensitive, super sensitive, because sometimes it may sensitive so much that actually it'll pick up even the fabric that it can be maybe people will misinterpret as clot. So, but this is a very, there's no doubt, sorry. There's no doubt here that these are clots here, So wherever you can see that that's a clot, So these are the DRTs that we are worried about, and how big they are or how small they are doesn't matter, because even this minutest one can cause a very a stroke that is very massive. So we need to treat that appropriately. So is there a gender disparity? We looked at from our center in our from multiple registries, whether the men or women have any problems in their DRT, and there's no meta-analysis showed that there's no difference between men and women. And the UROC DRT registry showed that again, these are the places that the common ones are actually people who's have gutters, whether it is with Watchman type of devices or with actually even with amulet type of devices, the pacifier type of devices, Lambre and Watchman, amulet. Also, if they're too deep, they will form blood thrombus. So how do you manage these patients? Who are the people who had thrombus, first of all? People who are on single antiplatelet agent, 26%. By the way, Boston now has a new device called Watchman Flex Pro, where it is actually FDA has agreed for a single antiplatelet agent. So we might be seeing more DRTs when we start doing that, in my opinion. 54.7% of the thrombus on people who are at actually, that's what the discharge was, sorry. Our discharge was DAPT, and very few people had been discharged actually with oral anticoagulation. But as the DRT was found in these patients, and the majority of them were treated initially with heparin, then vitamin K antagonist, then DOACs, and 32%. And so it all changed how we manage these patients. Majority of us, I actually start them on DOAC, and if there is thrombus in 3 months, then I switch to warfarin. So this is the two types of devices that we said. Non-pacifier type clots can form in these mainly in the gutters or on the sides, whereas the pacifier type such as again, if the device was here, probably the risk would have been low, the disc, but the disc is here, so it is deeper and it is a little bit increasing clot formations. So these patients, after how many days after left atrial appendage should we continue? As Dr. Ajay Swami said, 6 weeks. Yes, 45 days is the study. But who is to say that 45 days is the gold standard? Just because a couple of studies prevail and Protect AF showed that it is 45 days doesn't mean you cannot give it for 3 months. In people who are long-standing atrial fibrillation, again, who have deeper implants, maybe right from the beginning, give it for 3 months. It doesn't hurt. If patients, as long as they can tolerate. If they cannot tolerate, that is a different issue. So in people who are at a high risk, that's what I do in my practice, and at least for 3 months until it is completely endothelialized, and then they can switch to aspirin and clopidogrel for 6 months, and then aspirin alone after that. So the characteristics and how 20% of the DRTs are detected later than 6 months. 20%. So you think that we are done with 45 days and send them home and they might have a stroke. And then you're wondering, why did they have a stroke? Because of the DRT. And so if you treat them appropriately, 80% of them are responsive to anticoagulation. And higher rates of mortality, 20%, and stroke is of 13% in people who have DRT. So my advice is that don't just say the same thing for every patient. Look at the high-risk features, deeper implants, long-standing atrial fibrillation, renal insufficiency. Try to see if you can prolong the anticoagulation. If they don't have these high-risk features, maybe shorten the anticoagulation to 45 days. And so how to minimize DRT? Endothelialization may take time, and the more you look for it, the more you will find DRT. And sometimes people will say, then don't look for it. I don't think that's the answer. Aspirin and Plavix after day 45 may not be effective in some patients, and a reversal of heparin with protamine might have some risk. So this is the other one actually. We started very weird. One time actually I was doing a TAVR, and we finished the TAVR in 15 minutes, but the echocardiographer was still educating the fellow and playing with the TEE. And then we see a clot on the TAVR valve. We gave protamine already, and after they were still doing TEE, thank God I didn't scrub out yet. And so then there's a clot on the freshly placed TAVR valve. Right away it formed. It took maybe 5 minutes for the clot to form after protamine. So be careful. Prodamin, and so then we started saying that, again, same thing. There's no consensus among our own group. One person gives Prodamin, and the three of us don't give Prodamin. We actually say that if it's a venous stick, how bad it can be. So we can put a figure of 8 stitch, and actually in India, there's no cost for keeping the patient overnight. For us, we try to send the patients out by 4 hours. They come in for a watchman or a amulet, they go home in 4 hours out of the hospital. So, keep them a little longer. It doesn't hurt. And use oral anticoagulation beyond 45 days might reduce the DRT in those high-risk patients. Imaging is key. Spend time during TEE to look at left atrial appendage in different angles, just a sweep from 0 to 135. CT is excellent in experienced hands. I did say experienced hands because sometimes people misinterpret the fabric for a DRT. And repeat TE or CT, usually like 3 to 6 months after DRT detection. As long as it is not expensive, why are you worried so much? Getting a TEE, you just get a TE. As I showed you, 20% of them happen after 6 months. Management, continue oral anticoagulation for longer periods. In patients who are not good candidates for oral anticoagulation, maybe even consider if they have thrombus, the surgeons can actually do some mini thoracotomy, or in our center it is robotic always, and they can go, they suck out the clot, and they can ligate the appendage, they can do Cox maze, and so cure. Our surgeons have actually published data of a 98% cure rate for atrial fibrillations with their Cox maze. So in such complex patients, we send them to the surgeons. And so take home message, DRT is less than 5%. Patients with DRT have poor outcomes. Imaging is a key for diagnosis. And I think treating them for longer time with the oral anticoagulation or surgical ligation is recommended. Thank you very much.
Any questions from the audience?
Excellent talk, Dr. Ramesh. Just one question. A patient already had a intracerebral bleed, or the indication for LA closure is a prior hemorrhagic stroke or a massive GA bleed. So what will be your anti-thrombotic regimen after the device closure?
So, what would be the anticoagulation?
Yeah,
So actually, to tell you the truth, 90% of our patients are already had huge or massive GI bleeds.
Okay.
So, and meaning that their hemoglobin sometimes had dropped to 3 grams, 5 grams, and then they receive blood transfusions, and then they're referred to us. Or they're referred by neurosurgery after an intracranial hemorrhage. We get frequent consults for that. And we re-challenge them. We ask the neurosurgeon, when can I give them anticoagulation? And we actually ask the question, they will write back to us, so wait for 8 weeks, and then we can. So that's when we do the procedure. We re-challenge them with oral anticoagulation for 45 days, and follow up with a CT scan as well.
So you still give 45 days for them also? Pardon? You still give 45 days
Yeah,
for
we
them
still give
also?
them for 45 days.
45 days.
Yeah.
Okay.
Thank you.
Doctor, one question. Like when the patients who are especially on the very high risk of thrombus formation, like huge left atrium and chronic atrial fibrillation, so do we exclude them for going for the procedure, because we have to give in that case anyway, anticoagulant is needed?
Yeah. No, so we have a combined approach at our center. We actually evaluate patients for, as I said, robotic procedures as well as catheter-based procedures. So in such a patient, sometimes actually we try to ask the patient, is the patient agreeable to go for a one-time, one-stop shop, meaning they'll get robotic Cox maze and ligation. And as I mentioned earlier, it is very successful at our center. Thank you.
Very nice presentation.
Yeah.
Very nice presentation. So.
Thank you. I think we'll move to the next session. Thank you very much.
Thank you, Doctor. Thank you for the wonderful talk. I would request Dr. Ramesh Dagupati to give memento to the speaker, moderator, chairperson, and panelist. Dr. Munish Tomar, Dr. Ajay Swami, Dr. Mukul Bhargav, Dr. G.J. Shetty, Dr. Ravindra, Dr. Baijulal, Dr. Bipin Kumar, and Dr. Bharat. Dr. Bijulal,
We now start with the session 4, Lambre Symposium. I call upon the moderators, chairpersons and panelists for the session, Dr. Ramesh Dagubati sir, Dr. Ranjan Shetty sir, Dr. Biju Govind sir, Dr. Praveen Srikumar sir, and Dr. Anil SR sir.
Yes. So if I play it, light, one year. There it is. Good evening. I hope you're not tired of seeing our faces now. After this is the third case which we are presenting. So this one is a case of Lambre because we are starting the Lambre symposium. So you realize when you do LA, although it's one thing, there are some device specific things which you should learn. So we are going to have some discussion about pre, post, starting with a case so that we are oriented. Then we'll go to each step of it. So PhD and has AF. So the planning to close both LAA as well as ASD. ASD is not too big. It's around 14 millimeter. But the SVC rim is a little flimsy. But she's 58-year-old. PA pressure in echo is around 50. So we did the CAT now. The actual PA mean is only 32 and the pressure is not high. But still the plan is to do a balloon occlusion and then decide whether we need to do, whether we can close the ASD. But we can definitely close the left atrial appendage can definitely be closed and then So this is a case where there is ASD and AF and contraindication to anticoagulation. So as you are aware that adult ASDs when they come like this with some pH or NICO, the one problem is Eisenmengerization, but that's not a common problem. Common problem is they are used to this ASD for ages, and now if you close it, they might end up with pulmonary edema. So one option is to use those fenestrated devices which are available now. And so the first thing what we wanted to do is to balloon occlude, see whether the LVEDP rises. The PA increase is not a problem. So that's what we wanted to do, and obviously we wanted to do it before we do the LA appendage closure. But if you look at the ASD itself, the ASD is more superior and probably more anterior. So typically not the site for LA puncture or LA closure. Ideally your puncture should be somewhere here, but we have a ASD which is here. So these are the cases where we use the conventional sheath, not the double curve. If you use the single curve, we can. We wanted to try it through the axis because if you're anyway going ASD, it doesn't make sense you create one more ASD. So that was the plan. So first what we are going to do is to cross the ASD. T is already in. This patient required intubation, unlike the other previous patients which were all done through DexMed. She is obese, and we think there are more than one reason for PA, pressure to be high. Now I've crossed the ASD with MPA, and we are planning to enter the pulmonary vein. We went to right pulmonary vein, but we will go to the left upper if possible, and then we will do the balloon occlusion. Through radial, we have already kept pigtail in place to measure LVEDP after balloon occlusion. So now I'm in pulmonary vein, and we have got the balloon ready for balloon occlusion. So the question here is, should we use the same puncture for LA closure, or should we use a different? I think we will first document whether it can be closed, and if it can be closed, then we'll try to do it with the same axis. So hold here. Okay, so let's take the catheter in. Yeah. Are we in the upper pulmonary vein, Kavya? Yeah, can we come to LAO? Come to LAO? Yeah, we could be in the lower pulmonary vein. Just to see in LAO that, see, we are beyond the heart. We are in the lower pulmonary vein. Amplanza? So now here, using here, we will keep this one. Come. Is the balloon ready? Yeah, balloon occlusion, we'll keep it ready. Come. And we are going to now take the balloon. Yeah. This balloon would go in which French femoral sheath? 11. Yeah, we already have 11 sheath. Get the balloon now. You can come AP. Yes, get the balloon here. Come. So the first step is to see whether the LVEDP rises. LVEDP is already between around 12 to 15. So we need to see whether it rises. And Kavya is on echo, so she will see whether we have closed the ASD well. Yeah, holding. Yes. So we're going to go now. Yeah. So the balloon is already come. So in these cases with the, say, elder, yeah. Come AP, can you show? Yeah, can you? Yeah, we can see the balloon in fluoro. Can you inflate the balloon slowly? Yeah, inflate slowly. Yes, slowly. Yeah, is the balloon giving inflated, Kavya? Yeah, now, yeah. So can you deflate it? I think it's too much into RA. So I'm going to push it a little more and take it to, yeah, now inflate, yeah. Inflate, yeah, slowly, not too much, yeah. Inflate, yeah, slowly, yeah, enough. Close, lock. Yeah, now let's put the color across.
Some flow, we may have to increase the inflation slightly. Increase. Yeah, not too much. Yeah. Lock now. Yeah, see the flow, Kavya? Yeah, still some flow. Yeah, come, increase the inflation further. Yeah, now close. Yeah, we can see. Yeah, flow is now stopped, no? Almost complete occlusion of the flow. Yeah, little more inflation. Not too much. We don't want, yeah. Now the flow is obliterated and we will look at the LVEDP. Now this, we should at least wait for 5 minutes or maybe more. But now the flow, what you are seeing is probably not through the device. And can you just check the gradient across that? Yeah, no, yeah. Yeah, the balloon is half in, half out. Or is it fully in RA? It is in more out. Yeah, but it's you have to do a long axis, I think. Long axis. In short axis is getting, yeah. Long axis, yeah. Yeah, balloon is where it should be, no? Little more long, yeah. See, the flow is occluded. There's no flow. And we are looking at LVEDP. Can you put the timer on? Timer on? Yes. So we'll wait for 5 minutes. I feel, the LVDP is almost same. We had a slightly elevated. Yeah. Balloon is more in RA, I guess. Yeah, what we'll do it again. Yeah, deflate. Yeah, deflate fully. I think I'll go more to LA and then we'll do deflate.
Rajan, how do you know that your balloon is not going to damage or going to create more ASDs?
Correct. So
what you started with?
Yeah, we have to be very gentle. Look for that, look for that. There's a waste which was seen here. Be very gentle. Don't be very fast. And under echo. Whenever you are seeing, when the flow stops, just stop there.
So what Horst taught us, see what, that if you attach a three-way and you inject through that, syringe and check the pressure on the sideways, like you turn the pressure. If the pressure is not increasing, you are just doing good. Once you have a stretching or kind of constricting balloon, you're giving too much, then the pressure from the side port will start increasing. Intra-balloon pressure will go. So use three-way and then you check the pressure intermittently.
Yes.
See that your pressure is actually flat.
Yes. We have a lot of, I think, pediatric cardiologists here in the group. So how many of you do this for your adult patient or
any pediatric cardiologist sitting here?
Many.
Yes.
Yeah.
Your comment, please.
Yeah.
Balloon
Mine
sizing is
there,
outdated.
Yeah.
They don't.
No, not
please
for
use your mic. Please use your mic.
Yeah. Not for sizing, Dr. Tomar. It's more for LVDP rise.
One is baseline assessment of the right and sided hemodynamics important. Adult and elderly patients, whenever we are going to close, especially atrial septal defect. Yes, when in doubt, then balloon sizing is important because
Correct.
Not for the sizing, obviously to look for the hemodynamic.
Look for hemodynamic, LVDP.
And in this setting, it is especially important because LA appendage volume, it's difficult to decide with atrial septal defect.
Correct.
You expect it to rise in pressure and the size of everything. So here it has a very important role to check the hemodynamics.
Yes, and once you see the turbulent flow across that balloon, you are almost sure that this is not closable, the ASD itself, and it was only 14 millimeter. So even if you put a fenestrated, you're still leaving 8 millimeters. So it really doesn't make sense. Sometimes the big one, you would want to put a device. I think 2 days after this, we did one where the LVDP rise, we put a fenestrated device of 22 or 24 and it has a 8 millimeter hole so that you have a controlled flow. You don't want to overload the RV and lead to RV dysfunction.
There is a comment from the floor.
Do we really need to do this LV EDP increase in large ASDs? Because nowadays with all these medications like ARNI and diuretics,
And
we
Viagra.
usually do not need
You have
it,
to
except in a case where you have a concomitant mitral stenosis as well, where you want to do closure of this ASD as well as opening this mitral valve, then only yes, because LV is already underfilled because of tight mitral stenosis. You want to open up the mitral valve and you want to close ASD. These are the cases where you would really think of rise in LV EDP. Otherwise, most of the time, I personally feel is that standalone ASD, Even if it is large, you close it, you have good diuretics, you have good RNAs.
It could
I
work.
seldomly.
Yeah, but I'll give you a little more history about this patient after we hear from
Anil.
Dr. Anil. Yes.
Anil, please.
Because knowing the hemodynamics is very important. So if pressures are not rising, because adult means beyond 40, 50, they can misbehave anyway. We have seen
Yes.
many issues. So it's better to go safely. If every baseline, everything is clear and you are okay with age and no hypertension, any doubt, better to check it. Then you can plan. You are going to extubate immediately after the procedure, or you can take few hours or next day. Plus control of hemodynamic diuretics, plus afterload reducing. So planning is important. Not in every case, but selection is important.
Yeah,
Where you should check and recheck. It is important. Otherwise, you just crisis happen.
Yes.
Right, Anil.
I used to add couple of points. Very nice thing raised. First of all, the balloon stretching usually don't damage. If we stretch for sizing, it is the balloon stretch diameter which is used for device closure. Nowadays, balloon is usually multiple ASD only we use. Otherwise, we
you
usually don't
use.
use. Regarding this LVEDP, it is very common after 40 years to have uh, latent LV dysfunction diastolic, which will not be detectable. So it's mandatory to check the LVEDP pre-procedure, and if it is more than 12 in some series, in our series what we published it's 15, then we are supposed to occlude that ASD with balloon, and then 10 minutes down the line again check. We don't know which patient is going to misbehave, and that is an acute phenomenon.
Yes.
So you cannot control that LVEDP rise causing pulmonary edema. That will happen usually within 6 hours or even on the table. So if we try to control that with RNA or whatever, that is an ongoing thing.
Yes.
Immediately patient will be wrong.
Yes.
So we should always check. If pressure is not rising, then yes, we can go ahead.
Right.
Thank you.
So,
Dr.
so let,
Krishnamurthy,
let me summarize then.
Yeah.
If you have
Dr.
right,
Krishnamurthy,
I'll allow you,
yeah,
sir.
yeah.
I'll allow you.
Go
So
ahead, sir. Go ahead.
Just a minute.
Yeah.
If you have a pulmonary artery problem, you can use Viagra beforehand to see that is coming down or not. You have the same phenomenon. I put the ASD device after TMVR or mitral clip. You see the right atrial pressure going up, right to left shunt. You have to take out the ASD device and keep it open.
Yeah.
If you have left atrial pressure, you make atrial shunt. So all these things are important. You have to understand the left, how the left behaves, how the right behaves. In a given situation, in a given patient, it may be a right choice. Not in all cases. Your comment, sir. Last comment.
Very interesting to note that that discussion shifts into ASD hemodynamics. 2 points. Instead of using a balloon to size it,
Device
we
itself.
use it a device so that it occupies less space and the hemodynamics is slightly
Better.
optimum. That is one. The other thing is, along with the LVED, we would also like to know the pulmonary hemodynamics. What is RV pressure? What's the PV?
PA pressure.
So that's right. So sometimes I had a case, I have used the device, waited for some time before releasing the device.
Yes.
Only thing is the wastage of the
Correct. That is the problem in our scenario. Just we cannot waste. If you need to take out, who is going to pay?
And this patient actually had exertional slight desaturation. So I was reasonably sure this is not closable to start with. I just wanted to define the hemodynamic. And the subgroup, this probably, if we had closed this, maybe extubation would have been impossible. So there could have been an acute problem which we saw. So the one more which we did, we put a fenestrated. Since the size was already 14, 14 and 8 doesn't mean anything. You're just wasting a device. So more we realized that this ASD should not be closed for now. So next I will go ahead with this was the actual balloon. This is for discussion. LVDP is rising. What is the pressure? No? LVDP is rising. So we will not be closing the ASD. I think there's a significant rise of LVDP which has occurred. So yeah, we will not close the ASD for now at least there. And with the anticoagulation, we are going to close that there. And don't think so. We bought those devices with the anticoagulation. We are going to close the LA and then plan for ASD. ASD probably is helping. Even while intubating Dr. Karthik, our anesthetist felt that the pressures are actually higher. So I think closing ASD will be harmful for us. So now we are going to keep this.
I'm going to remove the balloon. Can we have an MPA again? Yeah.
Funding is a big problem.
So can we have the MPA? So ASD will not be closed. Okay. So come MPA. And maybe a term. In this case, now the issue will be using a ASD to close LA. So we need to use a different, the curve has to be little different. Yeah, we are near appendage, I think. So I'll try to go to the upper vein. Okay. Yeah, we are on the right side. We don't want to be on right side for this. This could be the appendage or there could be a palm. This is definitely, are we in the appendage now or are we above? The wire, nothing is in the pulmonary vein, no? So we are likely to be in appendage. So I'm going to, yeah, now, yeah. Yeah, this is pulmonary vein. Yeah. So we'll have to hold it closely, close. Yeah. Allow the catheter to go. Yes. Yeah, now in, yeah. So, yeah. Come, hold it. Yeah. Give amblanza. Yeah, good. So we are in the pulmonary vein, maybe a little lower pulmonary vein. Come, amblanza again. And we are going to take a different sheath here. Normally, you know, for almost all LAA, we take double curve sheath. Can we go to LAO to just see the pulmonary vein? The wire in pulmonary vein is seen now. So we're going to go to, yeah, come, hold. Can you get the sheath now? The single curve sheath. We'll not use the double curve sheath. We'll use the single curve sheath. Come. Come, get the single curve sheath. Yeah, and flush it and keep it ready. Come. And then we will go to the this one. So it's a single curve sheath. Just take the this one and get ready. Yeah. So the loading and everything. Once this is done, we'll take out the yeah. So this sheath is slightly different from the other sheath. It's a single curve. Normally the curves are 45 and then there is an anterior curve of 30. This has only 30. Did you flush? Yeah, flush. Come. Plus this. Yeah, take the dilate. Yeah. Now get this one. Y connector ready. Yeah, plus that we need one Y connector.
Anjan,
I'm going to take it out.
just a point.
Yeah.
In two cases when it's very difficult to understand or enter in the appendage because of the bad puncture, I use a buddy wire. I mean, two wires. One was more. First wire was in the pulmonary vein, left upper pulmonary vein. So that becomes a kind of lighthouse all the time. And second where you try to enter the appendage. So you can enter both wires in the pulmonary vein. Keep the one wire in the left upper pulmonary vein, that becomes a lighthouse. Then you try to fall below that wire, so that becomes a kind of a marker rather than just trying all around the appendage.
I have just small question,
So
Dr.
we are
Ranjan.
going to
Dr.
get
Ranjan.
the single sheath in. Yeah. Dr. Bharat.
Yeah, just wanted to ask you, you took a single curve sheath because 90% of time we take double curve only.
Double curve sheath.
So any specific reason why you took a single curve?
So I
and
think
what are the situation where you take single curve?
Yeah, so 90 to 95% is double curve, especially if the puncture is posterior inferior. Then you want to go front, it's an anterior structure. You want something to look anterior. Alignment with the upper lobe will be easy and the device delivery will be easy. But now the ASD is actually very superior. It's very close to SVC and more anterior. So it is exactly where not to do. The position is where not to do. So that sheath is not going to go to the appendage and not align. One is sheath has to go. Second is to align itself. So this works well. So if you're going through PFO or if you're going through the ASD, then a single curve sheath which almost looks like your ASD sheath, just a curve. It is nothing special actually, just a curve. I think that is what we should do if you are doing.
I think
all 10 French
whether you take single or double curve, once the device is in, is always a single curve.
looks single, yeah. But
Looks-
still, you still that torque, it helps. If you have a double curve, it helps, especially if you are using Watchman. So if this doesn't work, we may do a septal puncture later, but right now we'll try with this. And we'll also need a pigtail because as we discussed, we do not take the sheath in or out. You only take the pigtail in or out. Come. We're going to take it in. Yeah. So it's just at the groin point, it is okay. I think echo also you can see the wire here. Yeah, come. Hold it here, please. Okay. The sheath, yeah, we are going to. Where is the Y connector? Yeah. Wait. Yeah. Yeah. So we're going to take, can you hold it here, please? Yeah. Once we remove this, fluoro, please. Yeah. I'm going to keep it there. Although we are in Pulmonary, I'm okay being there. LA pressure was, yeah, come. Connect the Y connector here. Okay, and a pigtail. Yeah. Get the pigtail. Sheath actually doesn't have a valve, so you need that 2E to be connected.
Can you use, Ranjan, if Agilis kind of sheath, if you have a
Yeah, if
available
difficult to
Ox kind of thing, new generation Flex,
Yeah.
Watchman Flex coming with a flexible sheath.
Correct. So there are times it's difficult to enter appendage. That's where we have to do. The thing about appendage is when you don't want to go, you always go. Like in BMVs, when you want to go like this, sometimes it becomes difficult. But generally the pigtail goes. If you straighten it slightly, it goes. Other thing is, what you have noticed, the mismatch between LA and LAA size. So in physiology like this, LA is big, but LA is still small. So there is a mismatch. Just because LA is big doesn't mean LA, left atrial appendage, will be big, and typically it is opposite. If LA is big like this, LA is actually small. Appendage is smaller. Yeah, come. And a pigtail. Get a pigtail now. So we'll get a pigtail loaded. So generally I keep the wire because it really helps to load the pigtail. Yeah, load the pigtail. Yes. And in echo, you can beautifully see the, this one. So little dye is ready. Yes, come. Hold the wire. Now I think the wire is in the pulmonary vein, but the sheath is actually only in LA because it's difficult to orient there. So just to keep there and pull it down makes more sense to enter appendage. Yeah, come. Push the pigtail. Yeah. So we're going to take the pigtail in. We know the wire is there, but the sheath could actually be in, free in LA. No septal puncture done. So we're going to put it here. Yeah. Now the wire is already in. I'm going to close this, and we'll ask them to come to the, AP, and then maybe slightly RAO. No bleeding anywhere. I'm going to get it to AP. And then I'm going to pull this pigtail down and push it in. So once the pigtail is down and you push it in, we want it to, yeah. Now, can you check where it is? We are already in? Yeah, are we in? AP? Yeah, this is not easy. The manipulation with this catheter is AP? AP, no? Yeah. So it shows the struggle when, when you are not in the right position. It's not easy to enter, but then suddenly the catheter goes into appendage And
Yeah. Are we in appendage now?
Yeah.
Yeah, we are in appendage. So
Yeah.
I pulled it back and the whole catheter went to appendage. Okay. So now the pigtail is in appendage, which is very safe. I have a feeling with pigtail and a wire, I'll be able to take this catheter into. So I'm going to take the catheter in. Okay. So yeah, don't allow it to fall. Very good. Now both my catheter and pigtail are in the appendage. So as discussed, we are going to keep I want to take a small shot in ariocaudal. Can you prepare the device? At 20, we decided to take a. Ready? I'm going to take a cine. Yeah, this is where we are. This is the appendage. This is the area to close. There are multiple lobes beyond. So this is how the appendage is. Now the alignment looks okay. And there are two lobes. Those don't matter if you are using a device like lamprey or amulet. You're only interested in the neck. So anything beyond that actually doesn't matter. It's more to anchor and more to position. But in echo, you can see it better. Probably it doesn't matter when we do this. I'm going to take the pigtail slightly more in and maybe torque it a little more anti-clockwise and holding the pigtail and this. Yeah, I'm on a deeper lobe now and holding this anti-clockwise. Later, I will take the sheath also in anti-clockwise. I'm going to keep it there. So it is so this is the maneuver which we are talking about. Make the pigtail look up, maybe keep the stiff wire, use the anti-clockwise and the sheath in. That will be the perfect alignment. However you enter, this will be the alignment. So initially you see that it's just somewhere. It's just floating around, but just before the device, this is the position to be in. Little more deeper in is better because then you have to only unsheath the sheath. But you don't want to be very, very close to you can't push it with the device. Pigtail is safe. Pigtail is atraumatic. That's why it's always pigtail which leads. Sheath or a dilator will be dangerous. Anti-clockwise keep, I'm not pushing. 22, as we discussed, 22, 26 device. 20. Okay, just somebody wanted to know about measurement. So here we would measure this area, this one. This is 135. So just for understanding, this will be the measurement. I think it was 15 or 16. Upsize by 4 to 5, you read the next size, which is 22. This we are decided to do lamprey. Yeah, 22, 28 device. We'll load it and we'll take. The device is here because the size was 16, 17. We are already in. So the challenges in these cases are entering the appendage with a little abnormal puncture. So if you look at this ASD, it's a superiorly placed ASD. Please load it. Superiorly placed ASD and the traditional puncture is supposed to be infero-posterior. This, if at all, is superior-anterior. So it's almost exactly where you don't want to puncture and you don't want to do. But I think since our pigtail is in, our sheath is in, we should still be able to do the procedure. One more challenge when you produce with this is, yeah, load it. Yeah, one more challenge which you face in these cases is actually, orientation later. You can start deploying the device, but you may not deploy it in the way we need it. Okay? May
Ranjan,
not deploy in the way we need.
when you do a device, you wear a mask or not?
I plus minus, not all the time. Yeah, I don't
I
think that
think
there are
it's
randomized
mandatory to
trials.
wear a mask at least when doing a device. For stenting angioplasty without wearing
But-
gloves, you can do it. Or I think it's a protocol that we're not doing a device, ASD, VSD, and any
No,
device.
but
It's a,
probably there are no randomized trial to
no randomized.
prove that fact. Yeah.
Exactly. I was going to say there is no randomized trials. You're fine there, Ranjan.
CCU people were so careful about wearing the leg mask. Finally, it is out. No, nobody. The fumigation is out now.
Just one comment. No, you have done beautifully because of your experience. You have done that. The other way is obviously you put the jalebi wire through the ASD cross, put the jalebi wire, take the Agilis towards the mitral.
Yes.
Because the T image shows if you come up from the mitral, it's much more easier access rather than coming down from the left upper
valvular
mitral.
vein.
So jalebi wire, Agilis, and then slowly extend, falls.
Yes,
position.
I've done that too
Yeah.
for some cases, but here luckily once we were out, The sheath actually went.
Any comment from Praveen is waiting for a long time.
Yeah.
Yeah.
Another thing is, can we
Mike.
your cannulate the appendage? At that time, can we with the same sheath, can we use an amplats with a Teflon wire and slightly go into amplats with a Teflon wire, just an amplats one, so that you can rotate it with a Teflon, not much of pushing. Just try to guide into appendage with that and push
with
the sheath in.
with the appendage. Yes, I think I'm very sure there are many ways we can do it. And generally, it's not very difficult to enter appendage, but some cases, yes. So you may have to use a MPA, just keep it here, enter. There are some cases where you have to operate in appendage itself, giving a small curve, which Dr. Horst was deciding. If you're keeping a pigtail, if you're keeping only the wire also should look like pigtail. That means you need to give a curve to wire, make it look like pigtail, and keep it in the appendage. It's okay to do it. But first
Dr.
10
Ranjan,
cases be in.
Yes, one more comment, sir.
No, it's just a comment. When you were just saying about the randomized trial, actually there is a study from UK which did with and without mask and cap. They found no incidence of increased stent infections. It is only stents, not no coronary work.
I'm not saying.
I know. I'm agreeing with you. So that's coronary stents. There is no difference.
That's what I said. Stent without like microseal, you can go without gloves. Who cares?
No,
But you should not charge it. This is in light revenue. Don't take it otherwise. There are 5 French pigtail is a different pig from 6 French pigtail, or 7 French pig is different from 5 French pigtail.
Yes. And angulated pigtail.
Yeah.
Angulated
pigtail would have been much easier
the
than you are taking 6 French normal pigtail or 7 French pigtail. Angulated pigtail have a different curve, different tail of the pigtail.
Yes.
That's what you wanted to.
So here this device.
Okay.
Yeah, the way to enter, yes. But if it is very difficult to enter, like we are telling, it's okay to operate in appendage in such cases. Because if it's so difficult to enter itself, be in the appendage, but be very delicate. From groin to septal puncture. Here there is no septal puncture. From groin to septal puncture. Any push-pull, remember that it will be transmitted there. Make sure groin is free. There are problems which come in multiple places. So you have to be aware. It's a teamwork. So our team, they know what we are doing all the time. So it may become difficult when you start a program. Yeah. No, it's not as important, but it's still important, but not as. But the way the final position we got here, even watchman would work for this. Ball formation of the device, no? That can be done, but that should be done only with amulet. It's correct. So if it is a ball, you enter the ostium and then give the anti-clockwise as much as possible. You're not going much in, you're going around 10 millimeter in. That's the landing zone. But most people believe landing zone is where it finally lands. But landing zone by definition is 10 millimeter inside the appendage. So that is where you start turning it. And what amulet does is, initially it is the gola, circle. As you start unsheathing, it becomes a triangle. Now that is the position where it lands. So keep further unsheathing from that point. So since that whatever ball is formed is soft, it can be used. Actually, even Watchman Flex does the same ball. So it may be okay to do it, but it's not recommended by IFU because the older watchman, you could never do that. So as you use different devices, you learn that one device can actually be implanted in the other device way, and you can succeed in difficult cases.
So even with the amulet, do you recommend what do you usually practice? Unsheathing it, or you form that ball and then push it?
Yeah. Final should always be unsheathing. But initial, if you want, you can have the ball and push it in position. But the final movement is anti-clockwise torque and unsheathing.
What's your usual practice?
For amulet?
Yeah.
Nowadays, when I started with amulet and we did, I think 35, 40 cases, I used to go to pulmonary vein, make a ball, get the whole thing done, no pigtail, go in, unsheath. But nowadays, after I have used other two, I want it to be done in the same way. So I would now like to take everything with the pigtail, go inside, mark the zone where I want to start, then take the device in. I feel that's the safer way to do it.
All the devices philosophy is just walk in. Only watchman is walk out. That means you go distally, then you walk out. Watchman Flex Pro, Amulet, your ACPs, even your Lambre can form a ball. The best, safest is your Amulet and ACP and Watchman
No.
Flex or Flex
So
Pro.
given
You
that
can
we
walk
adapt
in.
this
Yeah.
strategy of unsheathing and use a uniform sort of deployment strategy, what would be your, can you like in your case show what would be an ideal sheath
Where would be
position?
the point of this one, right? Yeah,
yeah,
I got your question. So this would be the point. The where you see this is where I would should start. This is circumflex. I would be at level. This is the ostium, so-called anatomical ostium. This is called echocardiographer's ostium, 10 millimeter inside. I would start deploying here if it is a neck-based device. At this point, lot of anti-clockwise and start deploying, unsheathing here. The only difference, there is a difference. If there is a distal thrombus and you have anticoagulated it, you just can't anticoagulate. In such a case, you would start here and ideally it should be lambre. Like an umbrella you open here, then you go in and deploy. Any distal thrombus, watchman is out because you start very distally. Amulet is plus minus. Lambre is the only one which you could use, not as a preferred option, only when you are forced to use it. Then you would start here and push it in and not try such abnormal ASD positions.
And without a thrombus within watchman, your sheath would be further deeper?
Yeah, it would be somewhere here, this point, and this is a good view. So if you look at this, you look at the pigtail, it's here. This is 135, and this is the superior most lobe. You can actually see the pigtail here in this position. I would like to take a sheath till here, but if it is the other device, I would be somewhere here.
If you have
But I think since our pigtail is in, our sheath is in, we
if
should
you have
still be able to
thrombus in the appendage at the tail end of the appendage, you should never try watchman.
Yeah.
You never try to put pigtail there and inject. So these fishball or any onion ball device you can make in the pulmonary vein, then you can push as he was mentioning. The alignment, as you were asking, all the devices ideally, both the lobe and the disc should look at 2 o'clock or 2:30 p.m. or 2:30 a.m. Anything which looks towards 3 p.m. or 12 o'clock is not the right orientation. If there is dissociation between one lobe looking at 1 o'clock, other lobe looking at 3 o'clock, distortion is not the ideal situation, but it can happen once the anchor is good and you have a lot of difficulty in implanting the device, please leave it there. See it on the echo that the os is sealed. That's it.
But thrombus avoid doing because it's a preventive procedure. You can't have stroke on table in a procedure which is supposed to prevent stroke. No, it's not like TAVI where so you have to be careful. One more challenge when you produce with this is yeah, load it. Yeah, one more challenge which so we need to load it. Load this device. What I'm going to do is show where we are. See, we are in the upper lobe, different from that position. Can you save this? Okay, get the device. And I'm inside, but I'm safely inside. This is one more thing. Just before you implant, make sure everything is fine. It will never be the way you leave it. Just make sure everything, remove the pigtail at the last point. No movement of sheath after that, in or out. Okay. I'm going to take this pigtail out, but not push the sheath now in or out. And we are going to remove this. And okay, we are going to this. Can you flush it? Flush, flush, flush. Can you open it and flush? Yeah. Okay.
Just a minute.
Done.
Sometimes it may happen.
So we are going
Even
in now. Yeah, enough. No.
Rajan, just a minute. Sometimes it may happen even if you use the new sheath, your device may not go in because of some spar or something in the sheath. So what do? You dilate that sheath again with your dilator once more to and fro. That makes the passage much easier. So do not blame it on the device, blame it on the sheath, that it can happen.
We're going to go very slow. I'm going to take this in. I'm going to see where we are. We are very, can you disconnect this and connect this one? Contrast, yes. Can we go in? So, yeah, I'm deep in, so I'm being little careful. Yeah, see, we are almost there. I don't know whether you can see that, but I can see it. It's almost now at the tip. We have connected contrast just to be sure we are okay, but I generally don't prefer injecting at this stage. Keep it down and lock it, please. And I'm going to unsheath at this point, not push it, and concentrate on the echo. So the distal disc is partly come now. We are more inside, and I'm going to unsheath it further, and I'm going to unsheath with the anti-clockwise torque, and we're going to put it here. So if you look at this, the position looks good, and distal device looks slightly, compressed. So little tug is actually better because these are like pacifier. Child doesn't remove the pacifier. It keeps holds. So little stretch is not bad here. And almost all LADs will have a hook. There are whichever device did not have hook actually embolized, and most of them got withdrawn. So most of these will have a hook which anchor it well. And here you can see some stretch. It's a smallish appendage. We started a little more distal. So this was a lamprey which was almost implanted like a watchman. You started distally or come, but the pull and the position looks good finally. Yeah. It's there, but the proximal part and the width looks very good. So if you look at the appendage in echo, it's, exactly the whole appendage is now occluded. We started a little more distal than what we want, but that doesn't matter. So I'm going to do a little tug to see that the position is okay, and then give a push to see that we are in position. Yeah, I'm happy with this position. Now we'll wait till, what Dr. Kavya feels there. I think the position is good. So you see that it's actually, appendage is now almost completely excluded. So you feel when it endothelializes, there is no appendage here. And
About the sheath size,
compressed
about the sheath size, you have always a tendency to reduce the lower size in the arterial size, but do not compromise. I mean, you have a liberty to take higher size of sheath on the venous side. If you take a smaller size, you may get some advantage in the femoral vein, but there is a high chance of air embolism. So better to use higher size of sheath, like 14 French sheath, even if you are using a smaller device. Number one, and number two, never ever aspirate. If you aspirate, there a lot of air will go in and you have a difficulty. And number three, this device is very difficult to snare if it is embolized. So before the ultimate end, when you are ejecting the device from the sheath, please try to pull it back so that till the last moment everything is screwed nicely, because it has happened. The people who are starting their cases for the first time, they are pushing the device, actually they are rotating on the other side, it is unscrewed completely. And what is unscrewed, you have to take out the whole thing or you have to snare it out. Nothing is very difficult to screw it again. So these are the few steps.
Yeah. But lamprey comes with 10 French, so it's a 10 French system completely. But this is a good point. When we say unsheath, that's why I'm using that word so many times. People end up unscrewing, without knowing in the beginning. That's why I'm using the word unsheath. It's only unsheath, means you're not unscrewing. It's important to keep that in mind. Yeah.
When you give the tug test in this one, initially the disc landed on over the comedian ridge. Then when you push it with inside, does it make a difference where it lands?
No, initially also it was in. Only when I gave a tug, only the disc moved.
So given that the device-related thrombosis is more with Watchman because do you think it's a good idea to leave it right at the edge of the comedian ridge?
No, it's not a good idea, because then there is always it's not sealed perfectly. Again, in appendage, you want to close all the trabeculated part. Smooth part can be left because that's how Watchman works anyway, and the data is with Watchman. So just to cover the comedian ridge, it's not good, and most electrophysiologists will just not like it when you do that. Yeah. As discussed, we will not be closing ASD for now, and maybe at the later point we might. Okay. So the distal part sometimes looks funny, but it really doesn't mean anything in this. So I'm going to release it now, and we are going to have a, but does not allow maximum motion. But since the, and we are going to compress this site for maybe 5 minutes just to be. Any questions or
Any comment? Comment
Yeah.
from Anil? Yeah.
One point, nice case, I think it's very educative. Regarding venous access, we are taking 10, 14, whatsoever. We possibly don't pay much attention to the venous side, keeping its vein, it will be very accommodative. But a couple of cases, some difficulty. So we started on principle all the accesses after having a 5 French to have an angiogram of the vein in the cases where we are supposed to take a larger sheath. And after routinely doing, we are seeing the narrow diameter, some spasm and abnormal anatomy. So large sheath taking, we are more cautious and doing under fluoro. So possibly it may be a good idea in cases where we are requiring higher sheath to have an angiogram of the vein.
Angiogram. But we have not been doing, but we are closing figure of 8. So all mitra clip also, sometimes venous perclose is used.
No, it's not closer. I'm talking about
anatomy.
Taking the sheath, it may injure and it has happened. So just as an add-on point.
One more trick, like you can do the angiogram fine. Once you puncture the femoral vein, if you are introducing large bore device like a mitra clip, TMVR, LA closer 14 French, etc., there's always a chance you can go through and through anterior posterior artery and vein. So once you puncture, put the wire inside, small like 5 French or 6 French sheath inside, and take the sheath out. Keep the wire there as it is, sheath out. Once you take the sheath out, if you see a lot of spots, you have to redo the puncture, because most probably you have punctured, gone through and through. If it is only venous ooze, whatever size you take, doesn't matter. You give the manual compressions.
But I think we should.
That's the point I am trying to make it, sir.
Yes.
That only vein smooth puncture, but venous anatomy may be little different in a given case when we are taking larger sheath.
If you have gone through and through,
no, not through and through.
Angio will not delineate whether you have gone through and through because you are injecting into the vein.
I agree. I am talking about that large sheath taking may injure.
Yeah.
Keeping in mind there may be some.
Yeah. What we do, Dr. Anil, nowadays we have shifted to ultrasound guided puncture for all our cases. Whenever it is groin, artery or vein, the puncture is ultrasound guided. And we are fortunate because the IR and vascular people are around. But I feel we should shift to ultrasound guided because
one case I have to do femoral vein, iliac vein angioplasty to advanced large bore device. It can happen. Stricture. Yes. Somebody has done temporary pacemaker through the femoral vein, but some viral myocarditis in the past. Now femoral, this iliac vein is stenosed. Yes. So you have to pre-dilate or use a body weight to put the large bore device in myocarditis. It can happen.
Point well taken. Axis is something we have to be careful in all cases. Yeah. Thank you. So I think we'll continue with the next. Yeah.
Demonstration, sir. I think we'll go with Dr. Purohit is presenting about LA by a Lambre device.
Yeah. Pointer. Good evening, everybody, and I am really thankful Dr. Ranjan Sethi. He started this LA appendage occluder symposium, or you can say a conference, because that was something which was long due for all those people who have been doing LA appendage occluder, and that is one intervention for which there was no conference in India. So I really thank Professor Ranjan Sethi for initiating this. So because it's a Lambre session, and before we go deep into the device, the most important thing is to understand the device. So I'll be telling about what exactly is Lambre device, and it is claimed that it is it has got a superior seal, and whatever data they have, it shows that the peri-device leak is the least with this device. So we all know about all this thing. The risk of stroke with atrial fibrillation, it is almost more than 5 times, and majority of the stroke in non-valvular AF is mainly because of the thrombus in the appendage, and that's why this therapy has come into the picture. And this is a beautiful slide which says that as you try to increase the number of antiplatelet and anticoagulants, the risk increases. So that's why this alternate therapy came into the picture, and that is why we started using more and more of this device when we feel that the risk of bleeding is very high in a particular patient who has got a non-valvular AF and he may not be a candidate for an anticoagulant, or he is a contraindication for anticoagulant. And that is where exactly right now the entire indication for LAAC it resides. So if somebody has a contraindication, it's now a class 2A indication. And if it is a very high risk for oral anticoagulant, then it's still a class 2B indication. So these are the various devices. We are all familiar. In India, we have Watchman, and now we have Watchman FLX also, and the Amulet, and the new kit, that is the Lambre device. So, and these are some of the new devices which are coming up for future, which are going to make the process, the procedure much more simpler, which is the conformal, which is a foam-based device. Then you have this cardiocorex, which is a polymer which absorbs, and then you have this Append Medical, which is coming up with this device, which is going to, it's more of a exclusion device where it rotates and it makes sure that there is no appendage left at all. But these are for future, and we are right now going to focus more on the device which we have, that is the Lambre device. And as Professor has already, Ranjan Sethi has already shown some of his cases, so we are all aware that this is a device which has got an umbrella, which is made of a nitinol material, and the covering membrane is of PET, and then you have a cover. And for Amulet, we use the word lobe and disc. Here we use the word umbrella and cover, and because it looks more like an umbrella. And the cover is basically made of, again, it's a nitinol material, and it has got a non-thrombogenic, very compatible to the human body. The TIN, that is the titanium nitride, is coated. So that makes the endothelialization pretty fast, so that the device-related thrombosis in future it is minimized. And then it has got a connective sleeve, which is again made of a nitinol, and the connective sleeve here is so flexible that even if there is a misalignment between the umbrella and the cover, it can still give you a good seal when you have deployed this device. And the most important thing is the Lambre device comes in 2 different types of sizes. One where the difference between the disc, the umbrella and the cover is less. That means from 16 to up to 26 or 28, you have this different sizes of 6 millimeter is the difference between the umbrella and the cover. And whereas there is another type of devices where the cover size is much more bigger, like there is an anatomy where you have got 2 lobes and the LA appendage is immediately just like a bifurcation, so you cannot deploy the umbrella into any particular lobe. So you need a very big cover, and you can put the device in any one of the lobe which is there in the LA appendage, which I can show you with the diagram in the next. So this really gives a major advantage where there is a difference between the orifice and the lobe or the landing zone where you are going to land the device. And another important thing is the device is customizable. Suppose you have a particular LA appendage which you feel cannot be tackled by these conventional devices, then you can make a CT and give it to the LifeTech people. They will customize the device for that particular LA appendage and then send it back to you. Of course, it may take some time, but that is also an option which can be used if you are planning to use this kind of a device for LA appendage occlusion. So this is the delivery sheath, and you have the sheath, the dilator, and the cable, and the sheath has a hemostatic valve, and then you also have a loader. So this is the standard packaging which the lamprey will come with. So you can unleash. So this is how the closure system looks. And as just now you saw that case where he used a delivery sheath which had a single curve which was around 45 degree, and you have a double curve which majority of time we use, that is the 90% of time we use it, which has got a primary curve of 45 degree, and then it has a terminal curve of 30 degree. So this double curve actually helps in aligning the device with the LA appendage axis. So that is the beauty of this having a double curve. So you go inside the appendage. When you give a little anti-clockwise, it starts looking up. When you give a little clockwise, it will start looking down. So that way you can manipulate your device inside the appendage and make sure that it is aligned properly. So you have 3 different sizes. That is, it comes in 8, 9 and French. So overall you have 6 different types of sheath. But practically I have used only 10 French sheath in almost all of my cases. Even if it is a smaller device, still I use a 10 French. Even if it's a biggest device, still I am using the 10 French. So I use only one sheath, that is the 10 French sheath. And as Dr. Hazra mentioned, it doesn't, you should not be bothered that you are using a bigger sheath, because if you have a bigger sheath, the chances of air embolization will be less, because the device is going to go in a bigger sheath. So the air locking will not be happening. So you can easily, the moment you open up, the blood will come back. So this is what I was telling you. If you have this double lobe here, I think you can see here the double lobe, or then you can put the umbrella in one of the lobe, and if you have a differential cover, you can use a bigger cover which can cover this huge mouth, and thereby you can still cover it instead of using 2 devices. And if you have a single lobe, you can always use the conventional lamprey device. And almost all types of anatomy you can close with this kind of a LA appendage closure device. So we all know about this, the different types of LA appendages: chicken wing, wind shock, cauliflower, cactus. So almost all can be taken care of. So this is a schematic diagram of what I showed you earlier. So if you have multiple lobe, the umbrella goes into one of the lobe, and then the cover is going to cover the mouth here. So this is what I was trying to tell you. So the another important thing which makes this little different from the conventional amulet is the stabilizing anchoring mechanism. It has got 8 small hooks, and these individual hooks, they are little bit U-shaped at the end. So thereby what happens is, the moment you open it, they take a U-shaped and they go into the trabeculation. So that makes them little bit safer in terms of causing pericardial effusion or a tamponade in this set of patient. And you can see what happens in this diagram here. So they anchor it, and then they take a U shape, they go through the trabeculae and then take a U shape, so that it is anchored here and it doesn't cause any perforation, because there is nothing looking outward here. So that really is a safety mechanism which is there in this, and you can prevent a tamponade when you are using this device, when you are unsheathing, when you are retrieving and you are trying to reposition, so the chances of trauma is reduced. So another important variation which is advantageous in this is, it is a fully retrievable and repositionable device without causing much injury to the left atrial appendage. Unlike the other devices, which I think I was talking to other colleagues in Hall B, that if you are using an amulet device, you are supposed to not withdraw the whole device back, because the anchors are looking down. The moment you try to take it, the anchors will become straight, and that may cause more injury, and that will cause less stabilization of the device. Whereas the special mechanism of this, by which it comes down and takes a U, it makes it less traumatic. So even if you are retrieving it and you are trying to deploy it again, the chances of causing major trauma to the LA appendage wall and causing tamponade is reduced, because of this unique design which this device has. So this is what I was telling you. You can see this is how it takes a shape when you are trying to make in amulet you make a ball, here you make a little bit of like an umbrella kind of a thing, you can make it, and with this you go. So when you are going in, the devices are actually, the anchors are looking little bit inside, so you are not causing any trauma there. So this is what I was telling you. So this special mechanism of retrieving and repositioning makes it less traumatic to the LA appendage wall. So this is how it is. So this is the whole thing in the, this is the moment you open it, this is how they look. Then they go into the wall, and then they take a U shape and come inside and anchor there. So this is what I was telling. They come in 3 sizes: 8 French, 9 French, and 10 French, and you can see that it has got the least profile, whereas the other, they use 12 French and 14 French. And this specialized coating, which is the titanium nitride coating, it leads to a faster endothelialization, and this leads to reduction in delayed thrombus formation in this particular device. So this is a comparison, but to be practical and to be honest, there is no randomized data to say that whatever has been claimed here is going to make any difference in the patient's actual outcome. You can close any appendage almost more than 95 to 98% of time with any device you can take. But if you are faced with any specific challenge in an anatomy, then I think this device really comes handy there. And as you are a beginner, because of this unique design where it causes less trauma, and it is a go in kind of a thing where you are not deep inside the appendage and trying to open a device and bring it out, where there is a chance of, if you are not careful, you can cause perforation. This is a much safer device to start with and to begin with, so that you become more confident in entering the LA, entering the appendage, and then deploying the device. So that gives you more confidence. So the learning curve is, in my opinion, is little bit less here compared to other devices which you are used to. So these are all the features which I have already told you. So once you have deployed the device, generally they recommend you have to follow this principle of cost. That is, the device should be beyond the circumflex. This is the circumflex, and then the umbrella is fully open, and then you have to see the ceiling, and then you have to do a tuck test to check whether the device is getting dislodged or not. And if you are satisfied, you deploy the device. So in conclusion, the unique tin coating makes the device less thrombogenic, and the unique sizes which comes with this, it adapts to various LA anatomies, making it gives it a perfect seal in all the challenging anatomies. The anchoring device, the unique device, it makes the device pretty stable, so the chances of embolization are very minimized, and the fully retrievable and repositionable with minimum trauma to the appendage, it makes it much more user friendly. Even for a beginner, they will be able to use the device much better. And the smaller delivery sheath, it causes less injury to the vessel, thereby making the patient experience much better compared to what with a bigger device it is. So with this I conclude. Thank you very much.
Any comment from?
Sir, how many times can we
Switch on the mic.
How
How many times you recapture?
retrieve?
See, as per the IFU, you are supposed to retrieve up to 3 to 4 times, not more than that. But when we go for proctorship, we have seen people trying to position it, they're not able to position. When the puncture is little bit abnormal, we have used 4 to 5 times. The operator has retrieved 3 to 4 times. Then again we have gone inside and we have done it once or twice. So up to 5-6 times also you can do the 100% retrieval and repositioning. That should not cause any problem.
Right. So it is much more forgiving as far as embolization recapturing is concerned than the other device. But if you are struggling with the device, please reassess the whole anatomy again. And once you have done it properly, still it is embolized, then you have to have a backup mechanism in the hospital. So first thing to have in the LA is the jalebi wire. You know, there's Inouye balloon during mitral valve. We use that round and wear. So once you have detected that it has embolized immediately, if you push that jalebi wire inside, it will be working as a fishnet. At least it will not migrate in the LV or aorta. If it migrates in the LV, it's very difficult to retrieve. If it's still there in the LA, you have many mechanisms to take it out. You have a snare. You can take some time to prepare your snare, and what size of snare, 30 or 35, which end to end to catch, whether it is the disc end, whether it is umbrella end or the pin end, but whatever you get to catch, just pull it and use try to take it out in the RA. Sometimes you have to upgrade the sheath size to catch the bigger device, because it is easier to deliver to the smaller device, but it's very difficult to catch it back with the bigger device with a 14 French sheath. If you use a micro sheath, sheath, and if you bevel it, like in ASD, Anil will agree with me that if you bevel it, then it can go inside your guiding sheath nicely. But better is prevention of embolization is the best treatment of embolization. So nice talk. Any other question from the floor? Because time is
One reason why I have seen that most of the people go for retrieval is the device is not aligned. And the major reason which I have seen is when we go inside, it is generally recommended that you give a anti-clockwise so that the device looks little upward. So what I have seen is most of the time, by the time the sheath has looked upward and you try to push this cable, you have forgotten to keep that anti-clockwise and it has automatically taken its shape back. So that is where when you have gone inside, you find that the axis has changed here. So when you are doing it, if you are not very sure, if you are single operator, ask your associate to hold the device when you have already made an anti-clockwise so that the anti-clockwise is maintained there rather than leaving it and then trying to do something else. So that is the major reason why the device goes off axis or it gets displaced from the place where it is, and that's where you have to do repositioning. So that is the most common reason. Otherwise, another common reason is if the puncture is not proper. If the puncture is not proper, then you can do these manipulations and go inside, and then you can reposition the device inside.
Right.
And I think that's the
one more comment from the chair.
One question actually. I just want to ask Dr. Purohit. So multiple retrievals result in possibility of dislodging the device or the anchors coming out, opening up and damaging the appendage. What are the reasons which you explain?
See, the major reason why they say the multiple retrievable is the anchors which are there. The anchors actually get distorted. So the device stabilization leads to a problem. So you may have a delayed embolization also in these kind of, because continuously there will be a contraction and relaxation which can lead to pushing of the device out. So that is a possibility, but I have not seen it, but I think that may be a major reason for it.
Right. So Kabia, are you ready? Thank you, Purohit. I think while you are taking a lot of time in recapturing, please check the ACT so that you're nicely heparinized, because by the time your ACT goes down, you're killing time, patient gets thrombosis. And Kabia will pre and post imaging for Lambre device. Over to you, Kabia.
Hello, everyone. I will be very brief, maybe maximum 5 minutes. I know all of you are tired, so I'll make it as brief as possible. There'll be some overlap with Dr. Bharat's talk, so I'll try to skip those slides because you've already seen them. So this is a brief overview of what I'm going to be presenting now. So the name lamprey is derived from the umbrella in the left atrial appendage. It's a self-expanding LAA occluder constructed from a nitinol mesh and polyester membranes. It consists of an umbrella and a cover connected by a short central waist, as we have already seen in the images. And the device is, it is a low profile device. It can be delivered via a 8 to 10 French sheath, and it has full recapture and repositioning capabilities, which are the biggest advantage of this lamprey device. So this is the design of the device, and this is how the device looks on the delivery cable loaded. And as sir already mentioned, the bigger ones are used when we have more than 2 lobes, so that the entire ostium of the left atrial appendage is covered. So that's when we use the one on the right hand side of the screen. So this is how the device is fixed whenever we close the appendage. I think I'm not going to discuss on all these aspects. So coming to the imaging, how do we measure the size? Again, it is basically 0 degree, 45 degree, 90 and 125. So the measurements are taken at the ostium and a centimeter away from the ostium, which is the landing zone. Basically, it is the differentiation between the smooth part of the appendage and the trabeculations where they start. So, and that is the neck which is shown. And the one difference in measurement of the lamprey or amuletus, we don't go to the apex as we do in Watchman. We go to the posterior wall of the appendage. And I would say, okay, I'll use my mouse itself. So I'm sorry, I'm unable to show that. It is usually from here, we take it posteriorly downwards till the it won't be towards the apex. That's an important thing to remember in sizing. Tomorrow again, simulation TE is on 9 to 11. Dr. Edwin will be taking, and all of you can please measure the LA appendages after getting the views. And this is on the next view. Here we can appreciate 2 lobes, and these are the ones which where the central cover, if it is a little bigger, then it is better for these closure of these appendages. And again, profiling in multiple views. This is at 90-degree view. We can see that the patient is in atrial fibrillation. And this is biplane imaging, where this is the one we use as a working view during device deployment. So this is basically how do we size as shown in this. And this is at 135 degree from the circumflex ostium to the pulmonary vein ridge, 1 centimeter inside. Here depth is not as important as Watchman. Anything more than 10 to 12 millimeter depth should be enough either for amulet or for lamprey. So even for lamprey, 10 mm depth will suffice to plan for a device closure. So this is guiding during the procedure, where we see the wire is positioned in the pulmonary vein. Most of our exchanges, we do it in the pulmonary vein and then take it into the appendage guided via TE. And this is how it is positioned in the appendage. And this is during positioning of the device. Dr. Ranjan sees and then decides whether he has to further go inside the appendage or probably plan a little away from the apex. So this is during positioning of the device, all these images. And this is once the device is deployed in the appendage. And so we see that the ostium is nicely covered with the cover of the device, and the umbrella should be within the circumflex artery as already enumerated by the previous speaker. We look at these criteria, that the umbrella should be beyond the circumflex artery and the umbrella has to be completely open. There should not be more than 3 millimeter peri-device leak, and stability is again checked by a tuck test. So all these criteria are fulfilled. We plan and release the device. And also one more thing we need to check is on color Doppler, there is no device leak, tug and pulmonary venous flow increase in mitral regurgitation. So all these factors have to be seen before the device is released. So to summarize in brief, lamprey, it is a very versatile device, I must say, because it is suitable for almost all types of LAA morphologies. Sizing is done with TE imaging at 0, 45, 90 and 135 degrees. Transseptal puncture is again posterior and inferior. Positioning of the device is under both echocardiography and fluoroscopy guidance, and cost criteria must be taken into account prior to release. Thank you very much.
Thank you, Kabya. Any question or queries, comment from the audience? My co-chairs? No? So it's already 8 o'clock. And next speaker, thank you, Kabya. Next speaker will be my friend Anand. Eyes-guided LA closure in a patient with thrombus. Over to you, Anand.
Right. It's there. Thank you. First, sincere thanks to Ranjan and Ramesh putting together this fantastic program and the first of its kind in India. And I don't want to take much time. I'll probably take about 7-8 minutes because I don't want to stand between you and dinner. It's already too late. The current contemporary practice in India is general anesthesia, transesophageal echo guided left atrial appendage closure. But the future is local anesthesia, mild sedation, intracardiac echo guided appendage closure. So that's the future. And the last sort of 5 or 6 cases, the series we have done with the same procedure. So these are the devices currently available in India. And that's what the ICE probe looks like. That's what's available in India, the AccuNav and the ViewFlex. The AccuNav is a very user-friendly. It's got an anterior and a posterior flexion, lateral and medial. But more than that, you can rotate clockwise, anti-clockwise, so you can get a complete sweep. Structurals, most of structural interventions can be done with the ICE guided, which is going to be the future, as I said. Views, you need to know at least only 4 or 5 important views. You take the ICE catheter, you park it in the RA. So it's called the mid-RA or home view. And you can see the tricuspid valve, interatrial septum, and then slight flexion extension, you can see the left sort of aorta, clockwise, anti-clockwise, all those movements. Low RA, you will beautifully see the aortic valve in short axis as well as long axis. This is a view I use for transcatheter valve. We used this during COVID time when we could not use general anesthesia. We used ICE-guided sort of TAVI procedure. So this gives beautiful image for the TAVI. And then my sort of tricuspid inflow view, it gives you fantastic pictures of sort of LV as well as RV and pericardial effusion, looking all those things you can see. If you go a little bit up to the pulmonary artery, you get again nice views of the RVOT, aorta, and the main pulmonary artery, and the right and the left as well. When you cross over to the left atrium, this is the view you need to know. If you want to do appendage closure properly, apart from the mid-RA view, the left atrium, you get your ICE catheter to the left atrium, you can park it in the mid-left atrium, that is called the home view in the left atrium, or you can park it above the left atrium, so appendage in the upper pulmonary vein, or below that around the mitral annulus. So these 3 positions are the important ones. So these are the ones. So the yellow one is the home view from the left atrium, the blue one is the upper pulmonary vein, the green one is the inferior sort of lower pulmonary vein, and then the pink one is the mitral. So most of the time it's only 2 you will be using, the home view from the left atrium and the upper pulmonary vein, and that will give you beautiful images for closing the appendage closures. So you start with your RA view for the septal puncture, you cross over, you park it either in the mid-LA or even the left upper pulmonary vein, you get beautiful images. You do with a single transeptal puncture. Do one transeptal puncture, cross over, dilate with the sheath, keep the wire in the left upper pulmonary vein, bring the sheath back through the same orifice, push the catheter. That's it. Then you take the sheath back in. You don't need 2 punctures. So that's the steps in it. Obviously, for the transeptal puncture, use the mid-RA view. Once it is done, you cross into the left atrium. You get beautiful images of the appendage. So this is a small video showing if you have thrombus, Alambre device is the best and is the only device that's advisable to use. The only difference is the modified technique. So you start outside the sort of ostium itself. You slowly open the umbrella and open it more and push it so the thrombus is trapped. Then you unsheath and bring it and deploy it. That's as simple as that. That's the whole talk. So when you have thrombus, when you're using this, this is the technique, modified technique to use it. And the thrombus is trapped and you come out, procedure is done. So this is the patient. I just want to go into more not more details. Hemiparesis, previous sort of malformation, bleeding, presented again with a stroke, again both infarct and bleeding, again an extension next day morning. You do a CT scan, the apex is filled with thrombus. So you cannot anticoagulate. At the same time, he is having recurrent thrombus, sort of within 24 hours. You have to close it. So discussed MDT, planned for ice-guided, local anesthesia, because there is already swallowing difficulty. You don't want to give GA and a transesophageal echo. So I'll skip this because I've already shown this. This is what it's going to be. Local anesthesia, same puncture, double puncture in the right femoral vein, one for the device, one for the eyes, and then single puncture in the interatrial septum for both. Then your first view, right atrium, second view in the mid LA, that's all. So that's how it is. Your eyes catheter is always following you. You got it in the mid RA, it's showing you where you need to puncture. Beautiful. This is what in the morning I was telling. This is called the trajectory. Your indentation is there, your appendage is there, orifice. You need to see this. Apart from where you are selecting to puncture, the trajectory becomes important. For all your structural interventions, whenever you are doing a transcatheter procedure, the trajectory becomes important. So if you have a straight trajectory towards the orifice of the appendage, you will have a beautiful procedure without any difficulty. So that shows the mobile clot, and that's a puncture exactly sort of infraposterior towards that appendage, and the moving clot is seen there as well. This is very important. Take your sheath with the pigtail, upper pulmonary vein, drop it near the ostium, retract your pigtail, then you can see it. It's not entering the ostium, it's just in the ostium of the appendage. Take your device, and once your device umbrella is forming, then you push it in. So you can see umbrella is formed, it's pushed in now, and that thrombus is trapped. Once the full umbrella is formed, then you retract the sheath and release the disc. And as Azras was repeatedly telling, it's around 2 or 2.5 o'clock, not more than that. It should be in that position. It's completely sort of sealed off. And you can do your test, the cast test in this. As you're pulling, you will see in that as well. It gives you a beautiful image. No leak, color flow is good, done. You can assess your ASD and come out. And you can come to the RB view and see it in that as well, aorta on the top, appendage, and pulmonary vein on the bottom. So I'll skip this for the purpose of time, all these things. So you can do these cases much, much safer. This is the future. The 3D ICE probe is not here in India yet. It will come in a few months' time. So that's the future. So left atrial appendage, the suitable alternative for the oral anticoagulation. T is at the moment standard, but ICE guided is possible, and obviously that is the safest procedure in terms of these high-risk patients. Thank you.
Does the 3D
anything 3D, the manipulation is less. Let it be 3D TE or 3D ICE. Because you park it in one view, you don't need to move the probe. By putting a multiplane, X-plane, you will get two different images immediately. So you get a 0 degree, 90 degree, 35, 145, or 90, 180. That's a major multiplan. So you don't need to move, you just park it in one place. Yeah. Thank you.
In the interest of time, I will not present any case because my case will be another usual case. And please excuse me. After attending this summit, how many of you are now convinced, confident, inspired, which you are not early in the morning? Please raise your hand. Oh, plenty of people. That's Hanjana, where are you? Where are the industry people? I mean, so ladies and gentlemen, to summarize then, nobody has learned anything by birth. Neither TAVR, not angioplasty, not LA closer, not CBG, not TMVR, not mitral clip. It's a continuous learning. Learn from your seniors. Try to share your cases with your seniors, juniors, and all the time it should be our ambitions and aim to pass on the knowledge you have gathered as a teacher, as a senior, to the juniors, juniors to the sub-juniors, to the society as large, benefits from the knowledge and science and progress of science innovations. And you have to always think ahead of the curve. Nothing is impossible here in India. Next step will be manufacturing was, as suggested by Dr. Anand, and many things. There are 3 companies which made us very proud in the international market. One is your SMT for stent, Merrill for your the valve, and Concept Medical for your drug-eluting balloon magic touch. I'm sure in the LA field there will be more and more investment in the country. It's very easy to do, very easy to learn, and for starting the initial case, you have to have some mentor. But once you do 4 or 5 cases, next cases you can do it on your own. And it's not it's not a rocket science to understand the philosophy of LA closer. And the last question to me, how many of you believe that LA closer device can prevent death? And if it is so, what is the data? What are the data? How many of you are convinced that LA closer device does prevent death? Is there any data? Please raise your hand. Hardly. Hardly are convinced, but the surgical arm has shown that it prevents death and all-cause mortality beyond any doubt. There is NCDR registry in US of almost 45,000 people tried all types of device in the registry. It prevents 69% of death and all-cause mortality. Not in this PROTECT trial, but in registry data, because there are better devices now, safer devices now, better technique of understanding how to do it, and prevent the complications like tamponade. Ladies and gentlemen, let's stop here. There are much more interesting things are waiting. See you tomorrow early in the morning, and Ranjan will give you the vote of thanks.
Yeah. Thank you, everyone. I think all of you had, I hope all of you had a wonderful time and you're tired of seeing all of us now. So I think, yeah, you'll close the session.
We now conclude the session and also all the talks for the day. I call upon Dr. Chandramani Adhikari sir to come up on the stage to give mementos to the speakers, moderators, chairperson and panelists.
Dr. Adhikaris come from Kathmandu. Yeah.
Dr. Bharat B. Purohit sir. Dr. Anantaraman sir. Dr. Praveen Srikumar sir. Dr. Biju Govind sir.
So thank you. It's been this is end of day 1. I request all of you to join for fellowship and dinner. Dinner will be served here. So we are also having probably 2 alumni meets on top. PGI one will be in conference hall 1, which is in first floor, and the KMC one is in hall B. Please join, and we'll all meet up with dinner and gala. Thank you.
am the one who knows. I am the danger.